Good morning, everyone. We'll be beginning with the Hematology conference in another 5 minutes. Good morning, esteemed delegates, distinguished guests. It is my great honor and privilege to welcome you all to the RAKTAVIGYAN 7 2025, a gathering of some of the brightest minds and the most passionate hearts in the field of hematology. Today marks not just another conference, but a crucial moment of collaboration, innovation, and shared purpose. For further introduction, I would like to call upon Dr. Avinash Singh, sir, a renowned hemato-oncologist, Paras HMRI Patna. Sir, can we please have you on the dais?
Good morning, everyone, and thank you, Dr. Pritika, for introduction. So, I welcome all of you, all faculty from outside state, all delegates and local faculty for RAKTAVIGYAN 7 organized by Hematology Foundation of Bihar. And it seems that time has passed so fast. Just 1 year back we were there in the same hotel, in the same hall we had RAKTAVIGYAN 6, and today we are gathered for RAKTAVIGYAN 7. So, how we started? So, if I just look at past, it seems that things have happened spontaneously. So, I joined Patna in January 2014, and in 2016 there was one Patna hematology update in Paras hospital, and in that hospital all the oncologists, they had one responsibility, that you can organize one conference. So one conference was organized by medical oncology group, then radiation oncology, surgical oncology, then my turn came, and people were of opinion that कितना लोग आएगा, 30-40 लोग आएगा, ठीक है. तो बाकी के कॉन्फ्रेंसेज में, बाकी की जो मीटिंग हुई, around 15-20 people were there. But I thought, how can a hematology conference or meeting will be organized and only 15-20 people will come? So in that 2 years, I used to attend CME's conferences in Kolkata, because of Eastern region, in Odisha, in Northeast Guwahati. I did my MD from Guwahati, so any hematologist, any CME activity, I used to go there. So I invited around 10-15 hematologists from Eastern region and 1 or 2 from Delhi, my teachers. And that was one day event starting from 9 AM till 4 PM. It was in Paras Hospital auditorium. So that auditorium has around 60-70 sitting capacity. I was also not expecting much crowd. I was anxious what will happen, how things will go. And I chose around 10 topics, all were very basics, like today, ABC of CBC, approach to thrombocytopenia, bone marrow transplant basics. And we shared, so we shared on social media. Social media means WhatsApp group of doctors. Then we distributed this one agenda that you have. And it was so huge crowd that one hall was filled. Then we had to arrange in the parallel hall. We have to keep TVs there. Around 150-200 people were there. Topics were basic, but attendees were ENT surgeon from IGIMS, HOD. So for whole state, it was first time a hematology conference was organized. They just came to see that what is being discussed in hematology conference or meeting. And everything finished. Lunch was not there. So my teachers, Dr. Om Kumar and other teachers, they were standing in the queue to get some plates. So I just left the place कि भाई teachers हमारे खड़े हैं और उनको खाना नहीं मिल रहा है. और वो सर्व करने वाला जो है आवाज़ करता था बर्तन ढन ढन कि भाई ख़त्म हो रहा है अब मैंने. We had to start the meeting. बहुत सारे लोग even they sat without taking lunch. So that was huge success. And after that we thought that we have people who have interest in hematology, so we should start something. And after that, we organized one myeloma meeting, specific to myeloma, half-day meeting. Dr. Maman and many more from Eastern region, they came. That was also a success in Panas Hotel. And after that, we started one society as Hematology Foundation of Bihar. And first time in 2017, as a society, RAKTAVIGYAN 1 was organized in 2017. So that was as expected, very hugely appreciated by students from Department of Pathology, Pediatrics, Medicine. And I remember medicine postgraduates from different other medical colleges, they used to come to me, sir, I want to present oral paper, give me case. So I used to give them case, they will prepare and they will present. So many presenters, they are now consultant cardiologist, gastroenterologist, but they had interest in hematology. So in 2018, 19, then in 2021 there was COVID, so we didn't organize anything. Then in 22, 23, 24, and gradually uh, we widened the outreach. That is, the faculty not only from Eastern region, they started coming from different parts of our country, Delhi, Mumbai, and others, and they were all very supportive. They are very busy consultants there, wherever they are practicing, but they all agreed. They used to come even in spite of their busy schedules. And we, as a part of Indian Society of Hematology and Blood Transfusion, we started having hematology quiz in different medical colleges. So I got responsibility for initial 4-5 years. So we used to visit Darbhanga Medical College, Patna Medical College, used to do hematology quiz where PGs from medicine, pediatrics and pathology, they will participate. I remember the first hematology quiz in Darbhanga Medical College where one MD pediatrics student, she participated. She won the college level and then she came for a state level quiz. And today she is consultant clinical hematology in Coimbatore. So this time I thought that this will be a great learning for all students who have interest in hematology. She is Dr. Yoga Lakshmi. She will come as faculty. She will speak on primary immunodeficiency disorder. She is Yoga Lakshmi. And these are all pictures of 2025 college level hematology quiz which were organized at AIMS, Patna, madam is there, then IGIMS, PMCH, NMCH, DMCH, and all winners of that institute level, they will come to participate in a state level hematology quiz. There were workshop last day, and that was in AIMS, that was on coagulation and mixing studies. So thanks to Dr. Poonam madam for all help, and their team, Dr. Avinash, Dr. Ruchi and all other residents, Dr. Pritika must have been there. Then there was one workshop on utility of HPLC at IGMS. It was led by Dr. Satish, Dr. Kausal and Dr. Suchismita and all other team members. Then at Paras we had SDP and stem cell apheresis workshop. So that was also attended by around 15 to 20 participants. So this time we thought that okay, it has become monotonous just doing scientific activity for doctors. So we thought that we should spread hematology to each and every doctors of our state. So this time we thought that okay, we will have some poster competition on hematology topic for MBBS students, for nurses, for lab technician, even for GDA who work with hematology patients. So we sent them mail, we have flyer, we sent to all medical colleges, but this time we could not reach to each and every one, so we had less number of posters, but these are the posters made by these MBBS students and nurses and lab technicians. Some of the nurses, they are themselves patients of non-transfusion dependent thalassemia, so they had made some good posters. Now coming to this RAKTAVIGYAN 7, so I think 200 registration, more than 200 registrations has been done. So you will see the crowd over time when the day peaks. And medicine we have around 80 registration, both faculty and delegates, and in pathology maximum number of participants around 180, pediatrics around 40, and other disciplines they are less. But we have like anatomy, transfusion medicine, oncologist, hematologist, we have very few, and the main purpose of organizing this type of meeting is to encourage our young participants to take hematology as a specialty, and they should work hard because patients are there, nephro and other disciplines are there. So this is about RAKTAVIGYAN 7. Theme is hematology for all, so we have tried to keep the topics very basics so that audience can benefit. And this is the agenda. So we will have around 4-5 talks in this hall, common, and then after that we will spread to hall A and hall B. So hall A will have pure hematopathology topics, lab topics, and hall B will have clinical topics. So all medicine, pediatrics, clinical oncologists, they can go to hall B, and here then we will again meet in hall A for inauguration, and after that we can we can spread, so that will be announced. Then I had just one request that we have around 300 registrations, including all faculty, delegates, and most of the delegates, they are young, around 25, 30 years, and we have huge shortage of blood. So I would request all of you to donate blood every 3 months. Not only doctors, this one PGA students, even the hotel people, medical representatives, pharma people who are there, who feel that they are healthy, they should donate blood every 3 months. There is huge shortage of blood, and our patients like thalassemia, they depend on blood transfusion for their survival. We do treat acute leukemia, we do transplant where blood is required. So it's a noble initiative, a noble that you can start from today, that every 3 months we will donate blood. You can post it on social media so that others also can be encouraged to do so. And I will request all of you to become a member of Indian Society of Hematology and Transfusion Medicine, because you will get more updates and you can participate in national conferences which are being organized by them. In Eastern Hematology Group, Hematology Foundation of Bihar is there, and the next Hematocon is in Lucknow. This was last year's slide, so Nagpur is written, but next year, this year it is in Lucknow. You can become a member. If you have any queries, any problem, issues, you want to share your feedback, you can write to us on raktavigyan@gmail.com. And thanks and best wishes. And before I hand over to Dr. Pritika and team, I would like to thank all the core members who are hematologists from this city, and other super specialty oncologists. Dr. Dinesh Sinha is there, Dr. Sanjeet is there, and many more, for their all help and giving me full freedom to work whatever I want. So thanks to all of them, and with best wishes, I would like to start the meeting. Thank you. Thank you.
Thank you, sir, for the wonderful introduction. You've been inspiring us for the last 3 years. Let's gear up and be energized for the first session for today. The topic is ABC of CBC, and I'm more than honored to introduce the two chairpersons. First and foremost, Dr. Poonam Prasad Badani, ma'am, Professor and HOD AIMS Patna. Ma'am has been a mentor and guardian and has been inspiring us over the days. Ma'am, can we please have you on the dais? The second chairperson, Dr. Sanjeet Kumar Singh, sir, Professor HOD AIMS Devgar. Sir, please.
Should we start?
Yes, ma'am. You can introduce.
So good morning. First of all, I just want to thank Dr. Avinash for inviting me. I cannot spend more than 1 hour, Dr. Avinash, sorry to say. So some busy schedule in the department today. So I think the name of Avinash, something is there, because in our department also, an AP, he is Avinash, and he is very active, and he can perform multiple tasks at a time. So that's what I just saw in the Avinash, Dr. Avinash also. Uh, so this topic, ABC of CBC. So very very good topic, and without, like in the anesthesia, that CBCs means, ABC means another thing, but in the pathology or for the clinician, ABC I can interpret automated blood cell count, or if intelligent enough, one can think for absolute basophil count also as pathologist. So there is importance of both the thing, and without this one cannot survive. So welcome Dr. Vikram Prabhakar. He is MBBS from NGMC Tamil Nadu and PG from Manipal Academy of Higher Education. Worked with Medanta, Apollo, Core, and currently as consultant pathologist at Anquest Laboratories. Welcome Dr. Vikram, and can you start your session?
Good morning, everyone. Thank you for the kind introduction, ma'am. So this actually topic was originally to be taken by our everyone's lovingly Dr. Tejinder Singh, but due to health issues, he was not able to come. So at the very last moment, I made this PPT. I hope so it will be helpful. So my topic is ABC of CBC. I will just keep it very basic, and this is one topic which every one of us have been reading from the very first day of our MBBS. From the like physiology, when the first lab happens, and I guess it happens in the same in every medical college. You prick yourself, you prick your cope, who is sitting next to you, and you make slide. So this is the very first experience that we have. And still, this is, it's rightly said that this is the window of the body, because it gives so much information, and no matter whichever field one is practicing, be it gynecology, be it medicine, be it surgery, CBC is required by everyone. And believe me, it's very challenging also. I remember in my, I did actually first DCP. So post DCP only, when I went for my first job interview, so I was like, it was in Chennai. So very confidently, he was like one of our teachers over there. So I said, sir, yeah, I had little problem with bone marrow aspiration and all, but in CBC, I know everything. So he's like, son, I guess you know nothing. And it's actually true, CBC is very challenging. And no one can understand it better than a pathologist who is sitting in a standalone lab, doesn't have much means. Like bone marrow doesn't come to you for the correlation. You don't have much history also, and you have to have report on CBC. It becomes so difficult to take a decision whether it's a atypical cell, whether it's a blast, what to give on. So those kind of challenges are always there, and still we are learning. So just from the basics, I would like to start with, we'll show some photographs also, but just for the starting, I would like to start with the some histograms also. I was told that some pathology PGs will also be coming and all. So just wanted to discuss the basics of it, because I will always advise, because this is somewhere I felt like when I was doing a PG, we were told, we learned also how to read histograms and all, but it's very, very important actually when you start practicing, whether you practice in a hospital, whether you practice in your own lab or in some corporate lab, the standardization of it, how to pick up small things, how to pick up the degeneration part, and still you have to release the report. And so the maximum information that you can get from the smears, from the values, from the graphs, it's very important. So we'll start. So that's how I thought that This is just a basic graph. Like this is how RBC histogram, the middle one is the platelet histogram, and the WBC histogram looks like. For our pathologists, this graph should be, like what like ECG is for the MD medicine people or the cardiologist people. We should be knowing it like very well. So many different companies come up with different coulters. So everyone can have little bit variation between their values, between their ranges, but this graph remains the same. So first of all, this is just an example of the normal RBC histogram. So it's showing the variation in the size. So normally it's like between 80 to 90, 92 femtoliter, but there is a variations are there which we need to pick up. Then there are changes can be there. There can be spurious increase, which can be either due to the giant platelets. Sometimes the machine count the giant platelets in the RBC, so that will show as a spurious increase. Or the high WBC count can also be by the machine if your controls are not working well and all. And if the count is very high in the sample, like more than usually 50 to 60, more than 50, 60,000, that can also be machine, the coulter will count in the RBC. Then there can be spurious decrease also, like whenever there is a agglutination, like the cold or warm agglutination, there will be RBC clumping will be there. And those conditions also, the RBC count highlighted by the coulter will be less. So, but again, those are the spurious one. We need to pick it up. We need to have a correlation with MCHC, the MCV values. So that's why these histograms and the basic values come into the play. Now this is just an example of the RBC histograms that we see. The first one, as you see, there is a like over here, see the graph ends like around at the 200. This like it keeps on decreasing, and it finally ends around 200 value. But over here, as you see, the topmost left one first, it keeps on moving forward. There is a trailer of the erythrocyte population on the far right of the histogram, and this is what we see during the cold agglutination. Cause there is a clumping of it, so for the coulter it's difficult to count in which chamber it should go. So it will keep on, it goes beyond the 200. It's actually the right skewed one graph that we see. Then in this one, as you see, there is a right skew as well, which is going beyond the normal value. It is going like more than 120, 130 it's showing, and there is an increase in the peak also. So this is what happens when there is a macrocytic anemia could be there, or there could be target cells, or even in the dimorphic picture we will see such a histogram. Now if you have noticed, the normal one was not showing this one very small peak. So this small peak also, when we see, it's actually showing when there is a RBC fragmentations are there. So the coulter will catch it, and it will highlight in the, because there are smaller fragments only, so it will be less than 50 femtoliter and all, but still it will be highlighted. And some, as I said, the giant platelets and all, those cause the size is big, so those will also be counted in the RBC section. Now this one, there is a two peaks are there. So this one mainly we see in the dimorphic RBCs, dimorphic anemia, where there are two kind of sizes are there. So it's like normocytic, microchromic. So two peaks are being found, and this even happens when when there is iron deficiency is there, and the clinician starts with the hematinics, the supplementation of B12 or for iron supplementations have been given. So just to check I mean, like whether the patient is improving or not. You don't have to do the, like the serum iron study again, or serum ferritin study again. A normal CBC can also help. Like India being a poor nation, like not everyone can afford like like the expensive tests again and again and again. But as a the clinician also, but wants to know whether the hematinics that we are giving, we are providing, whether they are having some effect, they are having some improvement or not. So this, whenever we see some peak is coming, now there's a biclonal peak. So definitely, along with microcytic picture, there are some normocytic cells also. So we can give the clinician very confidently that yes, it seems like the patient is improving. Or such peaks can also occur when the patient is being transfused. Now there are two kind of cells. One is by the transfusion, there are some normal cells also, and patient like anyway having any kind of maybe infection or a blood loss. So there will be microcytic cells and all. So then also these two peaks will be there. So sometimes if we don't have a clinical history, maybe we should look for one when you see such peaks. Like as I said, the post-transfusion will also having these two peaks. Now the platelet histogram, this is how it looks like. It starts with 2 and usually ends at the level of 20. Now I must say these are the smallest one, but these are the largest culprit. They trouble us a lot. And whenever there is especially when the monsoon season is going on, now the dengue starts, or the malaria also starts. And in otherwise also with the practicing hematologist, they will be treating the acute leukemias or post bone marrow transplant. So many times I'm like, this is these are the ones who trouble a lot, because clinically they the patient immediately when the count goes between less than 20, very severe thrombocytopenia. So you need to have the clinical decision one needs to take, that you need to give a platelet transfusion or not. And most our own all the clinicians knows also, and you should also be I'm mainly addressing to the pathology PGs and all. You should be also telling that when the platelets count start falling, the reliability of these analyzers also decreases. So many times we get a request to do the manual platelet count, and one should do also whenever you seeing a slide. Please do even if you have a load of a very high where you're getting so many CVs and all, but still have an eye of that okay, with one lick on 40x itself, you should be having that okay, this is going towards mild, moderate, or a severe. If it's severe, then definitely go to 100x, make a good count, and well inform the the clinician. So I'm just showing these two small histograms from it. This one, the normal, as you see, starts with 2 and it's at 20 femtoliter. Now this one, the first one, is going beyond it. There's again a right skew to it, and this is what we see when we have giant platelets. So cause the size is more, and so it will go beyond, the analyzer will count beyond 20, and when you see this graph, you can feel okay, when smears will be made, I'll be seeing giant platelets in it. Now this is a peak of a small platelet. Most of them are falling between actually less than 10 only. So when we see such a peak, again we need to make a slide definitely for sure, because you need to do a manual count on it. You need to see whether there is any rare giant platelet there or not, because that will give an idea at least marrow is responding, there is a rare giant platelet. Why I'm telling this, because working in a corporate setup and all, there is always a pressure, how many slides should we make or not. To reduce the cost, so many problems are there. I'm sure pathologists practicing and don't know what kind of problems these are. So when I'm working, I see the monitor, and we decide whether to make a slide on it or not. So such small things, if you know, you already know, I have to make the slide, I have to see the smear, but you also know what to be expecting on the smear. So if you know how to read these graphs and all, the work gonna be easy. Unnecessarily, you won't be making more slides also. And you, before seeing the slides also, you know how to go about it, what to look for. This is how the WBC histogram will look like. So the extreme left will be the lymphoid population, showing the size between 50 to 90. Then comes the basophil, then comes the monocyte, then come the eosinophil, and in the last, this peak is the neutrophils. And as the differential goes in the normal blood, same over here, you see a more higher peak for the lymph and the neutrophil section. So if we so just few examples of it. So the first one on the left, you can see that those more of neutrophils are increased, so the neutrophil peak is increased. Now when the lymphocytosis is there, the extreme one, the one suggesting that okay, lymphoid population is increased. Now this is going, the size is going beyond it. So those could be reactive lymphocytes will be might be more, or in the smear I have to look whether those are the blast or not. Same, if there is a, for eosinophilia, where the eosinophil rise, like over here, kind of in the middle of it, usually the percentage is very less, less than 5 or around 5. So over here, in the middle of the peak, when I see a rise, it gives me impression that that should be expecting eosinophilia on the smears, what I make. And the last one, the blast, as you see, it will be falling after the lymphoid population and all, and the size is also big, so that will give me a clue that okay, probably those are the cause of the blast, and that's what I should be looking into the smears. Just few photographs. Now this is microcytic hyperchromic anemia photograph of one of our patient. So I won't be going, but you know everything in the books, and so just small examples. So it's seen in iron deficiency anemia, in which usually the RDW will be increased. The red cell distribution will be increased. Then the beta thalassemia trait, in which the RDW is usually normal. I'm talking mainly about the uncomplicated ones. Then this is anemia of chronic disease also, you will see a microcytic picture. As on the morphology, like you see, those are smaller size. There is more of hyperchromic, as you see, the central pallor has increased much more than the 1/3. In some there are more than 2/3 as well. Now the basic, which definitely those, the index which comes into our rescue is, that's one of the most common use is the Menzer index, which is the MCV divided by the RBC in the million count. So if it's more than 13, it goes towards iron deficiency anemia. If it's less than 13, it goes towards the beta thalassemia trait, could be the probable cause. Now there are so many other indexes are there, like England index, Srivastava index, so many studies have been taken. But Menzer, I just mentioned Menzer index for, like this is the most common one followed everywhere. Then the macrocytic anemia, you see the size are much bigger. This actually was, size was more than 120. And seen in like megaloblastic anemia. Liver disease can also show like that. In those, MCV won't be very high. It will be around 100 or 103, 105. So you can always mention macrocytes are there, kindly correlated with LFT as well. So that's why like liver disease also being so common in India. Then hypothyroidism also. And MDS, this is one of the very, a subtle one. Even if I don't see much of the information in the CBC, usually it's bicytopenia or pancytopenia. If I don't see much in the myeloid series, the neutrophils don't have so many features in MDS, but this could be a very subtle one in the initial stages. Then thrombocytosis. Just the one example that, as you see, there's so many platelets one can see. It's only in the 40x cell. This is a picture on the 40x. So in this one itself, we see so many platelets are there. So thrombocytosis, it can be seen in so many conditions. So like in MPN, first doubt comes whether it's a MPN, whether some kind of infection is there, and very commonly we also see in the iron deficiency anemia. So there will be a decrease in MCV, there will be decrease in hemoglobin and all, you feel it's and many commonly you will see that This is a mild thrombocytosis. This is mainly due to the reactive one, because body will be responding, it will be secreting EPOs. Now EPOs also have some action on for the platelet growth factors as well. So as a result, the platelets are also increased. So it's a more of a reactive kind of that body does. It's mainly due to the EPOs. Then thrombocytopenia, again very common during the daily lab practice. Right from the infections like dengue or a complicated one, malaria, you will see in everything. MDS or a leukemia patient, and very commonly ITP as well. It's so common that we come across every day. So same thing, thrombocytopenia is there. We need to look into other things, whether there are some blast or not, or there are some atypical suggesting for the MDS, and that's how we make an aplastic anemia. So it's a long DD over there. So this is how one of the basic picture for thrombocytopenia. Then same raised reticulocyte count, two photographs for it, highlighting the. So this mainly shows us the very basic test, not so expensive as well, and it gives so much information. More importantly, the marrow is reactive or not. So many times I myself please correlate with the reticulocyte count. It gives so much information to us. Right from after the blood loss or the hemolytic anemia, the marrow will be responding to it, and there will be a raised reticulocyte count, and it might be decreased. As you see over here, there's hardly any response to it. There's not even one single cell that I can see. So this, when marrow is not, maybe marrow is responding also, but there is you have iron deficiency, you have B12 deficiency. So marrow is not able to, EPO is doing its work, but cause resources are not there, in those conditions also, there will be a decrease in the reticulocyte count. Then again, aplastic anemia, even the CKD, when EPO will not be made so much, or a bone marrow disease as well, those can relate to the decreased reticulocyte count, won't be allowing the marrow to respond to the mainly the anemia part. Then the giant platelets, again very commonly that we seen during day-to-day working. So as I said before, so these giant platelets, the analyzer will might count them as in the lymphocyte chamber. So in the differential you might see that okay, lymphocytes are increased, but you need to do a manual count over there. And sometimes they might be counted under the analyzer in the RBC one. So there is a spurious increase in the RBC count. So this they are so big. One can compare. We have to compare to the size of the RBC. Or if you see a small lymphocyte, with that also one can compare. Then just for the example that for the leukocytosis, again one of the regular smears from our lab, where this one, the right one, is mainly from the having an MPN patient. They're showing the neutrophilic with myeloid left sheath, and there were some rare blasts as well. This just for the comparison, the leukopenia we might be seeing in MDS, aplastic anemia, post bone marrow transplant, and actually when I see a small lymphocyte or monocyte post transplant day 10, day 11, it makes us happy that okay, marrow has started responding to post transplant. So this, even the small cells either here and there gives a big information. Just a photograph for eosinophilia. So right from MPN to the allergic reactions, to the history of asthma, and so many things. So again, this is mild, moderate, severe, very severe. So as the grading goes, you need to highlight it and highlight the cause along for the same as well, depending what is the absolute eosinophilic count on it. So that's it. Thank you.
Thank you, Dr. Prabhakar.
Yeah, thank you, sir.
Really, CBC, the hematology itself, the blood is a very dynamic tissue. Changes with hours or days, even hours also.
Yes, sir.
And rightly said Dr. Prabhakar ki the CBC is the window to the health of any of the person, and it is very difficult to deal with the CBC in 30 minutes or 20 minutes of time. But anyway, you have provided us a insight to look at the histograms and the interpretation of the different blood picture, the morphology along with the data which are being shown by the CBC machine. The we can take few questions if anyone has. Not more than two questions, please.
It is a time to increase our knowledge in the field of hematology, especially in the ABC of CBC. And in the CBC, in my experience, sometimes you will give the values in dimorphic anemia. Perhaps you will agree or not, because I would try to take your comment. MCV in dimorphic anemia, if presenting with pancytopenia, is normal, or MCH is low. Have you seen this type of finding? In dimorphic anemia, presenting with pancytopenia, and having MCV within normal range, MCH below normal range. I have seen this type of cases, and on the basis, because I have especially tried to pick up this value to have a diagnosis of megaloblastic anemia with iron deficiency and dimorphic anemia. Other thing is histogram is very important, and histogram in peak is very important. You should also know, learn more and more how peak generated and how could be interpreted. So in the case of giant platelet, and even in the, so any pseudo-thrombocytopenia, histogram could be helpful. It is a question for you. In pseudo-thrombocytopenia, histogram could be helpful.
Yeah, definitely, sir. So in the pseudo-thrombocytopenia, like mainly happens like in IDTA vial, that's so causing it. So same, those will be showing spurious decrease first. Like there will be a low platelet count. So the platelet histogram won't be normal one, and those definitely sometimes giant platelets are there. So it will be reflected in the analyzer as the increased lymphocyte. So when I see, I'm thinking, oh, is it a cause? I just see at that moment that there is a decreased platelet and there is increased lymphocyte. So first thought is whether it's some kind of leukemia. But when I make the slide, we realize that platelets are not so much increased. Maybe, and some
yes.
platelet clamps or giant platelets are there.
So in the case of pseudothrombus, usual presentation of peripheral blood is
Dr. Jha,
is
sorry.
giant platelet or in cluster. So that giant platelet cluster could affect the histogram.
Yeah, definitely.
Dr.
Affects the
Jha,
histogram.
please, you can discuss all these things during tea break.
Sure. Thank you. Thank you, everyone.
Thank you, sir. That was a very visually enriching and gripping session. We would now like to move on to the next topic, which is clinical approach to thrombocytopenia. And I would like to call upon the chairpersons for that. Dr. Sudesh Kumar, sir, Senior Consultant Pediatrician, Kishanganj. Dr. Dinesh Kumar Sinha, sir, Professor, Radiation Oncology, IGIMS, Patna. Dr. B.P. Azad, sir, Associate Professor, Department of Medicine, NMCH, Patna. And Dr. Vibhu Prasad, sir, Assistant Professor, Department of Medicine, NMCH, Patna.
Good morning. Thank you, Dr. Avinash and his team for giving the opportunity. So today's session on clinical approach of thrombocytopenia, I warm welcome Dr. Anil Singh from RAKTAVIGYAN. So now over to you, sir. You can start.
Dr. Iram Anil Singh is a DM in clinical hematology and currently as associate professor at JLN IMS Imphal. So over to you, sir.
Pointer. So just is it this one? Great. And then I have just यहाँ पे good morning. I'm actually so privileged to be invited by Dr. Avinash Singh sir. We have been knowing Sir Avinash during our time in AIMS New Delhi when we were a student. We used to hear stories about Sir, and then since the time we pass out, I have been always having the opportunity to interact with him, and today again I have been given an opportunity to come down to Patna. This is my first time, and I like to start with the one word that morning shows the day, sir. So I think the amount of crowd you have been able to gather shows that what lies ahead for the people of this lovely state Bihar in the field of hematology, sir, and I like to congratulate for you for that, sir. So with that, I want to start about a clinical approach to thrombocytopenia. I think my job is much easier now because it has been already discussed in the previous slide also, previous speaker. So thrombocytopenia is when the platelet count is less than 1.5 lakhs. It may be further subdivided as mild, moderate or severe based on the amount of platelet count, less than 50 or less than 500, 50,000, I'm sorry. So, but are we going to be afraid of every thrombocytopenia? I don't think so. Every thrombocytopenia doesn't have a lot of problems. Sometimes they may be just asymptomatic or life-threatening bleeding. However, thrombocytopenia, we always think it will be bleeding, but no, it can also cause thrombosis that may be even more life-threatening, like say in heparin-induced thrombocytopenia. Even there is thrombocytopenia, but there may be thrombosis. Now, this also has been discussed just now, so my job is easier. Even if it is low, we don't have to jump. Okay, it is low. We have to really think, is it actually low platelet or not? So we have to rule out pseudothrombocytopenia. It has been already discussed just now. It is an artifactual low platelet because of the EDTA, and there is a already discussed now. You can see that clumping is there, so peripheral smear is so important to detect that it is not actually a real thrombocytopenia. It is pseudothrombocytopenia. It is due to EDTA-dependent platelet agglutinins that are already present in the patient's body that causes clumping. So in such scenario, I think citrate or heparin vial should be done. So the pathologists and hematopathologists will be surely saying to repeat the sample again in a citrate or a heparin vial. So now that a patient is found to be thrombocytopenic, how are we going to do? We have to go to the history. Most important is always the history from our time. We have been taught that history is the most important thing, and it will always remain true for every subject. So most important is it the first time? Was it low before? Is there any family history? Because some family have like platelet function defect, or sometime it may be in the family, then we understand something. Is there any kind of bleeding? Like bleeding, if it is from the muscle, then we suspect some like hemophilia. Suppose if bleeding is from the mucous membrane, then we think of maybe thrombocytopenia. So we need to know from where the bleeding is there. We need to understand if there is a medication going on. Suppose a patient is taking equestrian, for example, then over-the-counter medication is very common in this part of the world, and especially in, I think it holds true in Manipur also. I am sure it holds true in Bihar also. Then infectious disease exposure, I am sure dengue is quite rampant in Manipur also nowadays. It must be true here also. So dengue are notorious. And dietary practice, those who are taking pure vegetarian, they are known to have. And of course some other malignancies. Then physical examination to look for lymphadenopathy, splenomegaly, etc. Then we suspect, okay, it may be might be ITP, or maybe leukemia, maybe lymphoma, similarly. So based on the platelet count, we can understand like this. If it is around 30 to 50, minor trauma or some injury can cause some bleeding like this. If it is 10 to 30,000 without any bleeding, without any trauma, they may have some spontaneous, some rashes like this, petechiae ecchymosis. And in case of less than 10,000, some patient may have gum bleed. However, if it is less than 5,000, they may have IC bleed. However, Should we always be worried about, okay, bleeding hoga, platelet is 20,000, 30,000 in the middle of night, patient attendant and will be running around for platelet transfusion sometime, and the blood bank will be bombarded during COVID time, during dengue time. Lot of platelet prescription will be surely coming to many blood banks because platelet is very low. So should we worry that every time platelet is low, are we going to be worried? Actually, I want to share that platelet count, even if it is low, some patient may not bleed. I have a patient right now, acute myeloid leukemia, day 13 of induction, sir, Saravinas, day 13 of induction, and the platelet is 2000 today morning. I am giving platelet every day. Unfortunately, she doesn't have fever also, she doesn't have bleed. Actually, she developed some low antibody. Unfortunately, I cannot do more than what I am doing. We are giving only some platelet because 2000, but she doesn't have a single bleed anywhere. So sometime the platelet, even if it is so low, may not cause bleeding. However, some predictors are there, like if there is an episode of bleeding in the past, okay, then presence of this wet purpura. I want to stress on this. If there is a wet purpura, it's a sign that the patient may have some bleed, so we have to be careful in such case. And of course, if there is hematuria, there is already bleeding, so I think we should give more platelet. So the causes of thrombocytopenia, ITP is one of the most important. We'll not discuss today because we have a session tomorrow. Then drug-induced, then infections like HIV, hepatitis C, EBV, then sepsis with DIC, and hypersplenism. Many patients are there in Manipur suffering from chronic liver disease. I'm not sure about this place, but in Manipur is rampant, chronic liver disease. And then, of course, autoimmune disease, which is common in female patients, nutritional deficiencies, and pregnancy. I'll have to say something on pregnancy because it will hold true in every part of the country. So other malignancies, aplastic anemias and all, I will not be discussing because they are going to be always associated. So ITP, briefly, since I'll be talking only approach, so usually maybe mild or moderate or sometimes severe. Hemoglobin, WBC are unaffected. Complete blood count, as we have just discussed now, they are very important, and presumptive diagnosis is made when the history, physical examination, and the laboratory other analysis doesn't suggest alternative diagnosis. So it is very important that we understand that ITP is a diagnosis of exclusion. Then chronic liver disease, there may be isolated thrombocytopenia. Many of our patients are diagnosed as chronic liver disease only because of thrombocytopenia. These are just referred to me that a patient is suffering from thrombocytopenia. When we do a routine CBC, we find that, okay, hemoglobin TLC is low, okay, normal, and then only platelet is low. Then when we do an LFT, we don't find anything again. We find mild reduction in albumin. And then when we do further analysis, we find that there is already compensated cirrhosis started. So likewise, thrombocytopenia can be very important among the places where chronic liver disease is common. And platelet may not be very low. Spleen is sometimes palpable. It is mainly due to the reduction in the thrombopoietin synthesis. It is one of the most important area for synthesis. So if it is reduced, the platelet may be low. Then of course, ICU patient, we all know that around 60% of patients in ICU may have thrombocytopenia, and around 40% may develop during their stay. Of course, commonest is always sepsis and DIC. There are many other conditions, but sepsis and DIC, we have to understand. Again, among the post-operative surgeons, if there are surgeons among us, we know that around 48 to 72 hours later, there may be thrombocytopenia. It may be dilutional or consumption because of some DIC or something. And of course, if patient is on heparin, they may be again hit. Usually they recover by themselves. Infection is very important. Everyone will come through infection, and variety of infections may be platelet immune mediated, or bone marrow suppression, or platelet consumption. And so many of these viruses, I want to stress on these two at the moment. Dengue is, I think, very common in Manipur also. It may be true. And of course, COVID is lesser now, but that COVID still, I think, recently there was another wave, so I thought we should know. And of course, they are usually incidental, resolved completely in most, and may persist even after hepatitis C treatment is completed in hepatitis C infection. It may be because of direct toxicity in case of HIV. Then, bacterial infection is usually because of direct bone marrow suppression, or it may be as a component of DIC. Drug-induced, yes, every possible, whatever drug can cause thrombocytopenia. And within hours of exposure, if it has been previously exposed, it can cause, but however, after stopping that, it may again resolve. These are all the drugs, whatever, I think these are all commonly used drugs, so I don't know which one to be avoided. But then again, it depends on the luck also, that if you are suspecting that the drug may be the culprit, then just stop it. That is the only thing. Yes, then over-the-counter herbal products and all, ingestion of tonic water, which is very common in this part of the world. We are very fond of taking many things. I think cow urine we are fond of taking. So like that, so many things is going on. So sometimes medical science cannot explain all these things. So maybe they also may cause herbal preparations, over-the-counter medicines are known to produce. Rheumatological autoimmune disease is notorious. We all know that they will all have hematological manifestation, and SLE almost 25 to 50 may have thrombocytopenia, and to phospholipid syndrome also, and in thrombocytopenia also seen among the rheumatoid arthritis patient. Yes, this is what I want to stress. Pregnancy is a very complicated, I think, immunologically, and everyone will have some problem with this. Gynecologist, a surgeon, anesthesia, the physician, the pediatrician will all have. So gestational, we need to understand that it is when the platelet is only mildly reduced, it is usually asymptomatic, occurs during late pregnancy and resolves spontaneously after delivery. However, are we going to be worried every time platelet is low? No. If it is around 1 lakh, we shouldn't be worrying so much. And of course, if platelet is low, below 1 lakh, we have to suspect ITP, and other things are more dangerous. There is HELP syndrome, preeclampsia, and thrombocytopenic purpura. They may be associated with renal deficiency, hypertension, microangiopathic hemolytic anemia. So if it is isolated thrombocytopenia, we should not be worrying so much, because ITP is not that significant. Other related causes I am not discussing. Now how to approach? Routinely all these tests, I think we usually do only. Then when clinically indicated, other tests like viral infections. Yes, I want to know why we always throw our ball to the pathology friends. I think I have pathology friends who will agree with me. Many a time when there is anemia, they are referred to pathologists for bone marrow examination. Just because there is thrombocytopenia, we do that, and I think you'll all agree with me. But is it really indicated? I think we are very fond of asking them to give us a diagnosis. We shouldn't be doing that. Aspirate is not required in all the patients with thrombocytopenia. However, it may be helpful if the cause is unclear, or if the primary hematologic disorder is suspected to be maybe some leukemia or other than infection. So, if there is infection, fever, then we can think of this infection, DIC malignancies. If there is splenomegaly, we may think of lymphoma or hypersplenism. If there is lymphadenopathy, of course, we think this. Suppose if somebody has altered sensorium, we can think of TTP, HUS, like that. And if there is thrombosis, definitely HIT and antiphospholipid syndrome is what we will always think. Now, coming to the management. If it is mild thrombocytopenia, usually they are asymptomatic, so usually only observation is required. We just rule out the secondary causes. We don't need any treatment. And this is very important slide I want to share with all of you. Many a time the physicians will be getting called from every corner of the world. Surgeons, anesthesias will be not giving clearance for surgery. So for neurosurgery, it is always 1 lakh. For any major surgery, it is 50,000. However, our friends of the anesthesias and our friends from the surgeons, they are reluctant. They will not operate until the platelet is ready, until platelet is more than 1 lakh. But I think it's just I think we are just habituated. So with this, I want to share that this is the latest American Association of Blood Bank guideline. They advocate for restrictive platelet transfusion strategies to reduce adverse event, shortage, and costs. So, all the hospitalized adult patient with therapy induced because of chemotherapy or whatever, transfused platelet is prophylactically less than 10,000. So, less than 10,000 without fever, we used to remember. Then, undergoing radiology or any minor procedure, 20,000. So minor procedure also we are running around for platelets. I'm finishing my only 2 more slides. Just give me 1 more extra minute. Adult undergoing high procedure like elective surgery, then 50,000 with no major bleeding. adult with consumptive thrombocytopenia, DIC, which is what we are all afraid. If there is no bleeding, we don't need to transfuse. Then undergoing central venous catheter placement, I think sometimes we refer the patient to ICU for central catheter. Sometimes we refer to anesthesiologists also. They will not take up if it is less than 10,000. So I think it is not indicated. And non-operative intracranial, yeah, I am finishing. Just 1 minute extra, please. Non-operative intracranial hemorrhage transfusion not recommended if platelet is more than 1 lakh. And lastly, cardiac surgeries also with cardiopulmonary bypass, non-thrombocytopenic. Routine prophylactic transfusion is not required. So, to summarize, thrombocytopenia has a diverse cause and implication. The severity, acuity, and clinical context guide evaluation. Early recognition of emergency is critical, and the multidisciplinary approach is needed. With this, I like to end my slide, and thank you. Thank you, everyone. Thank you, Avinash sir, again.
Thank you very much, Dr. RM, for this comments on Bihari. It's a good one.
So, I like to say one more word, sir, if you allow me.
Yeah, of course.
I was going through what is more important in Bihar. Then I came to know that Bihar is the second highest number of IAS in India, next to UP, and the maximum number of IIM, IIT need, despite having the lowest literacy rate. I cannot imagine if someone is having a low literacy rate and having the highest number of all this. I think the heads off to. That's why I thought.
Yeah.
Okay. Dr. Aram, one question. Your observation only that post-dengue mild thrombocytopenia continuing for years. Your observation about it.
So, since it is a viral infection, we will want to know whether...
Without any other complication?
Yes. Because usually in case of thrombocytopenia due to dengue, what happens is that there may be a phase of thrombocytopenia. They go as low as around, say, 10,000, 20,000. Then they start...
For years.
I am saying about normal scenario. They start increasing, and they start increasing more than 10 lakh sometime.
It is between 110 to 130.
Yeah. So in this case, what I want to say is that maybe some viral infection, we have not learned everything in viral infection. So maybe some antibody formation have occurred. So yeah. So some antibody formation might have.
I got it.
Yes.
That is not your part. Some medicine people will come. Then I ask. But I am just putting the question to the general house that. What may be the remedy for post-dengue continuous thrombocytopenia? What could be the remedy? Dr. Jha is eager to say something. Okay.
Sir, I am also suffering from less than 1 lakh platelet post-dengue. Myself is a case of moderate thrombocytopenia. I am suffering. That could be reason that some antibody that generated at the time of dengue is still persisting in our body and hampered the specific stem cell that is responsible for megakaryocyte formation or possibly the destruction in the peripheral bulb. This could be two possibilities.
Dr. Aram, I have a question.
It does not need treatment.
I have a question. I used to practice solid tumor. That's why I'm asking some of the patient of the gemcitabines or like that, having the propensity of the thrombocytopenia.
Yes, sir.
In a solid tumor, giving the chemotherapy, in case of that, do you regularly use romiplostim as a prophylaxis or like that? Or do you recommend?
For hematological malignancies, platelet goes down as low
for
as
the solid tumor.
I'm coming that less than 10,000. But in case of usually solid tumors, the amount, since the bone marrow are usually not affected, the platelet may not be very low. Suppose if it is less than 30,000, sometimes we recommend, okay, please give romiplostim or L-thrombopag. Otherwise, if it is around 50,000, usually we don't recommend.
The main problem is that we have a sequential giving of the chemotherapy therapeutic regimens.
Yes,
So
yes,
that's why after the 8 days, day 1, day 8, in case of the day 1, day 8, day 15, the predictability is very lower.
Yes, yes,
So
sir.
there's a three things commonly we used to practice. One is that giving the Ayurvedic treatment of the like carry peel kind of the things, carica papaya. Second, we used to give L-trombopeg some of the patients. And third is the romiplostim, or fourth is the platelet transfusions. So in that case, any kind of the categorizations of like that or criteria where for the solid tumor people used to practice, should practice.
I think Dr. Kundo is more concerned about the delay in chemotherapy in solid tumors.
Yes, I can
so
agree
to
that. Because we don't want to delay
can
chemotherapy.
we use it?
Since to avoid delay in chemotherapy, we can use like GCSF, so similarly we can use romiplostin. So, however, if it is above 50,000, usually for any hematological malignancy also we give the next chemotherapy. So I think it should not be an issue, sir.
So do giving the romiplostim in sometimes in future can give like to PRCA kind of the things like APO, pure red cell aplasia like
no,
things, antiplatelets.
We have not come across any such data, sir.
Thank you. Thank you.
Thank
I don't think it's recommended for prophylactic use in giving chemotherapy for solid malignancy. And second thing, the carry peel, papaya extract, kiwi fruit, goat milk, they are not recommended. So we don't use. Dr. Anil, your opinion?
So somehow some of the doctors used to recommend deferring the dose. But in the solid tumor, we have to show the result also because the palatability of the surgeon to remove the things.
Yes.
In that case, we are a bit using the RDP or SDP, whether we go for the romiplostim for the augmentations of that when the bone marrow reserve is enough. That's why I'm asking what should be our criteria in a practice so that everyone can preach and propagate the things.
I think we should follow the recommended guidelines like NCCN for that particular solid malignancy. If as a supportive treatment they recommend that you should use, then you should use. Otherwise, it should not be. And regarding carry pill, I don't think we are not using for any of patients. But we have not seen any thrombocytopenia patient who has come to me and who has not taken papaya extract, goat milk, or kiwi fruit.
And kiwi fruit.
So that is the reality. Your opinion?
So
beyond NCCN.
Yes.
So thank you, sir.
Thank
Our
you.
session should be concluded.
Thank you very much.
I have one photograph. We can announce. Kar do.
Thank you, sir. That was a very energetic session. We'll move forward to the next topic, which is iron and medical practice, for which I'd like to call upon the chairpersons. Dr. Rajan Kumar, sir, Professor, Department of Medicine, PMCH, Patna. Can we have you on the dais, sir? And Dr. Arun Tagore, sir, Senior Consultant, Medical Oncologist, Paras, HMRI, Patna. While we encourage you to participate and post your queries, you can also post your queries via email on raktavigyan@gmail.com and tag the speaker that you would like to be addressed to. Thank you.
Now I invite Dr. Saurabh Neil Ball for his presentation. He is Associate Professor at NRS Medical College and Hospital, and his topic will be IV iron in medical practice.
Good morning, everyone, and thanks RAKTAVIGYAN. Thanks Avinash sir for inviting me as a faculty in this topic. So my topic is single dose IV iron. Let's make it simpler. So in our clinical practice, we are all habituated in treating iron deficiency with oral iron therapy. But now, most of the clinicians prefer IV iron. But there are lots of important science in it, which I am going to discuss. So we all know what is iron deficiency. It is basically, remember, absolute iron deficiency, where you get low TSAT, that is transferrin saturation, and low ferritin. But there are certain situations where there is functional iron deficiency, where there is iron sequestration anemia, and there are certain situations where there is absolute iron deficiency associated with functional and iron sequestration. So you get low transferrin saturation. So you ask me how you calculate low transferrin. You divide the serum iron by the serum TIBC. You get the transferrin saturation into 100. And serum ferritin is directly calculated by lab investigation. So after that we go. So there are two types of pull in iron deficiency. There is a storage pull, functional pull. We are all taught in our physiology and pathology days. So functional iron deficiency, just want to highlight here, the iron that is available in the storage pool is not properly utilized for hematopoiesis in the bone marrow. Okay. So absolute iron deficiency, iron is not there, but functional iron deficiency is that iron is there, but you are not able to utilize that iron for hematopoiesis. Thank you. So coming to the history of intravenous iron, which is my topic of talk. So the first you see in 1954 it was high molecular weight iron, followed by ferrimoxotol in 2009, and in 2013 the ferric carboxymaltose is used, and in 2020 we have iron isomaltoside. So we will be coming up for this carboxymaltose, which is most commonly used in our clinical practice, and also iron isomaltoside. So it's classified into first gen, second gen, and third gen. So presently we use the third generations, that is the ferric carboxymaltose and iron isomaltoside and ferrimoxotol. The second gens are used, and first gens they are more prone for acute infusional reactions. So they are mostly now less used in our clinical practice. So we are sticking to the third gens. So already I have told what are second gen and third gen. The minor difference is, remember, the iron in the third generation molecules are more tightly packed in their carbohydrate moiety. So they are released very lowly in the bloodstream. So chance of acute reactions are very low. So this is the third generation. They have a strong complex structure and releasing it much lower level. The free iron release is very less in third gen. So the chance of acute reactions are very low, but still there is a possibility, and I always advise to take them in a hospital setting. Do not try it at home. So you can see with iron dextran the risk of anaphylaxis is highest, but with iron ferric carboxymaltose and iron isomaltoside the chance of anaphylaxis is low. So these are different molecular weights that has been mentioned, and you see the osmolality, you see the pH, and of ferric carboxymaltose is almost, it is neutral isotonic with the human plasma. So what is the total iron deficiency in patient, you must know. So we are all used to this formula, that is the famous Ganjonis formula, and it has been found that almost in all patients who require iron, like in the postpartum, like the heavy menstrual bleeding, and idea of various etiologies, it is around 1531 milligram, that is 1500 milligram of IV iron is required. So if you give 1000 milligram, because previously the vials used to come at 1000 milligram and 500 milligram. So if you give one dose of 1000 milligram, it won't suffice. It has been found that there is a need for retreatment. If you just give a 1000 milligram iron, if you give 1500 milligram, the requirement over time is less because you replace the complete dose. So it is close to the actual iron deficit, that is the 1500 milligram. So it suggests that, remember, when you infuse iron, you should infuse total dose of 1500 milligram, but you cannot give total 1500 milligram iron at one go. You can at best give maximum 1000 milligram. So what to do? So most of the patients don't come for the next dose, or most of the time you skip. So what has been done to address this? I have already told. So what has been done to address that issue? So if a person is less than having hemoglobin of 10 and 70 kg, the total dose is always 1500 milligram. So how should iron deficit be replaced? So remember, so when you replace the complete dose, the finding is that there is a 32% lower probability that the patient will have a rebound anemia if you give 1500 milligram. Okay. And patient who have received FCM, remember at a full dose of 1500 milligram, they have less injections, higher percent of patient achieved an hemoglobin of 12 gram, and they have less outpatient visit. So that is the advantage of giving 1500 milligram of iron. How will you give it? So there are two dosage available. One is 750, another is 750. Give 10 days apart. Okay. So now coming to some clinical scenarios where I will discuss. They have the least labile iron content I have already mentioned. So there are some studies I would discuss. In cancers, it has been found that if you give IV iron in a situation, because here also the anemia of chronic inflammation works, so you should remember that you have to maintain a transferrin saturation of 25% here. Okay. So suppose that FCM monotherapy in anemia patient receiving myelosuppressive for non-myeloid who are unsuitable candidates for tolerate ESA or blood transfusion, you can go for IV iron. Okay. So what would be your option between in colorectal cancer? In colorectal cancer also for chemotherapy you need a iron of more than a hemoglobin of more than 12 gram per DL. So here also the studies have shown that IV iron ferric carboxymaltoside is the better option. And in day 30 it has been shown that the normalization of hemoglobin is best with IV iron. In colorectal surgery also, that I have already saw, coming to another important topic, that is anemia in chronic kidney disease. So here we find that the most favorite iron was with nephrologist was iron sucrose 200 milligram for 5 days. But 2 doses of FCM 750 in 1 week apart is also sufficient. So it has been found that it is safe and effective alternative, and hemoglobin increase was 1.13 gram per DL. So in any CKD patient, one must first correct the IV iron first, followed by the erythropoietin injections, because if you don't correct the IV iron, your erythropoietin injections won't give you the necessary rise in hemoglobin. So these are different studies you have seen with the IV ferric carboxymaltoside, 2 dosages, and also oral iron, and you can clearly see that 8 and 52 weeks with ferric carboxymaltoside, the rise in hemoglobin is 1.4, and hemoglobin increase in more than 1 gram, it is 56.9%. Okay. So there are different gastrointestinal cause of iron deficiency and iron deficiency. I am not reading all these charts, but you are knowing most of the things. In our clinical practice, we mostly get hemorrhoidal bleeding, diverticular bleeding, all these causes we know. But the important point you remember, the inflammatory bowel disease. Here there are some important points. Remember, in acute GI bleeding, the target hemoglobin should be your more than 7. But if your patient is having some amount of cardiac dysfunction, the target hemoglobin should be more than 9 gram per DL. Okay. So what are the transfusions for hemoglobin thresholds? So remember, in an upper GI bleed with hemodynamic instability, you maintain the hemoglobin more than 7. So don't increase to 9 and 10. Your target hemoglobin should be 7. So here iron infusion won't work. So we all know the blood transfusion is associated with different immunologic and non-immunologic complications. I am not repeating this, we all know this. So to mitigate this crisis, we prefer IV iron. This is a busy algorithm. Just you can see that what we do and what we prefer, and mostly where there is hemodynamic instability or there is associated cardiovascular diseases, we prefer blood transfusion. Other than that, we prefer IV iron. So in a inflammatory bowel disease, it has been found that IV iron at doses of 750 milligram 2 weeks apart gives you better results compared to oral iron. Only indication for oral iron in inflammatory bowel disease is that the active disease should not be there. If there is an active disease, you should not give IV iron. And there are some points, you check iron indices 4 weeks apart, and 50% of IBD patients again develop IDA within 10 months of adequate iron replacement. So in IBD patients, there is malabsorption. Check your iron indices 4 weeks apart, and iron deficiency gets repeated after 10 months of therapy. Again, I am not discussing this. It has improved quality of patients in all category of patients, both in chronic diseases and in ulcerative colitis patients. So, what are the side effects that we commonly across? It should be always in the hospital setting. And remember, never try IV iron at home. It is not permitted. And it should be always in a hospital setting in a proper clinical scenario. And in heart failure is another topic that IV iron is preferred. We know iron is much more required for myocardium function. So you can see that IV iron is across all these heart studies that FAIR-CARS, FAIR-HF, efficiency heart form, the IV iron is the most suitable way to correct anemia. Okay, and you can see the patients who have received IV iron in the form of ferric carboxymaltoside with full doses, they are much improved compared to oral iron therapy. So this is the algorithm of a replacement, but remember, if your patient is in heart failure, if your patient has hemoglobin of less than 7, prefer blood transfusion, because that time IV iron will take time to work, but after that you correct with IV ferric carboxymaltoside. Some local side effects, as we know with all therapy, like pain at site, diarrhea, nausea, constipation, abdominal pain, this we get. Often patients have complained to me that they have skin discoloration after IV iron. So here I want to discuss certain important points. Remember, I was always highlighting throughout my talk that IV iron can cause acute infusional reaction. So that is called complement activated related pseudoallergy, that is CARPA. Here there is no prior sensitization is required. The patient will complain of pruritus, isolated urticaria, flushing, chest tightness and joint pain. Okay, and IgA mediated hypersensitivity. Remember here, don't try to give IV Avil. Don't give. You can give Hydrocort and you can reassure the patient. Only one indication, if there is anaphylaxis, do not restart that injection. Okay, because this allergic phenomena is not what we get after we inject with antibiotics. Okay, so this reaction is CARPA. So that I want to highlight. So FCM 750 is the standard dose we use. Use 2 dosages 2 weeks apart. Do not infuse more than 1 K of iron in a 1 week. And your total dose is not complete with total 1 K dose. The total deficit is 1500 milligram across all patients that I have highlighted in various studies. And it should be diluted in 100 ml normal saline and should be given in 20 to 30 minutes. However, different papers have stated that you can give in 10 minutes time also, but prefer 20 to 30 minutes. So coming to the conclusion of my talk, the total deficit I have already mentioned is 1500 milligram. It has key roles in cardiology, oncology, GI disorders apart from gynecology. Gynecological iron deficiency is the domain of gynecologists. They do in their own practice in the second trimester of pregnancy. It has demonstrated that across large prospective studies in each of the indications, iron replacement definitely improves outcome. Hemoglobin concentration increases after IV iron is within 1 to 2 weeks. With oral iron, you will get the result in 4 to 6 weeks and should increase by 1 to 2 gram within 4 to 2 weeks of therapy. Many Indian studies have largely generated large wealth of data in various indications of FCM. Thank you.
Thank you, Paul. One question. Suppose the patient is on chemotherapy and having hemogram is 7 grams. Should I proceed with the IV iron, should BT, or along with both oral and the IV iron?
Sir, you first do an iron study in your chemotherapy induced anemia. Okay. In chemotherapy induced anemia, studies have shown that you will get a higher ferritin. Your transferrin saturation will come low if there is an absolute iron deficiency, sir. If it is an absolute iron deficiency.
Absolutely, yeah.
Suppose you don't get an absolute iron deficiency, that means it is functional iron deficiency or it is the drug that is causing you iron deficiency. But remember, most of our chemotherapy patients are not eating properly, so there is no hindrance of giving IV iron. But do not give your erythropoietic stimulating agents before replacing the IV iron. That would I would suggest. How much IV iron you can give? You should correct to 1500 milligram of 750 milligram injection 2 weeks apart. Okay, sir.
But the schedule is the so early. Suppose the after 2 days or 3 days the chemotherapy due date.
No, it won't work, sir. If it is
in that situation, BT should be given or the IV should be.
In that situation, suppose you have chemotherapy coming up in 2 to 3 days time, your IV iron will give you rise in hemoglobin at least in 2 weeks time, sir.
That's right.
So you cannot go for rely on IV iron in this situation. You have to go for blood transfusion.
And also, sir, there is a fear of giving IV iron. We are not hematologists. That's why sometimes we feel fear of giving IV iron, having reactions or like that. Does it happen in MCM nowadays?
It happens, but it is relatively more safe. Why it is safe, I have told, because the iron is tightly bound, but still it can happen. The reaction is CARPA, I have told it. So I have given to at least 1000 patients IV iron in my clinical practice. So reactions do occur in anecdotal patients, but it is manageable. Okay, but it should not be tried at home. Many patients ask me, can I get it at home? I say no, and don't do that. Okay.
Doctor, just load. Suppose you have given the IV iron, can you continue with the oral iron or something else?
No, sir. Never try IV iron and oral iron together, sir. If you give a complete, that's why the dose of 1500 milligram I was highlighting again and again, and that's why 2 vials of 750 should be used, because many times people are complacent with one dosage of 1K iron, but that won't correct. If you give IV iron and if you give oral iron, your oral iron is totally ineffective in correcting that dose. It will just give him added gastrointestinal toxicity, because when you are saturating your reticuloendothelial system, because that IV iron directly goes into your reticuloendothelial system, all the oral iron will not be absorbed at all, so it won't work.
But usually daily practice, our
no, it should not be done. It should not be done. If you are giving iron, IV iron, at least for 1 year, you should not be giving anything.
For 1 year?
No, because it corrects for 1 year, because it can come back. Again, the patient can
after
have
1 month, it is still the lower iron load should continue, IV iron or something, or
no,
wait
sir.
for
Once you have given a complete 1500 milligram of iron dosage, means I am correcting his deficit completely. So then we'll follow up the patient at time points at 3 months gap. If there is a drip in hemoglobin or if there is a drip in the iron studies, then only we can consider whether to choose for oral or IV. But simultaneously, both should not be tried.
And suppose after the 8 weeks or 4 months, you have given the IV iron, and after 4 months it is still go down the iron.
Yes, sir.
Should we continue the after 1 month or 2 months oral iron? But the iron deficiency anemia and nutritional iron deficiency anemia.
At least 2 months you should not give anything, sir, because the whole reticuloendothelium is completely saturated.
After 2 months, 4 months.
After 2 months, but do check the iron values. Do check it, because what I have shown in one of the studies, that after iron study should be done after 2 months of IV iron, not before that. If you find that your ferritin is more than 50, no need to give anything, because study says that one should not treat all iron deficiencies. There is normal hemoglobin. Suppose a person is having hemoglobin of 12 or 13, but he is having iron deficiency, that is his ferritin is low, but he is having no clinical symptom. Do not treat that patient.
My question is, suppose after
Sir?
Suppose a lady is having 12 gram hemoglobin and ferritin is 50 and patient having fatigue.
50,
so
sir, 15.
50.
50.
Should we give iron or not?
No. Because there we have to evaluate for
with the fatigue, not with the iron deficiency.
But our cutoff correction of ferritin is 50 nanogram per ml.
If there is a continuous bleeding, suppose that hemorrhagic telangiectasia or celiac disease loss is continuous, then what will be the target of the ferritin? It will be the same 50 or something.
If it is a patient with ongoing bleeding, sir.
Yeah, ongoing continuous.
If it is a patient with ongoing bleeding, if ferritin is 50, right, sir?
Yeah, 50.
And a patient is complaining of fatigue.
Yeah, just like celiac disease, yeah, hemorrhagic telangiectasia,
and
the gut.
Hemoglobin is normal, sir.
Hemoglobin is normal.
Hemoglobin is normal. So there is no point giving oral iron, sir.
No,
here.
no point.
No point.
IV? No point.
No point, sir. Unless and until, another point I want to share is very important. Check your ferritin before IV iron, always. Never give IV iron if somebody do not have absolute iron deficiency or the conditions that are made to be treated with IV iron. Okay? Never give IV iron to anyone if there is no absolute iron deficiency in the conditions I have shown in the first slide. Okay?
No, is there any need to replenish the iron store? So iron store is up to 3 milligram. So
Yes,
50
sir.
means the 50 milligram is the store.
We
Should have to
monitor-
complete with the 320 or something else?
Sir, can you repeat the question once again, sir?
No, the ferritin level is maximum is 320. Means 3 mg store is in the bone reticuloendothelial system. 50 means 50 milligram.
The 50 is the
Lower side.
blood level of ferritin that we get.
Yeah,
Sir.
that is the 50 level. Should
50.
we replace with to increase up to the upper level or still let the patient go with the 50 one?
Sir,
We correct to 50 nanogram per ml, sir.
Okay.
We stop it after that. We don't overcorrect. But in CKD patients, sir, the ferritin is at higher level. It is kept at 500 maximum, sir, in anemia of chronic inflammation. So the cutoff varies with different diseases, sir. In inflammatory bowel disease, it goes to 200, sir. But in patients who is having normal iron deficiency due to nutritional cause, due to any other cause, the cutoff is 50. We don't overcorrect. And that level comes at least after 1 year of oral iron therapy and after 2 months of IV iron correction.
In that case, vitamin B12 and vitamin B12 and folic should be seen in that case. And albumin level, vitamin B12, folic. Others should be also corrected along with the iron.
If you have a deficiency of vitamin B12, but that can be easily known from your MCV values and RDW values. Okay. Suppose your MCV is 70, 71, 69, 68. It is no point doing a vitamin B12 assay in that. Okay.
Sir, I have one question.
Thank you. Thank
Yeah.
you.
Sir, I have one question. Sir, in patients with just anemia, no comorbidities, no CKD, no nothing, just patient is following with anemia, her saturation is low and ferritin is high. Saturation is less than like 10%.
Got it.
And ferritin is 600.
Okay.
And she has received IV iron past 4 months back and blood transfusion. Again, she had anemia, so iron studies was done and the reports are this. Low saturation, high ferritin. So, what will be your approach in this case? Just IV iron or IV iron with EPO?
Okay. So, first you have to qualify what is the comorbidity.
No comorbidities.
No comorbidity. So, again this high ferritin 600 mg is not
She has
normal.
received IV iron like 5-6 months back.
This ferritin is 600 mg is not a normal situation.
Yes.
So, there may be some background inflammation.
Yeah.
Okay.
Yeah.
So, that point, but your transferrin saturation is low.
Yes, sir.
That means you have low serum iron in your circulating blood and your TIBC always rises in situations where there is an iron deficiency.
Yes.
So, you can give this patient oral iron or IV iron
with
depending on the patient choice and depending on his GI absorptional capacity.
And
Okay.
EPO?
Ketan,
Ready to
just
point?
running short of time. Just talk.
I
break time.
Unless and until your transferrin saturation rises more than 20%, your this storage pool iron won't go to the hematopoietic site. Okay. So give after you have corrected it.
Okay.
Okay.
Thank
So when will you measure the TSAT? You measure after 4 weeks.
4 weeks.
Okay. After IV iron. So if you find your TSAT is 20 to 23, start your EPO.
EPO.
And you give 4 to 6 injections of EPO and then you check the hemoglobin.
Okay.
Okay.
Thank
So do not rush.
Yeah.
You won't get results and you will overtreat.
Yes, sir. Thank you.
Thank you. Thank you.
Thank you, sir. That was an enlightening session and sparked curiosity all over the hall. We'll now break for tea for the next 10 minutes and then we can resume back for a Q&A session for the last 3 talks. The oral paper presentation by residents has been postponed till tomorrow. So we'll be resuming back with the Q&A session for the first 3 talks after the 10 minutes tea break. Thank you. Can we please have the last speaker, chairpersons, on the dais for a photography, please? Dr. Shubhra Neil, sir, Dr. Rajan, sir, and Dr. R.N. Tagore, sir, can we please have you on the dais for a photography session? I request all of you to please settle down on your seats. If you've We will, before furthering to the 12 o'clock session, we have 10 minutes time for any questions, queries, doubts regarding the last 3 sessions. I request all of you to please settle down on your seats.
Moving towards the next session is on the topic unmet need in hemophilia management. I would like to invite chairperson Dr. Nigam Prakash Narain, professor and ex-HOD Department of Pediatrics, PMCH Patna. Dr. Anuradha Singh, Associate Professor, Department of Pediatrics, PMCH Patna. And Dr. Hema Charan, Senior Consultant, Department of Pediatrics, Koji Holy Family Hospital, Patna.
Very good morning. I think all of you have settled down after snacks and coffee. Now, I think I have a proud privilege to invite Dr. S.C. Jha, who is a senior consultant and clinical hematologist associated with Mithila Hematology and Gardner Hospital, Patna. And he is a regular consultant and faculty in this RAKTAVIGYAN. I am seeing right since RAKTAVIGYAN 1. So I invite Dr. S.C. Jha to deal with the topic unmet need in hemophilia management. You want to say something?
I've been associated with Dr. S.C. Jha from long time, and from time to time, sir helps us in many ways. So I would like to invite sir to please come onto the stage and give his deliberation.
Thank you, sir, for a nice introduction. And Dr. N.P. Narayan, sir, was one of the teacher, and I remember those days he was coming to lecture theater 1 with a PowerPoint presentation. It was very unique thing at that time. I was not so communicative, talkative at that time, but that also inspired me how to present the things in front of August gathering. So I would like to, I am obliged to give the opportunity from Dr. Avinash Singh, the organizing secretary of Hemophilia Foundation of Bihar, and we are closely working for welfare of the thalassemia, hemophilia, especially we are talking to each other. So in front of August gathering, I would like to discuss other bleeding disorder that is entirely different from thrombocytopenia, and it is easy to diagnose the hemophilia and like the thrombocytopenia, ITP, and so so evaluation in hemophilia treatment has addressed a variety of patient needs. So it started from 40s and we are standing here in 2025. So it started, we started the treatment of hemophilia from whole blood, then FFP, then cryoprecipitate, and then plasma derived, then recombinant factor, the extended half-life factors, then gene therapy is started, but that is important to discuss or to remember that after factor therapy, other plasma recombinant, era of non-factor therapy has come, and that is a paradigm shift in the management of hemophilia. So unmet needs still remain in people with hemophilia. So what are the unmet needs still in the management of hemophilia? As for the diagnosis concerned, there is no so much unmet needs, but as treatment is concerned, there are so many unmet needs in management of hemophilia. So still we are treating the patient to control the bleeding, to stop the bleeding, or to give some prophylactic treatment to not have the spontaneous bleeding. But this treatment has not given long-term, long-lasting impact in the management of hemophilia on control of bleeding or disability. So there are so many unmet needs, and so the innovation is needed in the field of hemophilia. We are trying to control the pain or swelling, other complication like joint disability in the management of hemophilia. So hemophilia affects both mentally, physically, and as you know, why so much physical disability, so much mental disability in not only in patient of hemophilia, but the family members of hemophilia also affected mentally. So mental ailment affect both the patient and the attendant, but the pain or swellings that patient of hemophilia suffer, that is immense, and I closely involved in the management of hemophilia patient. I so know how they are suffering so much, and we try to give better, best treatment for relief of that pain. So development in inhibitory associated with dramatic decline health quality. So as you know, in the case of hemophilia, there is hemophilia A and B, both are genetical disease transmitted by the female. Females are usually carrier, and sometimes if female also bleed, that is different issue. But during the treatment with the factor, why the unmet need is needed? Because if you are treating the patient with factor, there is always chance of development of inhibitor. Inhibitor is neutralizing in nature. So it make the factor what infused inside the body, the hemophilia patient is neutralized, and it becomes ineffective. So whenever the development of inhibitor, we wonder what should be other treatment that could not have a antibody production. So concept of non-factor therapy came in. Hopefully all the non-factor therapy has no neutralizing antibody, so we have to not to treat those patients with the bypassing agent, and that is a problem with both the plasma-derived recombinant factor VIII therapy. So gap remain in each and domain impacting health-related quality of life in people living with hemophilia. Even mild disease patients have multiple stressors on health-related issue. So, as you know, hemophilia patient has spontaneous bleeding after trivial injury during the surgery, and if the in the course of treatment or bleeding, there is chance of development target joint convert into permanent disability, and then we need the physiotherapy, sometimes surgery. Those complications must be stopped with the proper drug treatment. So how it could be possible with the new innovation? Even with access to improved therapy in hemophilia, unmet burden school and work performance persists naturally, very natural. Current therapy of hemophilia may be associated with high burden of preparation, administration, impacting adherence. Till now, we are treating the hemophilia patient IV infusion. It is a lyophilized powder. We have to mix the powder with distilled water, then we have to infuse, and the venous access is a problem, especially in the pediatric patient group. So new drugs are needed. So factor and non-factor therapy still present a treatment burden for living with hemophilia, and so even with the newer subcutaneous therapy, unmet burden preparation administration persists. So now we are in era of non-factor therapy as far as maintenance therapy, a prophylactic therapy of hemophilia is concerned. Even during the surgery, major accident, you have to treat the patient with factor. Sometimes you have to give FFP, cryopreservation, but our purpose to treat with non-factor drug is to maintain a trough level, so the patient could not have the spontaneous, patient could participate in a routine physiotherapy and rehabilitation program, and that physiotherapy they could not have a bleed. If you are not patient of prophylactic therapy, there is always chance of bleeding during the physiotherapy or walking or some sort of sport participation. Importance of home therapy. So in Bihar, patients are coming for each and every, perhaps there are 38 districts in state of Bihar, and they are coming to our center in Patna, especially in Gardiner Hospital, also in PMCI, to have an infusion. So they have a loss of job, there is a loss of time, and there are logistic problems that could be addressed with the home therapy. Home therapy is a solution. Patient could be given the drug, and we will track the track the subcutaneous dosing of drug through the mobile, through WhatsApp. This could be possible in the era of modern technology. So barrier to home therapy in India, storage, concern, supply, injection techniques, logistic, technical expertise, motivation, advocacy, policy, inertia, lack of awareness. So if you are planning home therapy for hemophilia patient, so there are so many issues. There is lack of fridge in each and every house, and most of the patients are poor ones. So in that situation, how this situation could be addressed with the new drug, a new drug delivery system. So people with hemophilia still experience an unresolved burden of both the disease and treatment, and unmet needs remain. Several unmet needs still exist for people with hemophilia. They aspire for adequate bleed protection, improved joint health, reduce physical burden, and enhance physical activity, improve quality of life, reduce burden of preparation, administration, and treatment, reduce impact on school, work, and performance. So way forward So how to address all these problems? So, innovation through newer drugs, mechanism of ongoing research and developing hemophilia treatment aim to enhance patient quality of life. So how this quality of life could be? The mode of action is very important. If pharmacological aspect of the drug, you should know to have a basic concept how these new non-factor drugs work in management of hemophilia. So initiation, As you know, there is two pathway, intrinsic, extrinsic pathway. In intrinsic pathway, factor 8 and 9 deficiency, there is hemophilia or NB. So this balance is disturbed. So we have to rebalance the things with the bypassing agent. So especially bypassing agent in the case of hemophilia with inhibitor, or we have to replace the factor 8, 9 if the patient has not developed inhibitor with the factor 8, 9 replacement. So these are the initiation phase, tissue factor expressing cell. You know that in one other pathway is extrinsic pathway. Extrinsic pathway, that is endothelial injury, or you know endothelial cell, endothelial wall, endothelial injury, and the phospholipid surface is exposed. There is a accumulation of platelet. So coagulation cascade starts. So if the intrinsic pathway is disturbed, imbalance, so how to balance the normal hemostasis with the non-factor therapy? This is concept behind using the new drugs. So then there is a phase of propagation, and then there is ultimately clot formation. So a balance between procoagulant and anticoagulant underpins hemostasis. As you know, in our body there is check and balance between hemostasis and bleeding. And as you know, the factor is involved in having proper hemostasis, and other is other molecule that try to have try to thin out the blood, the thinning of blood. So once there is a procoagulant that try to have a proper hemostasis, other is molecule that have to not have excessive hemostasis, so that patient could not develop thrombosis. As you know, in the case of hemophilia A and B, factor 8, 9 deficiency exists. So the anti-hemostatic factors are still working properly. So there is a chance of bleeding. So balance between procoagulant and anticoagulant underpin hemostasis. So how to balance those things? In the case of hemophilia A, there is deficiency of factor 8 and 9, but the other TFPI or antithrombin, APC, SC, second PNI or ZPI are normally functioning. So balance is in favor of not having proper thrombosis. So there is a chance of bleeding. So RNA interferon therapy blocking antithrombin synthesis. So one of the end product is thrombin and fibrin, fibrinogen, then fibrin, and factor 13 working as a clot stabilizing factor. So in this case, if you are trying to have any molecule that inhibit the anti-thrombin 3, so that anti-thrombin C have opportunity to have the build-up of thrombin, and this is one of the mechanism that we have a proper thrombosis in the case of factor 8, 9 deficiency. TFI is novel target anti-hemophilia therapy, and there is a various Kunis type 1, 2, 3. So 1, 2, 3 is very effective, and there is a mode of action, and that mode of action they are working to neutralize tissue factor inhibitor. So like antithrombin 3, there is tissue factor inhibitor generation in extrinsic pathway that hamper the extrinsic pathway, coagulation pathway. So we try to have a thrombin burst through the extrinsic pathway. If the extrinsic pathway is augmented with the new drug, you have a proper hemostasis in the absence of weak intrinsic pathway. So the TFI is a potent regulator normal coagulation pathway. This is a photograph by which you could know how these drugs are working. So thrombin generation impaired in hemophilia, all you know, and inhibition TFI restore thrombin generation, tissue factor, factor 7, factor 9, despite factor 8, 9 deficiency. So how have you reached the end of innovation factor 8 mimetics? So optimization, the process engineering change in the structure of therapeutic antibody with the purpose of enhancing their safety, efficacy, and developing Wang B et al. Presentation to 2021. How does optimization of factor mimetics looks like? So we have also opportunity to have a new drug that behave like factor 8. So one drug is emicizumab that work on factor 9 also, factor 10 also. So these bispecific antibody also effective. So further innovation, mimetic, full optimization possible, rational concept behind full optimization, cofactor activity, affinity. So what is the concept behind have a good drug? We have to know non-specific binding. We have more specific binding, targeted binding with the proper heptane involvement. So rational concept behind full optimization, due to lack of time, we could not go in detail. Viral factor for gene transfer is possible, and especially in adeno-associated virus, because this virus is not existing in our body or not affected, so there is no antibody formation against adeno-associated virus. So this virus vector is very effective in gene transfer and correction of the in hepatocyte, that gene like in hemophilia A or B. While gene therapy offers the prospect of functional cure for some patients, limitation question remains. So innovation through drug delivery system. So their role of device in improved treatment adherence, despite have some improved quality of pen injector, easy to train, inject preferred by the patient. As a pen injector, easy to train, inject preferred by the patient. Time to change the treatment goal. So consumab is anti-TFI monoclonal antibody guidelines for managing mild to moderate or breakthrough bleed during Explorer 7 with consumab is proven that is very effective. It prevents the bleeding more than 92% of cases, spontaneous bleeding. So it is time to discuss. Presentation very easy. We have slides. So we have slides sometimes provided, but clinical experience, hands-on experience very important. In the case of consumab, and the other drug is emicizumab. Emicizumab already used in India, and it is there has a paradigm shift in the management of hemophilia with the availability of emicizumab bispecific antibody. It is useful in hemophilia A. Without inhibitor, and is a bispecific, it activate factor 9 and 10 simultaneously. So it's a very good drug. But what is the problem with emicizumab? Emicizumab is different from consumab, because in consumab, consumab affect the extrinsic pathway, emicizumab affect the intrinsic pathway. Two differences. Other differences, both are given subcutaneously, but consumab have a low half-life. You have to give on daily basis subcutaneous, but it comes in pen. You have to load the drug every day, but in emicizumab, you have to prepare the drug every day. We have to give but as per the duration of treatment, we have to give the consumab on daily basis. Emicizumab we have to give after loading to fortnightly or possibly the monthly. So there are so much differences. But good part of the consumab, it could be used in all type of hemophilia. Hemophilia A, B without inhibitor. But emicizumab has a limitation in hemophilia A because it needs factor 9 availability. So if the factor 9 is not available, then in that case you can't use. So it is a drug of hemophilia A or B inhibitor, but not in all hemophilia. But consumab use all type of hemophilia. So it is a time to have a very good discussion.
Thank you,
with
sir,
the help of
for
chairperson, I completed my presentation in before.
Thank you, sir, for a very elaborate talk on hemophilia. And this hemophilia, as we all know initially, it was only the clotting factors as you discussed so properly. And with your talk, we have been enlightened with the various monoclonal antibodies which are now available for the treatment with hemophilia patients, which can be taken even at home, need not go to the hospital, besides the cryo that we are already using in emergency cases. Besides this, some unmet needs like physiotherapy when the joint is involved, how to mobilize the joint, how to, as you said, mental anxiety, depression, sleep deprivation, all these are prevailing in the family members also in cases of hemophilia. We need to cater to those needs also besides the vigorous treatment.
Madam, if you put patient in non-factor therapy, emicizumab or consumab, you have opportunity to have better physical therapy or physiotherapy, because at the time of physiotherapy, you could not have a spontaneous bleeding. If the patient is on demand therapy, there is always chance of a spontaneous bleeding or joint bleed at the time of physiotherapy. So physiotherapists or Department of Physical Medicine rehabilitators are very fearful that there is always chance of bleeding. So if the patient is prophylaxis, these things could be addressed. We have a better chance of physiotherapy rehabilitation program and the pain, and patient could have a disability free. And with the home therapy, mental stress of the patient could be dramatically could be decreased.
Thank you, sir. Audiences, any questions?
I think as a generalist, we have found this a scholarly talk by you very interesting. And actually, I think the new vista of this gene therapy and this monoclonal antibodies, they have really created a very good revolution in the new treatment. And certainly your replacement therapy has got their own status, where you can protect the joints much better. So I think these three things are very, very important, as you said. And I invite any questions from the floor, if you want.
Sir, one question I have. Sir, can monoclonal antibodies be given to a bleeding patient?
If the patient is coming to you with active bleeding, acute bleeding, you have to treat the patient accordingly with factor replacement or if the inhibitor with bypassing agent. And once the active bleeding stops, because it is a drug of active, it is a prophylactic treatment, maintenance treatment.
Message is that it cannot be given during active bleeding.
No.
It is used as prophylaxis.
Prophylactic.
So I wanted to give this message to the audience.
During prophylactic period, it works very wonderfully, and patient has very good quality of life and participate in all the normal.
Patient can take himself.
Yes.
Yes, sir.
Subcutaneous.
So any question from the audience?
Especially consumab could be taken because it is pain, but in emicizumab, pain is not, there is some preparation, not preparation, but have to draw the from vial in injection, they have to put the injection, but it could be both could be taken at home. That is a good thing.
Thank you. Any
for
question
the
from the audience?
Thank
you. Thank you, sir, for such an insightful talk. I would request speaker and chairperson for a quick moment of photograph together on the stage, please. Thank you, sir and ma'am. Moving towards the next session is thalassemia management in 2025. For this, I would like to invite the chairperson, Dr. Bhupen Narayan, Professor and Head Department of Pediatrics, PMCH Patna, Dr. Hemant Kumar, Professor, Department of Pediatrics, PMCH Patna, and Dr. Shambhavi Sharan, Assistant Professor, Department of Pediatrics, IGMS Patna.
Good afternoon, everyone. I would like to introduce our speaker for this session. He is Dr. Vikas Dua, who is the Principal Director and Head of the Pediatric Hematology and Oncology, along with bone marrow transplant. He was the best outgoing fellow in FNB of Gangaram Hospital, And he and his team have performed more than 1,000 bone marrow transplants, especially in pediatric age group. And he will be talking about thalassemia and its management in 2025. Vikas Dua sir, please come on.
Thank you, madam, for the kind introduction. And at the outset, would like to thank Avinash for inviting me and having me here. And what I understand is that majority of the people who are sitting over here are from medicine or pediatrics background, because all the chairpersons are from pediatric background. So how many of you are from pediatric background before I start? Okay, and what about medicine people? Okay, and very few must be hematologists or hematopathologists. So I'll try to keep it very, very simple. We all know what thalassemia is. India is the thalassemia capital of the world. I don't know how many of you know that, but India is the thalassemia capital of the world. Maximum number of thalassemics are born in this country, and we know that it is a mutation in the beta globin gene. It's a significant burden worldwide, with around 60,000 children are born with thalassemia in the whole world, and out of that 1/6 are born in our country. High morbidity because of anemia, iron overload, and because of that some people may have early deaths as well. We all know the life of a thalassemic. A thalassemic is in and out from the age of 6 months for blood transfusion. Every month the patient requires blood transfusion, and once you are on blood transfusion, you get 126 milligram of elemental iron, you get iron overloaded, you need to be on chelators. It is preventable. So it's an autosomal recessive disorder. If two carriers, you call it carriers, you call it trait, you call it minor, two carriers get married, there's a 25% chance that the parents may produce a thalassemia major baby. So that means the family is at 25% risk every time. That doesn't mean that if at the first pregnancy you are unlucky, you have a thalassemic baby, next 3 pregnancies will be fine. In each and every pregnancy, there would be a 25% chance of producing a thalassemia major baby if the parents are carriers. Lifelong transfusion dependence, there is no passive excretory mechanism for iron. This iron gets accumulated in the liver, in the heart, in the endocrine glands. The patient are short-statured, have got hypothyroidism, hypopituitarism, they may have diabetes, they may have cirrhosis, cardiomyopathy, and cardiac failure is the most common cause of death for these unlucky kids. The treatment options. Let's talk about the treatment options which are available previously and what are available now. So one is the conventional track. The patient gets blood transfusion, 15 to 20 ml per kg of blood, and once your ferritin is more than 1000, you need to be on iron chelators. We all are aware that there are 3 common types of iron chelators which are available. And when we talk about a one-time solution is bone marrow transplant. I'll talk about transplant in detail because that's the area of interest which I have. There are certain pharmacological inducers which induces HbF, like hydroxyurea, which can decrease the chances of blood transfusion. There are newer medicines which are available in this country. I'll talk about that as well. And if somebody is born in US, he can have an access to gene therapy. There are 2 FDA-approved gene therapies which are there for thalassemia. We'll discuss that as well. So let's talk about the 2 common modalities in this country. Conventional track, getting blood transfusion, or going for a one-time solution transplant. Risk and benefit of both. Now, with improvement in supportive care, better supportive transfusion strategies, good iron chelators available, we have got endocrinologists, good endocrinologists, well-trained endocrinologists in this country. Even if you are on a conventional track, still you can have a reasonable, okay quality of life. I would not say a fantastic quality of life, but okay quality of life. And then, because of this supportive system, there is decreased mortality and morbidity. When we talk about a one-time solution, we have improvement in transplants, we have got high-resolution HLA typing available in this country, we have got concept of newer conditionings. Previously, we used to talk about just myeloablation, but now you have conditioning regimens, you have medicines which are ablative but reduce toxicity regimens. We can, with the help of PCRs, we can monitor the viral infections, we have good antibiotics, antifungals available, and we have now better understanding of the impact of iron toxicity. So it is very important when you take somebody for transplant to chelate. You need to bring the iron low. If you are able to bring the iron low, you have better outcomes. Still I would say we lose patients. We lose 5 to 10% patients because of transplant-related mortality. You may have GVHD. A benign disorder patient like thalassemia may have GVHD, graft versus host disease, may have rash over the body, pathetic loose motions, jaundice. And then last but not the least, even if you are using the reduced toxicity regimens like a triosulfan based conditioning, still there is a concern of infertility. That doesn't mean impotence, but you can be infertile with a transplant. Looking at the life expectancy, this was a study which was conducted in southern part of India, in which they collected data of over 1,000 patients from 5 different thalassemia centers, and what they found is that roughly 50% patients don't cross age of 25 years. So if somebody is on a conventional track and not getting a proper therapy in the form of good iron chelators, not being monitored, is getting a non-NAT tested blood, then 25% I would say 50% people die before the age of 25. Whereas in UK, 33% survival at the age of 45. This publication from Italy looked at the long-term survival of beta thalassemia major patients treated with transplant compared with conventional, which transfusion. So they concluded that the 30-year survival of an ex-thalassemia after transplant was similar to that expected with somebody on conventional track, but they put a question mark, what about the quality of life? Transplant, a one-time solution. Getting admitted for 3 weeks, getting conditioning, in 2 weeks you have a neutrophil engraftment, you go out of the hospital, you come on a weekly basis for follow-ups, and then after 1 year your immune system is healthy and you live a normal life. Whereas a patient on conventional track, every month has to go to the hospital. It is not just one patient in the family, the whole family has become a group of patients. The dad has to leave work, mother has to leave the household work, and they have to go to a transfusion center and need for the need of a blood transfusion. What is transplant? Hematopoietic, previously we used to call it bone marrow transplant because we had to collect the stem cells from the bone marrow. But the correct term is hematopoietic stem cell transplant. You can collect the stem cells either from bone marrow or blood or from when a newborn baby is born from the umbilical cord. The first successful transplant for thalassemia was performed by this chap, Dr. Thomas, and this was a publication in Lancet in 1982. So the first successful transplant for thalassemia was performed by Dr. Thomas, and he got a Nobel Prize for his work in 1990. The beauty of that transplant, which was performed in 1981, that boy who was transplanted in Seattle is still alive. It's been more than, I would say, 45 years. The boy is still alive, doing well, transfusion independent. So that's the beauty of transplant. What I just said, sources of stem cells. You can collect the stem cells from the bone marrow. The donors goes to the operation theater. You collect stem cells from the posterior superior iliac spine. You can collect the stem cells from the blood. GCSF, 5 days under the skin, and in the blood bank you can collect the stem cells. Cord blood is another source. 2 types of transplant: autologous, in which the patient himself is donor, which is not applicable in thalassemia. This is for other conditions like solid tumors, myeloma. For thalassemia, you need a donor. You need a healthy donor. And who's the best donor? The best donor is the brother or sister who's fully matching to you on a test called HLA. There's a 25 to 30% chance that you may have a full match donor in the family. But if you don't have a full match donor in the family, then you can search the donor from outside the family. There are registries. The biggest registry in the world is in Germany called DKMS. Second biggest registry is in US, NMDP. We have our own registry, our own database in Chennai. There's a registry called Datri from where you may get a donor. In case you don't have a full match donor in the family or outside the family, still you can get a transplant done, and that's called a half match or a haploidentical transplant, because we all know the fact that any patient's 50% genes comes from father and 50% genes comes from mother. So parents are usually not fully matching unless and until there is a history of consanguinity. So you can do a half match transplant for these patients. There is a probability, 40% probability of getting a full match donor from an unrelated registry for somebody of Asian origin. So 25% chance that you may get a donor from the family. There's a 40% chance that you may get a donor from outside the family, but there will be still 40-50% patients who don't have a full match donor in the family or outside the family. Or for them, there is a need, or you can do a half match transplant. These are certain registries I was talking about. With a match sibling or an unrelated donor transplant, thalassemia survival, which have been reported, are around 75 to 80%. And if you look at the Indian Stem Cell Registry indications for transplant, So this is an old, I would say, pie chart, 2016. The point I would like to highlight is that for allogenic transplants, 25% transplants are for thalassemia. I just said India is the thalassemia capital of the world. So you do quite a number of transplants in this country. The history of thalassemia transplant started from Pesaro, and this publication came long back from Italy, in which they reported a thalassemia free survival of around 1,000 patients of to close to 73%. It is important to do risk stratification. You need to do risk stratification, which is called Pesaro scoring. So based on hepatomegaly, how well you are chelated, and portal fibrosis, you divide these patients into class 1, class 2, and class 3. Somebody who is well chelated, doesn't have fibrosis in the liver, doesn't have a big liver, they are class 1. Somebody has got all three are class 3, and if you are in between, then you are class 2. The point I would like to highlight is sooner the better. It is important for all the pediatricians, physicians, and people sitting in this forum to understand that it is advisable for them to refer the patient early for a transplant. And now, there was a time हम लोग इंडिया में बोलते थे पैसा नहीं है, हमारे पास ट्रांसप्लांट के लिए पैसा नहीं है, 15 से 20 लाख रुपए एक प्राइवेट सेक्टर में लग जाता है, पैसा कहाँ से आएगा? So the answer to that is there are centers like ours where you get funding. Coal India through their CSR fund gives 10 lakh rupees per thal patient, provided you are less than 12 years of age, your annual income is less, the family annual income is less than 8 lakh rupees. So 10 lakh rupees through Coal India, 3 lakh rupees from Pradhan Mantri Rahat Kosh, then through some German NGOs we get a lot of funding. So practically transplant is free for somebody who comes to us from Bihar. If you send a patient to me who is less than 12 years of age and the annual income of the family is less than 8 lakhs, I can do the transplant free for that patient, provided that patient has got thalassemia and the family has got will. So these are certain indications and management recommendation. I'm not going to go in detail. This is a new stratification strategy for the class 3. Somebody who is class 3, who has got fibrosis in the liver, who has got big liver, not been chelated well, and they have divided, Vikram Matthews group from CMC has divided these two patients into class 3, high risk and low risk. If they have a big liver, more than 5 centimeters, and the age is more than 7, then the outcomes are even inferior. So that's why I again say, if you want to refer somebody, if you want to do a service to a society, please refer them early for transplant. Triosulfan, previously we used to use busulfan, cyclophosphamide based conditioning, but triosulfan is new kid on the block because less chances of VOD, veno-occlusive disease with this medicine. And publications of thiotepar, triosulfan, fludarabine based conditioning, all hematologists are very much familiar with. Whether you talk about a full match donor transplant or a a full matched sibling donor transplant or a match unrelated donor transplant, the outcomes survival is more than 80 to 90%. Then haplo. There are two ways of doing a haplo. I was talking about half match transplant. So when you take father or mother's donor, I give you an example. You have a 5-year-old thalassemic who doesn't have a full match in the family or outside the family, and you want to do a haplo transplant. Then there are two ways, because there are T cells. The father and the mother are not fully matching to the patient, so there would be a high chance of GVHD. So you want to avoid that GVHD. How you can do that? There are two ways. Either you manipulate the stem cells outside the body. That's called T cell depletion. You take out the stem cells from the donor, subject the stem cells to a machine which can deplete, which can do a positive selection, which will just select the CD34 cells and get rid of the bad cells. That's one way. Now we have better techniques, because it is equally important for the body to have NK cells, dendritic cells from the donor. So what you can do is, you can selectively deplete the T alpha beta cells. If you recall your physiology days, T cells are of two types, alpha beta and gamma delta cells. Alpha beta are the culprit cells which cause GVHD. Gamma delta are good cells. So you can selectively deplete the T alpha beta cells and infuse rest of the product, and that would cause decrease the chance of GVHD. If somebody is not able to afford that, then there's another way. That's called T cell repleted transplant. After giving stem cell infusion on day 3, day 4 post transplant, you can give this drug which all of us are very much familiar with, cyclophosphamide. If cyclophosphamide given on day 3, day 4 post transplant, there would be less chances of GVHD, because this is going to attack the alloreactive T cells. There are pros and cons of a haploidentical transplant. These two techniques I was talking about. the John Hopkins way, which is a post-transplant cyclophosphamide-based conditioning, or the German way of removing the T cells. It's very important to counsel these families. When you're talking about a benign disorder transplant, mortality acceptance is very poor. So it's very important to counsel these families in detail that yes, we can lose 5 to 10% patients, even if we are going for a full match or a match sibling donor transplant. The immune system is very smart in benign disorders. There are more chances of anti-HLA antibodies because these thalassemics are being transfusion dependent and they're getting blood from different people. So there are more chances of having anti-HLA antibodies and more chance of rejection. They have iron in the liver, iron in the heart, so more chances of mortality. So it's better, I would say it is important for us or any transplant physician to counsel these families in detail. The overall survival with haplotransplant in different studies have approached 90 to 100%. So even with a haplotransplant, you can achieve fantastic outcome provided it has been done in a center which is doing quite a number of match sibling, quite a number of unrelated, and have an experience of doing haplos as well. I'm not going to go into a detail because this is more relevant to hematologists. These publications are very specific. If you're talking about a haploidentical transplant which is a PTCY, post-transplant cyclophosphamide-based conditioning regimen, then this is one of the commonest regimen what we I would say majority of centers in India follow. You give post-transplant, you give pre-transplant immunosuppression. You give fludarabine, dexamethasone 2 cycles, and then depending upon the regimen of your choice, you give conditioning and then you infuse the stem cells. And we have publications from India as well. We have a publication from Chennai from Dr. Revati Raj group in which they used a similar conditioning of 2 cycles of pre-transplant immunosuppression followed by thiotepa, fludarabine, rabbit ATG and cyclophosphamide-based conditioning with PTCY and tacrolimus as GVHD prophylaxis, and they reported a 75% OS, 75% thalassemia-free survival and a OS of 100%. So encouraging outcomes. If you look at the ICMR guideline says if you have a match sibling donor for thalassemic, it's a standard of care. Whereas if you have a MUD or a haplo donor, it can be a clinical option. So that means even ICMR, EBMT and American Society all say that if you don't have a full match donor in the family, which is still the standard of care, you can do a half match or a unrelated donor transplant. Coming to certain other newer things, so gene therapy. If somebody is born in US, he can have access to gene therapy. So what is gene therapy? You have a defective beta globin chain. So you can take out the stem cells from the patient's body and you can rectify, you can edit the beta chain. So there are 2 I would say gene therapies which are approved by FDA. One was approved in August 2021 and the second one is been recently approved in January 2024 as a treatment option for thalassemia. There are certain limitations because these patients have to be subjected to a busulfan based conditioning, so there are chances of infertility with a gene therapy as well. There are 2 case reports of AML developing in patients of sickle cell anemia who were treated with gene therapy, but not even a single patient has developed AML or MDS. A THAL patient has developed that. So, but yes, we have to keep that in mind. But that is an option. Somebody born in US has got access to gene therapy, access to haplotransplant. Somebody young goes for a I would say match sibling or unrelated donor transplant. Somebody who has crossed 20, 21 years of age, you feel that he's iron overloaded, would not tolerate a transplant, gene therapy is an option. There is a medicine called luspatercept. Luspatercept is a subcutaneous injection given every 3 weeks, FDA approved, available in this country, and can decrease the transfusion requirement, and for very few patients it can make you transfusion independent as well. But the flip is that it's an expensive injection. Every 3 weeks you have to go to the hospital and get this injection done, and theoretically there is a bleak chance of thromboembolism with this. There are quite a number of novel medicines for thalassemia which are in phase 2 and phase 3 trial. I'm not going to go into the detail of that. Just like to conclude by saying that somebody who is born with thalassemia, try to give them a one-time solution. A one-time solution in this country is just one thing, which is transplant. Government of India, Pradhan Mantri Rahat Kosh, Coal India CSR funding is helping these patients to get rid of the financial issues. So the only thing left with the family is the will. If somebody has a will to go for a transplant, there are centers which can do transplant for free. If somebody is of adult age or adolescent age, has got a lot of iron related issues, then still you have in this country injections like luspatercept. You can try hydroxyurea, thalidomide, and there are new medicines which are in phase 3 trial which will be out very soon, which are showing encouraging results, and you can still lead a reasonably okay life. I would like to lastly conclude by saying that should all modalities be available, if you have in India transplant, if you have in India gene therapy, you have access to these fancy new medicines, a patient-centered approach should be pursued. With that, I would like to thank you all for a patient hearing. Thank you very much.
Thank you, sir, for enlightening us, particularly on stem cell therapy, but which are much lagging behind in modern therapy, either in gene therapy, gene editing, or gene addition. And still regarding stem cell, still cord blood banking is still coming to place in our place. So cord blood banking is also seeing a remote possibility at present time.
सर हमने कॉर्ड ब्लड बैंकिंग के बारे में मैंने एक भी बात नहीं करी. उसका रीजन यही है.
Scenario in the resource limited setting, why not we are accepting hydroxyurea like sickle cell disease? It is well accepted. Why we are not accepting hydroxyurea, which is easily available in thalassemia patients? What is your view on this?
So hydroxyurea can be tried. I am not against hydroxyurea. Hydroxyurea people are using. There are quite a number of people who are using hydroxyurea, especially for intermediate patients. It has helped quite a number of patients in decreasing the chances of transfusion by increasing the hemoglobin by 1 to 1.5 gram. It can work, but the flip is that sometimes it can cause myelosuppression. So that's why you need to monitor these patients, because if your ANC is less than 1000 or your platelet count is less than 80,000, you need to immediately stop hydroxyurea for these patients. And in case a patient develops fever, he has to rush to the hospital, he has to get a CBC done. In case he or she is neutropenic, a culture is to be taken and IV antibiotics to be started.
Thank you, Dr. Dua, for your nice deliberation. And I think our Bihari patient will be benefited from your Dua, as you have explained that 10 lakhs by the Coal India and 3 lakhs by Prime Minister Fund and 2 lakhs managed by your local bodies. So we are very much thankful for this information and your nice deliberation. Thank you.
Thank you, sir.
Just I want one message that we must bang on the antenatal detection of thalassemia patient. It must be routinely advocated for this, and antenatal non-invasive parental test or antenatal screening. You must go in a large way for this.
Absolutely.
This will be a great message to be.
Absolutely. We all know the fact that prevention is better than the cure. So if you cannot stop two loved ones from getting married, if two carriers are getting married, at least before conception, it is better to get the thalassemia status check. If they have already got married and the mother has conceived, then between 8 to 10 weeks of pregnancy, you can do CVS, you can do chorionic villus sampling, and you can come to know the status of the fetus. In case you are unlucky, you are in those 25% who, if in case you are among those 25% and you are carrying a thalassemia major fetus, then the government says and the law says you can go ahead and you can do the abortion. Thank you, sir.
Thank you, sir, for such a valuable and informative talk. I request speaker and chairperson to have a quick photo session together. Thank you, sir, ma'am. Next, we are having a panel discussion on blood component therapy. For this, I would like to invite Dr. Tufan Kanti Dolai, sir. He is a professor and head of Department of Hematology, NRS Medical College and Hospital, Kolkata. He is an alumni of Calcutta University and completed his MBBS, MD, DNB, and DM in clinical hematology. He has more than 100 publications in national and international journal and having association with many clinical trials as co and principal investigator. So kindly come on the dais.
So thank you very much for this introduction, and I like to thank the RAKTAVIGYAN 7, especially Dr. Avinash Singh, and also the team of the Hematology Foundation of the Bihar for the wonderful lectures and the CMEs under the different lectureship program. And the more important is the energy of Dr. Avinash. Avinash single-handedly did this program for the last 7 years. So lot of things has to be learned from Dr. Avinash. So please give a big round of applause for the Dr. Avinash and the team. So with this, I am begin with this important session of the blood component therapy. You know, without blood we are nowhere. So the blood has become very, very important to, without wasting time, this panel discussion. So may I call my panelist, the esteemed panelist, Dr. Shailesh Kumar is the Assistant Professor, Department of the Transfusion Medicine, IGI MS Patna. Please come. Dr. Shailesh Kumar. Dr. Bonkim Das is the Head, Department of the Transfusion Medicine, AIMS Patna. Dr. Neha Singh, the Assistant Professor, Department of the Transfusion Medicine, AIMS Patna. Dr. Rakesh Kumar, the Assistant Professor, Department of the Transfusion Medicine, the AIMS Patna. And Dr. S. Srivastav, the Consultant Transfusion Medicine, Patna, Medanto Patna. There is a chair here also, you can come. There is a chair here also. 1 to 2% can come this place. There is a chair is there. You can sit here also. नहीं आप इधर ठीक था, उधर थोड़ा रिक्स हो जाएंगे, इधर ठीक था। अच्छा ठीक है, हाँ हाँ, there are 6 people is there. So can I begin? Yes, yes. So thank you very much, everybody. So I'll begin with this, the blood component therapy. You know the history of the blood component. In the very ancient era, the people are giving this blood from one people to the other like the movies. When we see the movies in the very 80s and the 90s, blood from the one person to be given to the another person, from the hero to the heroine. But this is not true in the blood component therapy. Gradually, by the discovery of the 1910, the fellow have been discovered, the ABO blood system, and got Nobel Prize in 1930. That is called the Karl Landsteiner. He is a good fellow for do these things. And the important thing is that none of the blood product is safe. You have to remember that in a single unit, they have a risk of your lot of the problem is there. Because without risk, nothing is there. So I am begin with a transfusion reaction, because you first know the problem of the transfusion, then how to give the blood, that has to be keeping in the mind. So my question to the panel is the types of the transfusion reaction. Anybody can start from the, anybody can take this question, that what are the different types of transfusion reaction you came across in day-to-day clinical practice. Anybody can take the question and give the expert opinion.
Okay, thank you. Thank you, Avinash sir, giving us the opportunity to speak on being a panelist for this important topic of blood component therapy. So coming to transfusion reactions, we define it as a immunological causes and non-immunological causes. Once we define it as a immunological causes, it can be a immediate or acute type and delayed transfusion reactions. Where we are going for non-immunological causes, most important is your transfusion transmitted infections that we look into it. And if you go for the classifications as clearly outlined here, is that most common that we are afraid of for immunological causes is hemolytic transfusion reactions. That is the thing.
Yes, thank you. Thank you very much. He have been given very briefly the important aspect of the transfusion. So we can encounter the acute and the delayed transfusion reaction. So what are the acute transfusion reaction which came across in day-to-day clinical practice? Acute transfusion reactions.
Hello. Sir, good morning. Thank you so much for addressing us. Thank you to Dr. Avinash. Sir, so most commonly the acute reactions that we are scared of is either hemolytic, where we are suspecting maybe a wrong group has been, or an incompatible group has been transfused to the patient. Otherwise, acutely, the most common ones are febrile, immediately, or allergic. These are the other very common acute reactions. And of course, then there is Trali, which in my setup, which is Medanta, we've suspected 2 of them. And then there is a shortcoming there because we are not able to do the HLA match of the donors.
Right,
and
absolutely.
So otherwise, sir, the common ones are these only.
So the allergic reaction is very, very common, but you should not forget the rare thing, the Trali, which is the devastating complication. In terms of the delayed transfusion reaction, what are the common delayed transfusion reaction we seen in day-to-day clinical practice?
If you go for the definition of the delayed transfusion reactions, any reactions which is not noticed after 24 hours account for the delayed transfusion reactions. But we perceive the criteria, what are the patient symptoms we are seeing into the patients. If we go for the delayed transfusion reactions, there is a most commonest graft versus host disease reactions, post-transfusion purpura, delayed hemolytic reaction, these kind of the transfusion reactions which can happen up to 24, up to the many years. So if we are transfusing any blood to the recipient, we will be say that if first 4 hours is completely go well, we will account after 24 hours, still patient is deteriorating or not. We have to consider every aspect so we can further proceed towards the delayed transfusion reactions.
Right, absolutely. So in terms of the different viral reactions, a lot of the viral reaction is worried about related to the transfusion. So what are the common viral reactions usually seen in day-to-day clinical practice?
See, mandatory test we are screening for viral infection is HIV 1 and 2, hepatitis B and C in India. But other viral infection can be transmitted like dengue, chikungunya, cytomegalovirus can be transmitted. But mandatory in India as per Drug Cosmetic Act, 3 screening is mandatory. And prevalence in India is least prevalence for hepatitis C, hepatitis B more 2 to 4%, and HIV 1 to 1.5. This is as per national, and at IGIMS we are getting the same prevalence.
Right, absolutely. So in terms of the viral infection, the more component is that what technique you are using to screen for hepatitis B, hepatitis C and the HIV, because you have to use the more sensitive ELISA technique. Ideally you should do the ECLI technique to find out the each donor, they do not have any hepatitis B, C and the HIV infections. So if we consider the transfusion reaction, the fatal reaction incidence in 1 in 0.6 to 2.3 million. If we go to the right chart, they have been clearly written in terms of the common reaction is the mild allergic reactions, then febrile hemolytic transfusion reaction. Sometimes you can have a in terms of the fluid overload, that is called the TACO, that can be there if we give excessive blood to the patient in a short interval of the time. So there is a lot of reaction is there that has to be keeping in the mind. That's why in the Dr. Louis Diamond 1965 clearly said that the blood is often wastefully, improperly and dangerously. Because everything is become dangerous, so you should be keeping in the mind that the blood is not safe. That's why you have to be used judiciously. The important thing is that the blood component has to be used judiciously, whether you have an indication for transfusion, whether you have any benefit for giving the transfusion, that has to be keeping in the mind, and the blood has to be used rationally, because the blood is not available in any shop. That has to be there. So economically, a lot of the things is there in terms of the blood, and nowadays the component preparations, there is some improvement of the component preparation across the country, but still there is a few centers they are doing the component preparation, and majority of the cases they are the whole blood, and there is a problem of the infection we have been already discussed. And the more important thing is that if the anemia is corrected by some measures, don't give the blood transfusion. If your requirement of the blood transfusion 1 and 2 unit, don't give it. You try to give with the other injection, lot of the injection, particularly the people receiving the iron injection therapy for correcting the anemia, the vitamin B12 injection for correcting the vitamin B12. So you should give that therapy rather than giving the blood. If the patient requires the 1 to 2 unit of the blood, means there is no requirement of the blood, you should manage with the other things of this patient. That's why the blood has to be used rationally, the right product, right dose, right time, and the right reason has to be used to save the life of the people. In terms of the blood component, there is a concept that the whole blood component is there, but nowadays we are moving for the last 10 years that the component therapy. So what are the different components we can prepare in your blood bank for a single donation?
Sir, as you usually told the 3 component, but some different were 4 component, because of if prepare first packed RBC, FFP, fresh frozen plasma, and platelet concentrate, but any facility your center have you prepare the cryoprecipitate, then one donation can prepare the 4 component.
Absolutely.
Packed RBC, FFP, platelet concentrate, and cryoprecipitate.
Absolutely. So we have to, so single donation can save your full life. So this is our caption to the general people awareness that single donation, full life can be saved. That is the very, very important thing is that, and depending upon that, we can keep the blood in the different unit, and we can keep it in the different temperature. And another important thing is that in terms of the clinician, because sometimes we require the blood immediately, sometimes we require the blood in a planned way in the different surgery. So what are the minimum time required for the cross matching?
Cross matching, it depends what in the form what we ask for. We ask for if you are asking for within minutes or immediate, or if you have some time, then it depends. For example, if you're going for a minute, it is usually happens in urgent cases or emergency in trauma cases where we do not have a time. It is the primary objective is to save the life of the patient. In that case, we ask for a sample and ask for a consent, and that you just give us a consent, then we give them a O pack cells. Negative or positive, it depends upon the stock you have. And you just mentioned, the blood center mentions that is uncross-matched blood that has been issued. Yes, you keep a segment of it. Let the once the blood has been issued, and you have received the patient sample, and you perform the cross-match, you complete it afterwards, so that you do not have any problem in that case. If you have sometimes, for example, in surgeries and all, planned surgeries, usually samples you have time, then we go for at least 40 to 45 minutes. Where we do immediate spin cross match and ASG phase cross matches, where we look up for both IgM antibodies and for IgG antibodies.
Right, absolutely. So depending upon the urgency, depending upon the situation, there is a lot of the way we can do the blood, but ideally it should be the cum cross-match blood transfusion that has become very, very important. So we have a 3 to 4 things is there, from the whole blood, the pack cell, the platelet, the FFP, the cryo, and a lot of the things is there. But in terms of the choice of the group, in terms of the pack cell, it is the same blood group, should be the cross-match. In terms of the FFP, it will be the same blood group. There is no cross-matching required. In terms of the platelet, ideally it is group specific, but any group can be given for the platelet transfusion. And similarly, in terms of RH positive and the negative, that has to be keeping in the mind. In terms of the different component therapy, particularly the whole blood, that nowadays the whole blood is not recommended. So why it is not rational for this giving that the whole blood?
So whole blood is now considered to be an outdated concept because we now have specific tests which can help us to give specific products in terms of component therapy to the patients. So if the patient is anemic and we are considering a restrictive or a liberal policy of transfusion of PRBC, according to that we will give only on the basis of hemoglobin. Similarly for platelets, we'll see the platelet counts. If it is PT, APTT, fibrinogen levels, then we can consider fresh frozen plasma and cryoprecipitate. So without causing the patient more harm in terms of overload,
Absolutely.
more harm in terms of transfusion transmitted infections, more harm in form of transfusion reactions, we generally say whole blood is not recommended.
Absolutely. So that's why we shift to the component. The whole
Excuse,
blood.
I'd like to add two points into that whole blood. See, what is the concept behind giving a whole blood? It is the concept, the pre-notion concept that whole blood contains each and every component. The truth is not this. Once the blood has been taken and put it in the refrigerator in 4 to 6 degrees Celsius, your platelets are dead in any way. And your FFP, or if you're asking for FFP also, those clotting factors also come down. Secondly, once you take the blood, whole blood, there are WBCs, other the Buffy code things. With the storage, these get lies in your bags. So there are chances of infections, chances of transfusion reactions basically. And third thing is most important, that you cannot give whole blood as you cannot.
So you have to use the concept of the whole blood is very, very less. I will be coming the current indication. So what is about the concept of the fresh blood? Sometimes the people is asking that मुझे थोड़ा fresh blood दे दो. So what is your concern of the fresh blood?
Sir, there is a various trial has been occurred with the approach of restrictive and the liberal approach. There is such example of the proper trial where in orthopedics patients, they have used the fresh blood and see the mortality over the 28 days. They have seen the control and the cases group no variation, and there is no difference over the mortality morbidity. So a lot of trial supports that always restrictive approach. So fresh blood is a certain condition still patient is demanding, such as a neonates, CTVS patients, they are asking, but various trial are support in these gestures. So we can offer always all the stored blood have lesions, but we are giving the as much possible to save the patient's life, and their viability of the stored blood is account from up to the 70 to 90%. So there is no use for the demand of the fresh blood.
Absolutely. So in terms of the fresh blood, because you have to test for the lot of the things, that is the TTI, you have to do the testing, you have to do the cross matching, so you require some time for issuing the blood. So that's why the fresh blood concept is not there. And in terms of the fresh blood, there is a lot of the things is there. You should be keeping in the mind that nothing is fresh, because in terms of the fresh blood, if you give to the patient, it is require some time to prepare the blood. Means आप blood collection करके immediately दे देंगे, this is not a fresh blood. That's why the concept of the fresh blood not there. But you should remember that if you give the blood in the early times, you have a chance of malaria infection, you have a chance of syphilis infection, you have a chance of CMV infection if you give the very early without these things. The another concept is the warming of the blood. When we are in the student in the 90s, that in the OT, after receiving the blood from the blood bank, there is a bowl is there with the hot water, there is a warming of the blood and they are transfusing. So what is the concept of the whole warming of the blood nowadays? Any concept of the warming of the blood?
Sir, no concept of warming of blood. Main thing ki blood storage at 4 to 10 degrees centigrade. So required during the issue cross matching and then transfer blood bank to clinics such as transfusing area. So temperature always increase to 10 to 20 degree. मैं immediate transfuse नहीं करना within 4 to 5 degree. अगर if immediate you just out the fridge, then immediate transfuse, then chances है कि then hypothermia causes may be.
So sometime in case of the massive blood requirement, particularly in case of the trauma cases, you may require the lot of blood. So in that condition, should not warm the blood, rather you warm the patient. not the warm the blood. This is the important message is there that should be keeping in the mind. In terms of the whole blood, so what are the indication of the whole blood nowadays?
Generally, whole blood is not recommended, but in case of severe accident, in certain situation, massive trauma, you can give whole blood.
Absolutely. So in
probably this is only indication.
This is the only indication, absolutely. For the excess transfusion, for the trauma cases, for the massive bleeding cases, only the whole blood is recommended. In terms of the packed cell transfusion, so what are the indication of the packed cell transfusion and which value you should transfuse?
Packed cell transfusion, it depends upon the cases basically. If you are going for a surgery, what is the hemoglobin? Usually it is for 7 to 8 grams per DL. You can keep it. Then that is called a you have given the chart. Thank you. Restrictive versus liberal. We do not use liberal in cases. Restrictive, we use it in surgery. Whereas 9 to 10, it is, though it is not been practiced now, it used to be practiced, specifically in thalassemia where there are chronic patients are requiring those bloods. So that is the cases are there. Generally, you can use for the trauma, sepsis, injuries and all. That is.
So the important thing is that we have a problem of the awareness among the physician, as he rightly pointed out, that our strategy is the restrictive. When the hemoglobin level is 7, then only we order for the blood. The people ordering blood at the hemoglobin level of 9, the 10, there is no requirement at all. The data have been clearly show that the restrictive strategy as superior as the liberal strategy, even in case of intensive care unit patient, even in case of trauma, sepsis, the brain injury, the post-operative cardiac surgery. In that case, the restrictive strategy has to be used rather than the liberal strategy. There is a lot of the trial, lot of data, meta-analysis have been published that they are clearly in favor of the restrictive strategy of the transfusion. But in terms of the few patients, particularly in case of the cardiac patient, that you should maintain the hemoglobin level around the 9-2. But the another important thing is that if the patient is symptomatic, in that symptomatic patient, you should maintain the hemoglobin level around the 9 and the 10. In terms of the hematology patient, if you are considering, like we are considering the regular transfusion, the chronic transfusion in case of aplastic anemia, we are waiting till the hemoglobin level of 6. If the patient has a PRC, we are waiting the hemoglobin level of the 6 and also the 5.5 also. So the chronically transfused patient, the indication is different, but in general, usually the medical patient and the surgical patient and the people in the ICU, the 7 grams of the hemoglobin is the threshold for initiating the transfusion unless and until you have an emergency of this, the problem of the transfusion. In terms of the fresh frozen plasma, so what are the indication of the fresh frozen plasma and cryo?
So first we'll talk about where it should not be used. It is not supposed to be used as a volume replacement or a fluid replacement technique. So otherwise, generally, an adult dose is said to be 4 to 6 fresh frozen plasma. So maybe in bleeding patients or in TTPs or in specific clotting disorders, we generally shift to cryoprecipitate or specific factors which are available.
Absolutely. So the FFP and the cryo, usually in case of the bleeding patient, there is a particular the DIC, the liver disease, but the people are using this, the FFP, the plasma for volume replacement. She is correctly mentioning, and for correcting the PT and the APTT prolongation, the people are using the FFP. You cannot correct it. So there is no indication for giving the FFP and the cryoprecipitate in that scenario. Let us come to the platelet transfusion. That has become the very, very important thing. So what are the types of the platelet that are available in your blood bank?
So platelet, we can prepare platelet as a single donor platelet, as TP. We, in common terms, we know this random donor platelet donations, pool platelet, there's another sort, platelet concentrate, and platelet poor plasma. These are the 4 factors where we can get the platelet. And methods, when from the whole blood, when we are taking the blood, it will be terms of over the random donor platelet. After that, we are making it platelet concentrate. But SDP platelet is more better, and it is nowadays spreading everyone, because if there is a demand of the platelet in terms of what are the platelet which can be increase the platelet, so SDP is far better. To transfusion in contact with SDP, they can raise the platelet count up to the 30,000 to more far better.
Absolutely. So HDP is ideal when it is required, but sometimes the HDP preparation you need specialized design machine called the cell separator. Sometimes it is not available across the country. So in that cases you should use the random donor platelet or the pool platelet. So what is the concept of the therapeutic vis-a-vis the prophylactic platelet transfusion?
So in terms of there is no role of the prophylactic giving the platelet, but if the platelet count is very low, such as less than 10,000, in that terms we can use the platelet as a prophylactically. So there is some indications we can give platelet prophylactically, such as if we are doing any intervention, we are doing the bone marrow aspirations, central cannula insertions, so or we are planning to neurosurgery, we have to see the platelet count. If it is the less than 1 lakhs, so we have to give in the neuro patients. We are doing any intervention and platelet count is up to the 20,000, so we have to give it prophylactically. We should very accountful to giving the prophylactically platelet.
Yes. So the thing is that the platelet transfusion across the physician, I think the knowledge is very poor. It is very sorry to say that, because sometimes during the dengue period, people have been transfusing the patient of platelet 50,000, 80,000 and the 90,000. There is no need for the platelet requirement at all. Because if you consider the bleeding risk, if the platelet count is less than 10,000, there is a chance of spontaneous bleed. If the platelet count is less than 20,000, there is a chance of risk with minor trauma. So spontaneous bleeding only possible if it is platelet less than 10,000. So there is no worry that the 20,000, 30,000, the patient is usually no bleeding. So that's why there is no recommendation for giving the prophylactic platelet transfusion. Yes, there is a indication for therapeutic. If the patient has a bleeding symptom, you have to give platelet transfusion. Suppose the patient has a platelet count of 40,000, 50,000, patient is bleeding, so you need to give the platelet transfusion in that group of the patients. So I'll be coming in that portion that which platelet count you have to transfuse it, but before that, what is the risk of platelet transfusion? That has to be very, very important. Anybody can tell the risk of platelet transfusion?
Sir, mainly risk of any plasma product you transfuse, the first risk of the allergic reaction. And the platelet, the second, the most common is the sepsis is the very important. If upper storage system is not properly maintained, then very chance that bacterial growth is done and then cause the sepsis reaction. And then also trally and some other reaction, febrile non-hemolytic reaction is the third and fourth, like most common is the allergic and sepsis.
Absolutely. So this has to be keeping in the mind.
So one point I have to
Yes,
add
yes.
here: why contaminate platelet sepsis chance is more, because storage temperature is 22 to 24 degrees Celsius. That is favorable for bacterial growth. That's why more chance of sepsis.
Absolutely. So there is a chance of infection is more with the platelet rather than your FFP and the pack cell. That has to be keeping in the mind. So in terms of the managing the threshold of the platelet transfusion, there is a old guideline is there. I am coming into the new guideline that recommendation of the platelet transfusion. In terms of the recommendation of the platelet transfusion, if the patient has a no bleeding, patient has a hypoproliferative anemia, thrombocytopenia requiring stem cell transplant, our threshold is less than 10,000. Only 10,000 you give to transfusion. In terms of the preterm neonate without the major bleed, 25,000 is the threshold. If patient undergoing the lumbar procedure technique, the lumbar puncture, the 20,000 is the threshold. If the patient has a dengue conjunctive coagulopathy or any other conjunctive coagulopathy, there is no indication of the platelet until and unless patient has a bleeding. If the patient has a bleeding, then only you have to give the transfusion of the platelet. In terms of the hypoproliferative anemia, patient has a no bleeding, particularly the aplastic anemia. Nowadays, there is a no prophylactic strategy, but usually we follow the less than 10,000. In terms of the adult patient also, in terms of the non-dengue cases, less than 10,000 in the threshold. In putting the catheter of the patient, they have been recommended that the 10,000. If you do the intervention guided, the radiology guided, you can do the procedure safely even in the platelet count of 15,000 or the 20,000, so on. So there is no worry about the platelet numbers nowadays. And in terms of the adult patient that undergoing the intervention radiology procedure, usually the 20,000 is the cutoff. In terms of the neurosurgical anesthesia, neurosurgical surgery, that is the 50,000 is the cutoff. That has to be keeping in the mind. And if the patient has a adult patient, there is spontaneous, the traumatic, non-operative intestinal hemorrhage with a platelet count of the 1 lakh that have been receiving the antiplatelet therapy, there is no role of the platelet transfusion. That is the current guideline and recommendation have been recently published in the JAMA in 2025. So the important thing is that platelet has to be transfused very judiciously, because the platelet, the risk is more. You have allergic infection, you have a sepsis, sometimes they have a trally. The lot of the problem is land up with the patient with the platelet only. The complication with the PRBC is less, but the complication of the platelet is more. So you have to be used the judicially the platelet transfusion. The point has to be remembered in the blood transfusion that the blood component, particularly when you are using the RBC, that RBC should be transfused within the 30 minutes for the issue has to be completed within the 4 hours. So there is no delayed transfusion is there. Platelets should not be placed in a refrigerator, as Harry rightly pointed out. It should be kept in 20 to 22 degrees centigrade under the agitation. In terms of the FFP, you should transfuse after the issuing from the blood and should be completed within the 20 to 30 minutes. So in terms of the monitoring, this is the last question. In terms of the monitoring, that has become very, very important in terms of the transfusion, because the mismatched transfusion is there. So how do you ask your student nurse to monitor the patient?
So there are various checkpoints. The monitoring starts actually before you transfuse the patient. You have to get their vitals prior to starting the transfusion, after which the recommended guidelines say that in the first 15 minutes where you are transfusing the patient slowly, that is when the vitals should be checked, and after which every hour, and then they say 1 hour after the completion is done. So for the first 15 minutes when we are transfusing at 1 to 2 ml per minute, the chances of most reactions are at that time. So that is where the nurses and the doctors are told that don't leave the patient's bedside.
Absolutely. And even after the completion, you should observe of the patient for at least the 2 to 3 hours. Sometimes sometimes the delayed reaction might be there. That has become very, very important. So after the finishing the blood, you cannot send the patient to the home. So that, ladies and the gentlemen, the take-home message is there. The clinical situation has become very, very important for analyzing or the blood transfusion. And the blood component has to be used, the right product, the right doses, the right time, and the right region has to be there. In terms of the pack the restrictive strategy has to be used when the hemoglobin level is 7, and the transfusion of the platelet if your platelet count is 10,000. And more important is that you should monitor the patient during and after transfusion. So with this, thank you very much for the patient hearing, and thanks for all the panelists.
I'd like to add one point. Sorry, sir.
Yes.
One thing that we have missed here, we have missed जो blood bank या blood centers बोलता है documentation. The right documentation. There are 5 hours in that place. Whatever they are transfusing, whatever you are doing, whatever the thing is done, even your nurse has to document it in the file. Without documentation, nothing is complete.
Absolutely.
That is the thing that I felt is not there.
Yes, in terms of the monitoring that is there, the documentation. So any other question or the comment, because the session should not go in late.
Sir.
Yes, Dr. Jha, please.
Sir, it is time to have a discussion on this topic and trolley. How to manage it? Because we are component therapy. What is side effect, serious side effect of trolley? How to manage trolley?
So trolley, the management generally is supportive in the initial few minutes, because you are not able to differentiate it between tacho and trolley. The confirmation of trolley is only once the chest x-rays are in. You have ruled out the symptoms of circulatory overload, which was transfusion associated. The confirmation of trolley is still after the HLA antibodies or the HLA antigen matching is done, sir.
Absolutely.
Actually,
I'd like to
trolley.
Sir, मैं 4 point add करना चाहता हूँ trolley का diagnosis के लिए. Trolley is always a diagnosis of an exclusion. आपको ये बात याद रखनी पड़ेगी. First thing. Second thing, trolley उसी को ही होगी when there is a previous lung insult is there. यानी कि पहले से उसको lung injury होगी ही होगी. Third point, triggering point is the plasma. आप उसको कौन सा plasma दे रहे हैं? FFP कौन सा जा रहा है नहीं जा रहा है? Fourth point, radiological evidence of batwing appearance. That is the thing. A plasma may be kaun sa plasma. All plasmas does not cause TRALI. It has been found in studies that a plasma from the multiparous female, if it is being transfused, then there are high chances of a TRALI. And treatment is always supportive in the line of you're treating a case of an ARDS. Why sahi hai? Or diagnosis of exclusion.
The important thing is that in terms of the TRALI, is rightly pointed out, so the TRALI is more common into the plasma, the TRALI is more common with the platelet, and it is presented like the features of the ARDS. That is the non-cardiogenic pulmonary edema. The physician has to take in the call whether my patient developed TRALI or not.
So it is treated with oxygen. It is treated with oxygen.
Treatment is the supportive. Treatment is the supportive. The none of the drug has been approved for the treatment. It is the supportive. I think we can discuss with this during the lunch.
Sir, one short question, sir. Sir, a patient on taking aspirin, just has taken aspirin yesterday night or a day before and has to undergo a major surgery. So do we need to give prophylactic platelet transfusion, and how much?
So it is your planned surgery or emergency surgery?
Sir, emergency surgery.
If it is emergency, you have to give the platelet transfusion. If it is planned surgery, you should stop the aspirin for at least the 5 days. If patient on the clopidogrel, you should wait for the 7 days at least. But yes, if it is emergency surgery, you should transfuse the patient to reverse the platelet function.
Sir, how much platelets, 1 SDP?
Usually the 1 RDP raise the platelet count of 5,000. If you give the SDP, the 1 SDP raise the platelet count of 40,000. So which surgery you are doing, depending upon that, you have to transfuse. If you are doing the intracranial surgery, your threshold is more than 80,000 of the platelet and 1 lakh of the platelet. Depending upon that, you have to infuse the SDP or the RDP. So I think with this, thank you very much for all the panelists for their and all for the audience for the patient listening. Thank you.
Thank you, sir and ma'am, for such a informative discussion. I would like to request panelists and speaker to have photo session. Thank you, sir and ma'am. We will having a lunch break right now. Before that, I would like to have your kind attention that post-session talks will be done in 2 halls simultaneously. Clinical talks will be done in Hall B. So those who want to attend, kindly proceed to Hall B after lunch. I request everyone to have lunch.
Good afternoon to everyone present here. It gives me immense pleasure to welcome you all to this next session that is titled A Potpourri of Interesting Cases in Hemato-Oncology. The session, as to its name, will provide us with a rich blend of insights into different kinds of real-world experiences in clinical and pathological cases. So may I first of all please welcome to the stage the esteemed panelists. Dr. Indranil Sen sir, who is a managing director of
I'm not Indranil Sen.
Yes, yeah. And next we have Dr. Poonam Kumari ma'am. Ma'am is the professor and head of Department of Pathology at DMCH, Darbhanga. Can you please round of applause for all of them, please, over here?
Yeah, open. फिर से मांग रहा है? अच्छा, you called it.
To the esteemed panelists, sir, please can you introduce sir to the stage? Professor Dr. Brigadier Dr. Tathagat Chatterjee, sir.
Brigadier Dr. Tathagat Chatterjee. He is alumnus of AFMC and AIIMS Delhi, President-elect Indian Society of Hematology and Blood Transfusion, ISHBT, currently Senior Professor and HOD Department of Hematology and Stem Cell Transplant at ESIC Medical College and Hospital, Faridabad. His topic is a potpourri of interesting cases in hemato-oncology. Please, sir.
Thank you, Chairperson, for a brief and a precise introduction. And this is post-prandial session, so I'm so grateful that so many of you are still there. Okay? So, without wasting much time, I'm going to show you 10 cases. And what's the idea of showing you these cases? Is to motivate you into hematopathology. Hematopathology is not just about next generation sequencing or flow cytometry. It's a huge subject. It starts from the basic Leishman and Jenner's and so many other stains to the complex procedures of molecular genetics. So in this next 40 minutes, I've got 40 minutes, I'll show you 10 cases, and I'm going to show you some autopsy cases also. PGI Chandigarh and AFMC, we are still doing a lot of autopsies. And you will see how autopsy is also important in hematopathology. So I'm going to show you a plethora of cases. So let's start with the first case. Bring you greetings from AFMC and Army Hospital. So my first patient is a 16-year-old male. It is an unusual translocation in a usual leukemia. It's a very, very basic case. Try to follow it carefully. So the standard complaints of weakness and fatigue of 10 days duration in a 16-year-old male with no lymphadenopathy or hepatosplenomegaly. And it was a bicytopenia In that, there was anemia and thrombocytopenia, and the peripheral smear showed blasts. We'll not go into these. The bone marrow was hypercellular, 90% blasts. So we thought of AML-M2, and we did an IHC on the bone marrow biopsy, and it showed a 34 and a 117 and a 68 positive. Please settle down. I mean, I don't want you all to miss it. Are you all pathologists? Please settle. No, it is for you. So now concentrate on the flow. How many of you have done flow? All of you know about flow? MD pathology students, side scatter CD45. Which is the cell which has the lowest side scatter and the brightest CD45? Not for you, for the MD pathology. Lowest side scatter and the brightest CD45. I know you know the answer, but this is not for you. MD pathology. Granulocytes. Agranulocytes. Lymphocytes, isn't it? So if you do not know such basics, then how will you understand? I'm going to show you some flow in leukemia. So have a look. So, which do you think is the blast? Does the pointer work? Does it work? Yeah, it works. Which is the blast? This is the lymphocyte, isn't it? This is the blast population. So the CD45 is lesser in intensity compared to the lymphocytes, and the side scatter is highest. What does side scatter indicate? Granularity, not size. The forward scatter is size, the side scatter is granularity. Okay? So you're seeing this? Now see the anti-MPO and the 34. What does it mean? The pinkies are the blasts. They are co-expressing CD34 and anti-MPO. It's a very standard case, okay? Next, we have a 13 and a 33 co-expression, and a 117 and a 64. What does 64 indicate? MD pathology students, please settle down. This is for you. Please maintain time, okay? 2 o'clock is 2 o'clock. तुम लोग के लिए बनाए हम लोग ने cases. CD64 tells us it's about a monocytic lineage. So a myeloid leukemia with a monocytic lineage, okay? The one which you call AML-M5 or whatever, okay? So 1333 is positive. So these were the markers which were positive, okay? So you see 11C, you see 14, and you see 64. So what was the topic? A usual leukemia with an unusual event. What was the unusual thing? Is the chromosomal analysis. When we did RT-PCR on this, in our own hospital, we found a translocation 821. What is the translocation 821? 821, E-T-O. E for 8, T for 20, O for 1. Okay? Don't forget it again. 821. So the translocation of chromosome 8 and chromosome 21 causes a chimeric protein called the RUNX1 ETO. The RUNX1 is in chromosome 21, right? So we have got this fusion protein, and that causes the leukemogenesis. That is, it disrupts the normal gene. You never see this sort of a translocation in a monocytic leukemia. So this is a very, very basic flow, a morphology AML-M2, a flow showing monocytic leukemia, and the translocation showing 821. 821 is a good prognosis, isn't it? This patient died. Monocytic leukemia, good prognosis, because it had another translocation. It had a complex cytogenetic along with FLT3 ITD. So it makes it a very complex situation. So we got hold of a transplant donor, but he didn't survive the induction at all. So this was your first case, right? These are a comprehensive RT-PCR panel which we have standardized in a government hospital. So I come from Army, and then I have gone after my superannuation to a government hospital where we have standardized the flow, the NGS, and the RT-PCR. And we give a comprehensive language with a small turnaround time of 3 days for a comprehensive flow and RT-PCR. And if it is an NGS, it is on a case-to-case basis. It really doesn't help us much, because the flow and the RT-PCR and the morphology and the cytochemistry gives us what we and the clinician and the patient requires. Okay? The idea is you can set up a lab similar to mine by doing morphology, cytochemistry, flow, and RT-PCR. Okay? It's not a big task, you can do it. Okay. So these are the key points of AML. I've got some more cases. Let's go to a childhood AML. Now, childhood, we have got ALL cases, isn't it? Acute lymphoblastic leukemias are common. Now here we got a childhood AML. 8-year-old male, fever on and on for 3 months, and has pallor and all those things. These were his investigations. LDH was elevated, viral markers were negative, and this was the CBC and peripheral smear. What is your interpretation? 8% blasts, okay? So you got blasts. And the bone marrow was hypercellular with predominance of blasts. So why am I showing you this case? So you got a lot of hypolobated megakaryocytes. So we had a child who had a lot of blasts in the bone marrow. It was AML and had features of myelodysplastic changes, right? These are the flow findings. Can anyone interpret? The green ones are the blast, agreed? And they are positive for HLA-DR. 10 is bright to moderate. 13, 33, 64, 11C, 56. What does it indicate? Again, a monocytic lineage. AML with a monocytic lineage. See the cytogenetics. We found an unusual cytogenetics. Translocation 3, 5. What is translocation 3, 5? Which is the protein in chromosome 5? Of which is of interest to the hematopathologists and clinical hematologists like Tufan sitting here? Nucleophosphine. What is it? Nucleophosphine. And translocation 3, MLF1 gene. The myeloid leukemia, myelodysplastic leukemia factor 1 gene. That is in chromosome 3. So this is a very, very unusual translocation in a child who has presented with AML M5. Hematopathology lab giving you the cytology, the morphology, the cytochemistry, RT-PCR, now cytogenetics and flow, okay? So this is the rare childhood AML. Only 0.5% of AML has this sort of translocation. So today I have shown you 2 interesting cases. One, a usual leukemia with an unusual finding. That is a translocation 821 in a monocytic leukemia. And you got a translocation 3-5 in a childhood AML. Have you ever heard of a DECCAN, SETCAN mutation? Any of you? So you're not reading WHO. WHO is full of this. 2008 had this, 2017 had it, and now 2022 calls this a defined genetic abnormality. DEC and SET. Okay? So these terms are now obsolete. DEC is in chromosome 6. SET is what? NUP214. That is in chromosome 9. So this is a 48-year-old male. Generally you get this in a child. This is a 48-year-old male who is presented with the following features. And these were the lab investigations. So you had thrombocytopenia. You heard so much of thrombocytopenia. Today Tufan was discussing thrombocytopenia. So this is one thrombocytopenia which required platelet transfusion, despite the trigger being only 51,000 and not less than 10,000, because he was bleeding. Anyway, so this is the peripheral blood, which was acute leukemia, likely myeloid, and we did a real-time PCR and we found the, this is in our lab, we found the, what mutation? DECCAN mutation. Seen? DECCAN positive dekha? So that is what? So what is DECCAN? AML with translocation 6-9 is a distinct and aggressive subtype of acute myeloid leukemia. And it is found in less than 2% of AML cases. It is commonly associated with younger patients. Our patient was older, 48. Poor prognosis and frequently associated with FLT3 ITD. If Dr. Tufan practices clinical hematology, he doesn't go by very big things. He tells us, diagnosis में बताओ ये AML है कि ALL है, FLT3 है कि नहीं. You know what? Because you're going to start a medicine called midostaurin upfront with 3+7 induction, right? So FLT3 ITD is one of the very, very important, and it is done by conventional PCR. You cannot do it by RT-PCR. FLT3 TKD is done by RT-PCR, but FLT3 ITD is done by conventional PCR. And so we have done a conventional PCR, and we found this DECCAN fusion protein with FLT3 ITD, a very, very aggressive disease. Only 2% of childhood AML can have this, and this is a AML with defined genetic abnormalities. or sometimes called other genetic abnormalities in the WHO classification. It targets primitive hematopoietic cells, blocks differentiation, and enhances leukemic transformation. Interferes with histone acetylation, methylation, and DNA methylation. So it is a leukemogenic factor. This is a very, very interesting case. This case went all over the country. A person came, 43-year-old male, with massive generalized and retroperitoneal lymphadenopathy. So he had cervical, he had axillary, he had inguinal, he had retroperitoneal. So here in my setup, we report lymphoma as well as leukemia by the hematopathologist. It so happened that day I was out of station. So the histopathologist was reporting this case, and she was a very senior lady. She was director of RML Hospital, Delhi, and she rang me up, ki, where are you? I said, I'm here. I'm coming tomorrow. She said, I want to show you a case. See, this is a diffuse large B-cell lymphoma. She had already diagnosed it. Diffuse large B-cell lymphoma. So the patient had multiple, mild splenomegaly, and as I said, fever and all sorts of lymph nodes. How many of you do lymph nodes pathology? Can you identify this lymph node? So the entire perihilar fat is all involved with the lymphoma, right? And the high power view is showing a monomorphic population cell which was diagnosed as DLBCL. What is the first thing a hematopathologist sees in this case? Like Dr. Jain is sitting here. The first thing we see is the type of cells. It is blastoid. Okay? So it doesn't make it DLBCL, right? So the first thing I did was, I did a IHC on the lymph node biopsy, and I did an immunochemistry on the lymph node biopsy. And what was this? MPO. MPO was strongly positive along with TDT, along with CD56. What do you think it is? So we are dealing with the lymph node now. I have done an IHC on the lymph node. I have not yet shown you the blood, right? Yeah, the IHC on the lymph node. Basically, remember one thing. If the MPO is positive, don't neglect it. It is a myeloid leukemia, which has affected the lymph node. So that's the question. So why the TDT was positive? So now let's see. Now look at the bone marrow aspiration and biopsy. We went for the bone marrow aspiration because the MPO was positive. Now see the biopsy. Diffuse involvement with non-Hodgkin lymphoma in the bone marrow, all sorts of blasts you're seeing. And then we did a flow on the bone marrow aspirate. So we have already done the IHC. We have got the lymph node pathology. I have committed. This is a myeloid leukemia which has affected the lymph node and has nothing to do with lymphoma, right? So I did a bone marrow aspirate and I got the blast. I was keeping my fingers crossed and I got the blast. You can see the blast? And these blasts were two populations, as Dr. Saab said, two population blasts. One population shows an anti-MPO, HLA-DR, CD38, 56 and 34 positive, and 34 was negative. That was one population. So anti-MPO positive hai, mujhe lymph node mein mil gaya tha. It further confirmed my finding. But this was only one population. The other population was TDT positive. So let's see. We'll not commit. Okay? I am still banking on my MPO. My MPO is myeloid. So I put up this case, Dr. Jain, to Dr. Kikiri Naresh. We were having a meeting of lymphoma groups. So he is now in Seattle. So all sorts of discussion took place because we had to start the treatment. And I was insisting myeloid. So Kikiri Naresh said, come what may, 2 population, 3 population. MPO positive is AML. So this was an AML with aberrant CD56 expression. But what was the differential diagnosis? Blastic NK cell lymphomas. This term is now out from WHO. Blastic plasmacytoid dendritic cell neoplasm, BPDCN, where you have CD123 positive, and early T myeloid leukemias. So we have various differentiating points of blastic NK, BPDCN early. This is not a theory class. You all can go and read it. Our final diagnosis was an undifferentiated AML with an aberrant 56 and a 7 expression. We put this patient on 3+7 treatment. He is in remission. His nodes have disappeared. So the beauty of hematopathology, as I was discussing with Dr. Jain, is that we have to now start telling you how much of complement work hematopathology does for clinicians like Dr. Tufan. He can't do without us, right? So we complement each other and we speak the same language. So hematopathology is one subject where you should be proud of, and you should continue as a good pathologist ठीक है? The diagnosis, the final diagnosis, if you have read Sir Arthur Haley's book, The Final Diagnosis, please go and read it. The romance and the beauty of giving the final diagnosis is such a feeling, जिसे हम हिंदी में बोलते हैं ना, सुकून आता है अंदर से. That is the final diagnosis. Case 5. Interesting case. 28-year-old female, fever, cough, and bleeding per vaginum. This is a very, very exciting case. Hemoglobin 9, TLC 1,11,000, platelets 45,000. Right? High TLC, isn't it? Thrombocytopenia. इसको transfusion भी मिला, platelet transfusion, SDP दिया 2. Yes, diagnosis, peripheral blood. What do you see? So when we were in AIMS, Dr. Pati and Dr. Renu Saxena used to treat. No, there are no factors. There's no ore rods here. So think. Every cell is looking like a cell with a indentation, right? Which is that mutation which gives you basket cells? Excellent. Who was it? Raise your hand. I think I put a chocolate. Yes. There's an AML with NPM1 mutation. Very good. So the blasts were 2 to 3 times that of a mature lymphocyte with scant to moderate cytoplasm. Small set showed nuclear convolutions with cup-shaped indentions, right? Very nicely caught. So this is acute leukemia, and see the flow now. You just can't make a morphology diagnosis like that. So you have to do a flow. What do we see in the flow? Again, the pink population, the blasts, and they're 13 and 33 positive, 34 positive, HLA-DR negative. Name the leukemias which are HLA-DR negative. Besides APML, an AML with NPM1 mutation is also HLA-DR negative. So just getting HLA-DR negative and you say, oh, APML hai, और पता चले NPM1 mutation है. An NPM1 mutation is a fantastic, good prognosis. You treat them energetically. Unless of course FLT3 आ गया. अगर FLT3 उसके साथ आ गया फिर intermediate risk हो जाएगा. ठीक है? So this was the immunophenotyping. 90% blasts were gated, and these were the positives, and the HLA-DR 34 was negative. So 34 HLA-DR negative, कभी-कभी AML M7 में मिलेगा, AML with NPM1 mutation मिलेगा, और APML मिलेगा. Clear? Are you all awake? Enjoying? Because next 2 cases may be autopsy cases. I'll show it to you. Very exciting cases. Okay. So this was the mutation panel which we have standardized in a lab, and we do this. Okay. We have discussed this. An excellent case, 1-year-old child. Now the pediatrician tells me कि तथागत हमें केस देखा, इसका प्रोप्टोसिस हो रहा है, ये माइलॉइड सार्कोमा है. ठीक है? A child. 1-year-old child, fever on and off for 4 months. Moderate hepatosplenomegaly, developed unilateral proptosis in the last 10 to 12 days. Acute onset. Talking about proptosis, when I was doing my DM in AIMS, इस तरह का केस आया था. अरे ये तो रेटिनोब्लास्टोमा है, तथागत आकर थोड़ा, that time given call duty. I said ठीक है, रेटिनोब्लास्टोमा, what am I supposed to say in रेटिनोब्लास्टोमा? मैं बोले यार PS देख लेते. PS देखा सिकल सेल से भरा हुआ है. And we put the patient on hydroxyurea and saved a blindness. Everything was retinoblastoma. It was homozygous sickle cell anemia. So I'm talking that, but this is a different case. ठीक है? Proptosis. Hemoglobin 5. TLC high. Thrombocytopenia. ठीक है? Yes. Morphological delight. We diagnosed this just 1.5 months back. What is the characteristic blast you see in this? Yes, young man? You're observant. Fantastic. You got the diagnosis. What is the diagnosis? AML M7. Brilliant. So everything is organizers, you must give him a Cadbury. Okay? So I'm coming to that. Yes. So very correct. Yes. Yes. So this patient has come with proptosis. We are getting this. Now see my next slide. Bone marrow biopsy, right? We have already done the biopsy. IHC CD34 positive, MPO TDT CD117 E cadherin negative. Why did I do E cadherin? Yes, The early pro-normoblasts are E-cadherin strongly positive in AML-M6. Blebs can come in AML-M6, as he has rightly said. It can come in ALL, it can come in AML-M7. So हमने E-cadherin कर दिया, negative है. TP53 wild. TP53 in 98% of AML-M6 is positive, strongly positive. So this is wild. Now see the flow on the bone marrow. Who is going to interpret? Anyone? Any wise guy? I'm losing too many Cadburys. What do you think? So 34 and 38, what is your interpretation? And 56 and 34. 56 negative? Strongly positive. 34? Negative, dim. What else? 38? Now see. HLADR? Negative. Another case where HLADR comes negative. We said AML-M7. Okay. What else? 117, dim. 33, positive. 41% of the cells were gated on a 45 versus side scatter with dim to moderate 45 and low side scatter. Okay. 34 dim positive. 117, 56, 33 bright positive. 38 HLADR weak positive to negative. 41A dim positive. 13 negative. What's your diagnosis? This is RAM phenotype. Have you heard of RAM? It's a very rare case of an AML-M7. RAM is the initial 3 names of the child. Uske naam se RAM phenotype. RAM phenotype has got a dismal prognosis in AML-M7. So ये जो proptosis हो रहा था, I've selected some interesting cases for you. ठीक है? So bright CD56 with a weak to negative 45 HLA-DR and 38 expression. You have to actually demonstrate a 36 negativity to finally prove this RAM phenotype. But what was exciting was FISH panel was negative, but positive for trisomy 21 in 60% of cells. What does it mean? Not exactly Downs, so सब cell में होता है. So it is maybe Downs or a non-Downs. हर cell में नहीं है. Mutation profile. We just got this report day before yesterday. This is from a outsourced lab, this mutation, because we don't have this capacity. GLIS2 fusion. Chromosome 16, exon 11 with breakpoint of so-and-so. This is considered as AML with other defined genetic alternate abnormality in the current WHO. There is a cryptic inversion or fusion in children less than 5 years, the so-called non-Downs AML-M7 with RAM phenotype. Okay? So today you understood something called RAM phenotype. Clear? I think we have had enough of flow. Okay, histopathology. Histopathology and its relevance in hematology. You know, I started my career as an oncopathologist under Dr. Borges. And then army said, नहीं, मैं तुझे hematopathologist बनाऊंगा. ठीक है, बनाओ, बना दिया. It's a fascinating subject, the entire pathology. So when you talk of renal involvement in plasma cell neoplasms, you talk of amyloidosis, monoclonal immunoglobulin deposition disease, plasmacytoma, light chain tubulopathy, cast nephropathy, and some sort of a glomerulonephritis with minimal diseases. Case 1, one case hai. 60-year-old female, generalized weakness for 6 months duration with a hypertension of 3 years. Evaluation at civil hospital, the high creatinine. Urine examination, nephrotic range proteinuria. ठीक है? तो kidney में problem है. ठीक है ना? Now it comes to Dr. Tufan. Now Dr. Tufan को refer किया किसने? Nephropathologist ने और nephrologist ने. So he's scratching his head. क्या है ये? So he does the LFT, the RFTs again, and he still finds that the creatinine is very, very high, and the ultrasound kidney size अभी तक बड़ा नहीं है. ठीक है? But creatinine high है. Proteins कम हो गया. ठीक है? Proteinuria हो गया. So he has a clinical impression. Is it a chronic glomerulonephritis or a chronic kidney disease, and maybe an IgA nephropathy, or a focal segmental glomerulosclerosis, or a hypertensive nephrosclerosis? This is a standard diagnosis of a good MD pathology student or a good MD clinical medicine student. Okay? So Dr. Tufan has made this diagnosis. Biopsy किया. He said biopsy करो. देखो. A very exciting case, isn't it? So global glomerular स्क्लेरोसिस दिखाई दे रहा है ना, H&E, pass, strongly positive, membranes positive, ठीक है, pass positive, pass M, negative, it is not argyrophilic, ठीक है, ठीक है, congruent negative, amyloidosis है नहीं, ठीक है, तो क्या है, IgG glomerulus negative, tubules negative, A, M, C3, CIQ negative. Now they have come to Dr. Tufan Dulai again. So he does the kappa and a lambda. And he finds strong positivity for kappa, lambda is negative. Glomerulus में भी है, tubules में भी है. Monoclonal light chain deficiency. Okay. Now his kidney is going away. Now the clinical hematologist comes with the question कि भाई इसको myeloma का treatment दूँ या kidney को ख़त्म कर दूँ. So now you got something called bone marrow was normal. Okay. So monoclonal gammopathy of renal significance, MGRS. So here an astute clinician will go up front and give the treatment of myeloma and the patient's kidney is saved. Have you understood? तो MGUS सुनते, ये सुनते, अभी MGRS, monoclonal gammopathy of renal significance. Okay, so you got a lot of articles in blood, और मेरा भी article है, autopsy. 2 good autopsy cases. A good pathologist must always do autopsy. I'm happy that PGI Chandigarh, हमारा अभिषेक PGI Chandigarh से है. I am from FMC. We do a lot of autopsies. ठीक है? See one case. A beautiful place in Northern Ireland, and this is the hint of the final diagnosis. A beautiful resort in Northern Ireland where this gentleman came back in Uganda and did an epidemiological survey. Okay, and he found a particular type of a virus. And he presented this in the British Journal of Surgery. He was never a pathologist and he was blind in one eye. Whom am I talking about? Yes, I'm talking about Burkitt's. So interesting case. I must admit yours is one of the most baffling cases I've ever seen. So let's see. So this is a patient who was referred to us from Base Hospital, Delhi, with distension of abdomen, progressive breathlessness, weight loss and loss of appetite, low SAG ascites, serially rising LDH, no malignant cells. Tumor markers, viral markers negative, chest, abdomen, bilateral pleural effusion, ascites, extensive diffuse omental and peritoneal thickening. Okay? Whole blood, whole body PET CT, metabolically active, involvement of peritoneal lining, mesentery and omentum, and all those things you can read. Okay? This patient was being treated for tuberculosis for 1 month at Base Hospital, Delhi. और लास्ट मिनट में उन्होंने हमें फ़ोन किया कि भाई मामला गड़बड़ है. So we did the ascitic fluid tap. Patient is dying. और हमें ये मिला. See, ascitic fluid, the role of hematopathologist in ascitic fluid. We knew the diagnosis. Patient died, we did the autopsy. We found nodular deposits over rectus abdominis muscle, omentum, gallbladder, pancreas, appendix, liver. हर जगह. Look at the liver, look at the autopsy findings. कहाँ मिलेगा ये सब चीज़? Hilar lymph node. देख रहे हो? Differential diagnosis? I think it's your colon. I came to that conclusion through the process of elimination. This is Burkitt's lymphoma, right? Wrongly being treated as tuberculosis. Okay? So these are the various types of Burkitt and Burkitt-like lymphoma and differential diagnosis and various IHC. Remember, TDT, negative. 10, positive. BCL2, negative. Burkitt में apoptosis हो रहा है. ठीक है? So remember that. 34, negative. Okay. So 23, Ki67, CMYC. Where is MYC chromosome? Chromosome? कौन सी? 6, 7, 8. कौन सा? 8. Good. You're active. Burkitt's lymphoma revisited. We have published this case, okay? So we'll not go into this. Final diagnosis. Last but one, I got 2 more cases, including this, okay? A case of multiple myeloma, known, old case, refractory to chemo. How many of you have seen an autopsy in a multiple myeloma? Patient on palliative chemotherapy. Progressed to anaplastic plasma cell myeloma, which involved kidneys, small intestines, meninges, Solitary hylar node during the course of illness. See how myeloma kills. There's a duodenal serosal surface showing nodular mass. There's a large exophytic growth noted on the meninges. Autopsy and gross pathology teaches you. ठीक है? Myeloma में कौन करता autopsy? हमें मौका मिला. Look at it. Look at the kidney. तुमने एक MGRS सुना था ना kidney? ये देखो myeloma kidney. Nodular white mass at the upper pole of kidney reaching up to the pelvic, calyceal area, bilateral kidneys. The kidney is gone. This was a section from the colon, bilateral kidneys, brain, anaplastic myeloma, showing positivity for CD138. This is anaplastic myeloma. Okay? You got a standard multiple myeloma, you got an anaplastic myeloma, bizarre cells, high mitotic. And if you do not know the case, you might think, am I dealing with a plasmaplastic lymphoma or is it an anaplastic myeloma? Have you understood? Okay. So ISC 38138, 56 EMA EBV. Epstein-Barr virus will be negative in anaplastic myeloma. It will be positive in plasmaplastic lymphoma. So this was now the last case. Again, a case came from a very reputed hospital as acute leukemia, and we diagnosed this as a neuroblastoma. Many times a neuroblastoma in a bone marrow will mimic an acute leukemia and vice versa. So you have to be very careful. अरे ये तो acute leukemia ALL है, ऐसा नहीं होता है. You have to thoroughly investigate the case. Yes, small blue round cell tumor of childhood. Neuroblastoma is the most common extracranial solid tumor of infancy. Remember that. It is an embryonal malignancy of sympathetic nervous system arising from neuroblast, blah, blah, blah. This is a 3.5-year-old child. Fever, 2 months, not responding to antibiotics. Swelling, right cervical node, 2 months, progressively increasing. Splenomegaly, 2 months. Bilateral proptosis, dilated veins over forehead, multiple scalp swelling, 3 days. Okay? Investigated from this place, Bihar, with blood test, FNAC of lymph node and bone marrow aspirate. यहाँ से आया है ALL, ठीक है? Bone marrow and reactive lymphadenopathy on FNAC. Child was referred to Army Hospital. ये एक हवलदार मेजर का बच्चा था, ठीक है? Okay. Investigation, hemoglobin, very low. Patient is moribund. TLC देख लिया, DLC देख लिया, okay? C-reactive protein is high, ASR is high. Bicytopenia with microcytic RBCs, leukopenia, relative lymphocytosis, flow. Absent CD45. Besides BCR ABL like or a Philadelphia positive ALL, neuroblastomas are also CD45 negative. Okay? This was the X-ray, radiology. These were the NCCT heads, the bone marrow aspirate and biopsy we reviewed from Patna. So bone marrow shows deposits of small round blue cell tumors. Dr. Saab bola, round blue cell tumors having high NC ratio, hyperchromatic nucleoli, inconspicuous nucleoli, forming rosettes. Homorite के flexner, कौन सा rosette है? Neuroblastoma? Homorite, okay. Flow, 45 site starter showed 60% cells in the absence of 45 and positive of CD56. So we got a hint, CD56 positive hai. And then we did the IHC, we did a FNAC of the cervical node, we did a biopsy and found synaptophysin positive. Points to emphasize, neuroblastoma is a very, very close memory, and we have seen at least 4 such cases of ALL were turning out to be neuroblastoma. You got to be careful. Yes, I heard you. Flow cytometry is very useful aid in not only leukemia diagnosis but also in diagnosis of solid tumors. And here we did flow on both lymph node aspirate and bone marrow, and we had similar immunophenotype. So we'll not discuss this. This is the institute where I'm working for the last 4 years. I have got it to a level which I'm proud of. Thank you very much for your patient hearing.
Thank you, sir, for your brilliant presentation of different type of rare cases, along with your autopsy cases, which were a very nice one. Autopsy is a place where the dead person teaches the living persons. Thank you, sir. Any question from the audience?
APML could present without phagot cell, without all routes, on basis of morphological diagnosis for peripheral ischemia.
Yeah, this is a very good question. Can anyone take it before I answer it? Have you all understood what sir has said? APML in the absence of phagot rods, classical morphology missing. So microgranular, hypogranular variant can always show you features. So look for the bilobed cells. You have hypogranular. The difference is classical APML presents with pancytopenia. And here the microgranular will present with a higher count, right? So phagots are not always seen, but the cytoplasmic MPO or the cytochemistry of MPO is strongly positive. So if you have got a robust cytochemistry lab, you really don't have to climb to flow every time. You're seeing bilobed cells, you're seeing a count of 16,000, cytoplasmic MPO strongly positive. Preempt the diagnosis, give it to the clinician till your flow is ready, because you have to start the treatment there and then. Upfront arsenic with etra, okay? So it's very important.
In your experience, morphological experience, peripheral ischemia, what are the characteristic features of APML on peripheral ischemia? Sorry, no APML, sorry, AML M7.
AML M7 is an interesting thing. Yes. If you're seeing a child, a newborn child up to 3 months of age, think of TAM, transient abnormal myelopoiesis. Tell the clinician, give him the confidence कि ये अपने आप self limiting है, अपने आप ठीक हो जाएगा, and you will be very, very surprised to see how beautifully the patient, from a count of 80,000 it comes down to 8,000 ना, अपने आप ठीक होता है. So that is very important to eliminate TAM. Now when you are having a Downs-like feature, child is 1 to 3 years old, AML M7 diagnose कर रहे हो, if you don't have flow, the clinical profile, the Down syndrome, the cytogenetics, and the type of blast you're seeing, which is MPO negative on cytochemistry with blebs, at least you can suggest. Okay, of course, followed by flow. Anything else?
Any more question? Thank you, sir.
Now, photo session. Isn't it? I know you're going to announce that.
So thank you so much, sir, for such an enlightening and sequence of 10 interesting cases. Now let's take a photograph. I once again thank the chairperson. So sir has insisted so much on the flow cytometry, the significance of flow cytometry not only in the living but also in dead. So that leads us to the next session titled as Setting Up Flow Cytometry Lab in Limited Resource Setting. So to chair this topic, I would request Dr. Ravi Bhushan Raman sir, Associate Professor, Department of Hematopathology, IGMS Patna, to join us on the dais. Following, I request Dr. Amit Kumar sir, Senior Consultant Pathologist, Mahavi Cancer Sansthan Patna, to join us on the dais as well, sir. I now request the esteemed chairperson to introduce the speakers.
I welcome Dr. Sonal Jain, DM Hematopathology from AIMS Delhi. She was associated with RGCI, NRC, Dr. Dang's lab, MD at Art of Healing Cancer, and founder of Ashi Care Hematology Solutions and Digital Pathology, Gurugram, Haryana. Dr. Sonal, please start.
Very warm good afternoon, everybody. And after a fabulous talk from Dr. Tathagat, I feel like I do it justice by not letting you go to slumber again. Thank you, Dr. Avinash and Thai Hematology Foundation, Bihar, for this opportunity to share excerpts of my experience. Serendipity says it all. At all of these places, I had the privilege to start the flow cytometry laboratory. So I would not name Delhi, where I got the training from, the most premier institution of the country. At Modern Diagnostics, currently I set up the 10-color setup. At Mavi Cancer Sansthan, Patna, we had together built up the 13-color flow facility, Dr. Ahmed, Dr. Sarita. And I had the privilege to set it up at Rajiv Gandhi as well as Dr. Dang Lab. So why I'm mentioning this is that all of these setups are very different in their structure, in the way they work. And coming from the extremely complex cases which Dr. Tathagat shared, I go back to the basics that should all of us do flow cytometry. So we'll begin with how many, I hope most of the people here are pathologists. How many of you are doing actively flow cytometry? How many people have the flow machine in their setups and trying to build it up? Okay. 3 heads there. So how many want to do flow cytometry? So that's just 5 to 6 handfuls. So rest of them don't know. Is it? How I understand it as? Okay, sure. So the objective, do you want to do flow? I assume that when I say want to do flow, all the hands would be up, but that's not the case. If yes, then is it feasible to do it at your center? Or you do not want to do it, or it's not feasible, still you have a machine sitting there in the store and you are told that you have to run it. So then how do you plan to sustain it? And just a brief of the rest of the stuff. So please first thing to understand is understand your work environment and culture. It's a huge investment, not just at the point 1, but subsequently also. So you have to understand your work culture and the environment, because all of this has to come together for you to make some sense out of it. So you have to understand your own needs. Why establish flow cytometry? Is it a value addition to the services that the hospital or the laboratory is offering, or flow and molecular are considered at the pinnacle of hematology? So it plays an extremely important role in building the brand imagery of the setup as well. And if either one of these is the case and you have to run the machine, what are the needs of the patients that you have? The infectious disease monitoring, leukemia, lymphoma diagnostics, or advanced oncohematology, which would, beyond diagnostics, would include a lot of other stuff. So let's be honest, most of us don't work in TMH, AIMS, at the most premier institutions. Most of us work in standalone laboratories, or lab chains, or corporate hospitals. So we train, we learn from TMH and AIMS, but what we apply is according to the habitat we are in. We all have to adapt to the habitat. Only the adaptives can survive. So that's the reality. And so places like where Dr. Tufan, Dr. Avinash work, they would have a lot of demand for this benign hematology flow as well. PNH, immunodeficiency disorders. I missed Dr. Pranta. So he would, where places where entire oncology is being done, advanced oncohematology setups, and entire hematology is being done, the gamut of the work that is needed of the hematopathologist increases. So step 1, do you have the space? If you have the space, flow doesn't require an extensive, hugely secluded kind of place, but a clean lab which has an air conditioner, and it should have a good electrical UPS backup, etc., etc. So now the most important aspect, we live in India, which is resource-wise extremely varied, but whichever place we work in, resource optimization is necessary, because whatever money that's being put into this setup is coming from somewhere, and somewhere else, if it's needed more, you should be. So what's the budget of this setup? What is a one-time budget? One-time budget means we have our management who feel that our setup should have a flow machine. They buy of extremely expensive, most complex machinery. So trust me, for a flow setup, the budget ranges from 50 lakh rupees to 5 crore rupees. The initial capex. What is a one-time budget and what is the recurring budget? Recurring budget would mean an annual budget of close to 10 lakh would be still required after that initial spend. First is the machinery, second is the people who work with this machines. So what are the HR policies of your place? They love the machines, but they don't love people. They get you the machines, but they don't get you people. Then what to do? And how is the supply chain management? How fast do you get your reagents if they're over? So everybody in there needs to be aligned with this concept of flow. So choose your machine well, choose your people well, and choose your reagents well. I'm telling you all of this because you have all of this at hand, but you do not know what to do next with it. Then you are, the entire management, the finances are sitting on your head, and you have spent more than 1 crore rupees on that setup. And it's not even self-sustaining. So how to choose your machine? Machinery again you choose based on what applications you have to do. If it's a basic simple cell count monitoring, then it's a most basic 4-color or 6-color device will do. Does it work? Okay. Not work. Okay. So if you are the most basic HIV immune monitoring, most basic single laser 4-color instrument would work. You are working in an oncohemat setup with adequate workload of blood cancers, then minimum of 8-color would be required. Minimum of 8-color, you can go higher, there's no limit to the higher. If you are in a research setup, then research, more colors the merrier, more extensive research you can do. Also see what is your technical workforce. I was speaking to one of my seniors who was discussing that they have a flow machine, but they don't have this technical expertise. More complex is the machine, more complex is the technical requirement. 4-color machine or 6-color machines are easier to use by the technicians as well as the doctors. A 13-color, 16-color, 20-color or 32-color, you would require extensive expertise day 1 and day end. Again, more colors, more capex. That we know. If your management says I can spend 80 lakhs, that's okay. But understand that a 10-color machine, the reagent cost for the same number of antibodies would be more. Whoever has a 1 laser versus a 2 laser versus a 3 laser machine, the 3rd laser which has been added later, that is a violet laser antibody for the same antigen, would cost more than a FITC or PE labeled antibody. And the cost difference is not little, it is huge, sometimes twice or thrice. A cyto-MP on a FITC, cyto-MP on a BV421, the cost difference would be huge. So understand it on day 1. If your system needs only leukemia, lymphoma phenotyping, then stop at 6 or maximum 8 color, don't go beyond it. So more colors also mean that you would not have the vendor choices. What does this mean? A violet color brilliant laser dyes would be available only with one vendor, and that's why they'd be more expensive. You can't replace it with any other substitute. All of these things you must decide at day 1. Otherwise, 6 months later you have that panel ready, but your finances say we have spent enough, we can't spend more. So don't go for a 12-color, 14-color, 16-color machine because TMH does it or AIMS does it, or for that matter Mavi Cancer does it. Please don't do it because you may have to stop doing the entire flow assay 1 year later. So besides the flow machine, there are a whole lot of other stuff which do not cost too much, but yes, these are also required. Choose your people well. Why I'm saying so? Because again, coming from very different backgrounds I've worked in, sitting at All India Institute, you have PhD students, trainees, endless workforce who is there, who are willing to learn, who have their projects going, you have no dearth of trained hands. You come to a private standalone laboratory or a laboratory chain, the objective is to keep the cost minimum. You have one technician who is very good, but when that technician goes, you do not know how fast I'll get a good trained technician, how fast I'll get another one, because 2 technicians would take twice salary. You're in a corporate hospital. Is your flow machine the core focus of that corporate hospital? Depends on how strong your medical oncologist or hematologist is. Right? So choose technical workforce. Again, go back to your habitat. Where are you sitting? Would the trained people willing to come? Or if they're willing to come, is your organization in a situation to pay that salary? So start your work at that. That doesn't mean that so I'm come to that. If you have a lot of money, less technical staff, what to do? You have less money, highly trained people, then what to do? But if you have no money and no people, then also you can do something. So let's see. Highly qualified, highly trained people. Yes, one person is there, but if that person is on leave, what to do? So that this first one is desirable, but not necessary you will have it, but it again should not be a deterrent in reaching your ambitions. Semi-trained and untrained people. So trust me, a person who is not trained, willing to learn and intelligent is a more important asset. Stick to him or her, train her, get more untrained people, train them, make your center a training center. It's not difficult to do. You only need dedicated, intelligent and honest people, and there is no dearth of those people in our country. So these bigger institutions where we got trained, they're open to training people. We love these organizations love teaching. So send your guys there for CMEs, conferences, they can be trained. But how to start? They are not trained, but you want to start. So if human resource is a challenge, so in smaller cities you have good people, bigger cities we have other challenges. So that's those are the HR policies. People, Dr. Pranta, AI, digital is the era, people love machines. We have stopped loving people. And love for people and getting that back is even more rare. So if you're working in a high workload laboratory, you have a very ambitious oncologist, hemato-oncologist, and your organization, because he has a transplant ticket, which is a big ticket, so your budgets are unlimited, but your HR policies, highly skilled, dedicated people are missing, then what to do? And this solution, everybody will be happy. Dr. Panther, Dr. Tufan would be the happiest people on earth if you get this done, this solution, automated. And everything from sample pipetting to analysis can be automated today in flow if you are rich, if your hospital is rich. So you can do flow without people? Yes, you can. Which step of automation you want? So we are somewhere in the middle. Fully automated workstations are possible. Then there are semi-automated solution, which means they are ready to use kits. One is that you automate everything. You just load the reagent and the sample, it gives you the entire stuff. Those reporting softwares are not yet mature enough to work without a hematopathologist, so we are still there. But you have kits which are ready-made, validated reagent combinations. What does that mean? Just add the sample after minimal processing. Technical errors are minimal. Because you have an 8-color machine, there is an 8-color cocktail. You just prepare the sample, add it to that cocktail, and minimal processing, it's all done. And there are automated analysis software also. So I said first, choose your machine well, understand your habitat, don't get an elephant for a place which cannot accommodate it. Then choose your people well. Choose people with whom you can sustain. Don't choose people who are one time and then you do not know how to replace them. Third thing is choose your reagents well. This again you have to do at the outset. So there are individual antibodies. You have all the organizations panels. There are 6 color, 8 colors, 10 colors. Dr. Prashant talks of 16 color diagnostic panels. So individual antibodies, you have ready-to-use kits and you have dry reagent tubes. So this one is the best, but this requires a sustained, good technical workforce, because when you are pipetting 2 microliter, 3 microliter antibodies in one tube, which requires 8 to 10 to 13 such pipettes, best of the technicians go wrong. So this is doable when you have a dedicated workforce, not one, more than one, 2 to 3 people. Second is the ready-to-use kits. So individual antibodies, they need to be designed. Each antibody needs to be titrated. It needs to be titrated at day 1. It needs to be titrated every time a new lot comes, which is a lot of work. Then it requires validation of the panel. So it requires expertise. It requires good dedicated tech, but it gives you flexibility. So if you have a 6-color panel today, you can move to 8-color, 10-color, 12-color as the capacity increases. And it also gives you another flexibility. I'll show you how. You have designed a leukemia panel which has a T tube with CD4, CD8, CD3, 56. You can use the same antibodies for your DBNK assay. You can use the same antibody set for your CLPD panels. This is something which you cannot do when you take ready-made cocktails. So this is the best, but for this, you need to be sure that what you are setting up, you can sustain. Then there are pre-mixed antibody cocktails. These are fixed combinations, but again, as I said, if it's an 8-color cocktail, you know that all of these antibodies would be in the required amount, which is not the case when we go for more than 6 to 8 color in a manual pipetting assay. It requires less extensive validation. But again, it comes with a caveat. If you have a low volume center, the expiry of these cocktails is very little. Not very little, but at least it would turn out to be less than the individual antibodies. So it turns out to be more expensive. You can use it if you say working in a NATO organization where you know what assays are coming to you, or you're working in a TB center and you have fixed assay requirements, then you can easily go for these assays, these kits. Then this is relatively new but very interesting, and dry reagent tubes or cocktails. These are also pre-formulated antibody panels, but what they have done, they have lyophilized those all 8, 10, 13 color antibodies, to which you just add. The shelf life is more than those liquid cocktails, and I'll come to why this still holds a place at every center, because it allows you to do more complex assays with relatively less expertise. So I'll start with acute leukemia and CLPDs, which is a basic requirement for any oncohematology setup. Looking at the time that's there, I'll just quickly move on to the minimum requirements for an acute leukemia panel. So if you look at this WHO classification, this is the MPAL classification, and this recognizing a bilinear leukemia does not require too many antibodies. This is just 8 to 10 antibodies. So what does this mean? Setting up an acute leukemia flow cytometry is not difficult, but if you're using an 8, 10, 13 color antibody combinations and you try to do myeloid T, B, lineage, all of these together, this becomes an enormous amount of cost. Each antibody is close to 150, 200 to 400 rupees per test. And when we move from 10 to 13, you don't get more money for it. Okay. So what we do the lineage characterization first. This tells you cyto-MPO 117 will tell you it's myeloid, 79A 19 will tell you it's B, C7 and 3 will tell you it's a T. And it will also tell you if it's an MPAL. But what can be missed is the monocytic, because 64, 14 are not here. So what we do the screening tube, and if it's a B, we do a custom myeloid where we have the necessary myeloid and a B tube, which allows me to do the MRD markers as well. So in diagnostics today, you have to, at the end of, besides the diagnosis, you should be able to tell the clinician what are the MRD markers, what are the LAIBs. And this two-step approach allows you to do that. So just quickly showing you, this is a 10 color panel. You can similarly, this is a 13 color panel at Mavi cancer. So we do the screening tube here first. Whatever it tells us, based on that, if it's B, we do the entire B along with the custom myeloid. If it's myeloid, we just do the myeloid. If it's a T, we do the custom myeloid and T. If it doesn't tell us anything, we do the entire thing. So we save a lot of money and we give a better report, because if it's a T, we know we have a CD1A, we have TCR-GD. It's a complete panel, which we cannot do if we are doing a 6-color and 8-color panel. So this makes the best use of the best technology without increasing the cost. The cost doesn't become important, the patients can't pay, and the government also cannot pay. So somewhere this money is coming, you have to optimize it. So this two-step approach allows you to do that. Interesting part is that this two-step approach you can do by single antibody combinations, and it is also available as a lot tube, screening tube from a company which is a lyophilized tube. So if you're beginning, you can buy those tubes, put up a screening tube, but the subsequent panel you will have to do manually. For that also you can prepare cocktails, which increases your technical workforce requirement. Similar approach can be used for CLPDs. Again, this is a screening tube which tells you it's a B or a T or an NK cell. I love this way because although most of the CLPDs are B, but what do you do when it's a T? You have already used close to 30 antibodies. If it's a T or NK CLPD, you are again increasing the cost immensely. So we and this way, so if it's not a CLL or non-CLL, it's a BCLPD or T or NK, the first screening tube itself tells that. And complementing to this, there's an LST tube which is available. So again, you can start a CLPD by this approach. Even if you have minimal workforce, LST tube has dried reagent cocktail, minimal sample preparation is required. More colors again helps, because this single tube tells us not just B, T, NK, we have 13 colors, 223 FMC7, it tells us it's a CLL or it's a mantle or something else. Most of the time we don't need anything else. So just a quick, how do you do analysis in this screening? To just look at this box. This first tube tells you how many are the 19 positive cells, how many are the B cells, how many are the plasma cells, how many are T and NK cells. So you have a preliminary diagnosis right after this tube. Commercially available tube has kappa lambda, it's also added to this. So this is that's a complete solution to at least a CLL. I'll have to, so for the cell counts, this was what the most of the centers would require cell counts. For cell counts, we have ready-made kits available. But again, if you are planning more than the cell counts, go for individual antibody panels. Because then you can use the same antibody combination in also. You're coming back to this T tube. This T tube can be common for all the panels. You have this T tube. This can be used for TB-NK. This can be used for CLPD and for the acute leukemia with the minimal modifications. So the applications of flow go on and on and on, but understand your habitat. If it requires supporting a huge workload of oncohematology, you will need all of this, and all of these are doable. A lot of it is automated already. For the rest, the you can easily standardize the assays. They are not any rocket science, but the heterogeneity of the work support is heterogeneity of the work environments is extreme. But do the best you can in whatever situations you are in, and remote support is available. That's the revolution of this era, the digital and AI era. Nobody should be deprived of the best support possible. So if you have a flow machine lying there, try to understand the needs and get going. There are automated solutions, there are semi-automated solutions, and you can get an expert on board wherever he or she is available. So just go slow and understand the work needs and your ambition levels, balance them all, and move. Speed thrills, but it kills, but you still have to go. Thank you.
Thank you, Dr. Sonal, for giving brief detail regarding starting flow cytometry lab with limited resources. Main thing is that the madam is agree with that. We start with simple flow cytometer with less number of antibody panels, 8 to 10 antibodies. So it will reduce the complexity of the compensation and preparation, and trained technicians are required, make a standard operating procedure. So it will help you in doing the flow cytometry. Any question if anybody want to ask?
I have worked on this machine way back in 2004 and 6. My question is, if the blastoid cell present with only CD4 and 8, could you diagnose is a case of ALL?
Only CD4 and 8?
Oh, co-expression on same cell, CD4 and 8.
So that is a feature in ALL, but saying that every CD4 co-expressing case is a acute leukemia wouldn't be right. We need the immaturity markers. At least the minimum requirement for calling anything as a T is a surface 3 dim or negative. Rarely it can be a bright 3, but we do need to see that these are immature T cells.
Last question is, in era of AI and automation, could you diagnose all cases of acute leukemia without going for morphological examination of bone marrow?
So I skipped many of those slides. I am the biggest protagonist of morphology.
Yes.
Do not stop doing MPOs. MPO on flow should be supplemented with a cytochemistry MPO and if possible an IHC MPO. So in a good number of cases you have very little population of blast on MPO. We have even seen cases where MPO is completely negative. We had on extensive screening in 1,000 blasts, we saw one blast with organ. One organ makes it in myeloid differentiation. So one should never stop doing cytochemistry MPO. And many centers stop doing it once they have flow. That's a very bad thing to do.
Okay, thank you.
I just want to give one comment with your permission of the chair. And the comment is ki Dr. Jain, you have been doing a fantastic job for this last so many years, setting up flows in this. It is not a joke. 6 big centers in which you have set up flow. I think you need a standing ovation. Okay? So this is good. No, because having set up flow in 2009, yours truly, I know what a Herculean task this is. And coming to my main comment is, the Royal College of Pathology of Australia has come up, as the chairperson said, about minimal antibody panel. Very right question by you. Actually, in 2009, one of my MD students, I was the guide, I had given this panel. Without realizing that in 2024, the Royal College of Pathology will ask me to review a meta-analysis in which they have introduced this minimal panel in 126 countries. And they have heavily quoted my primitive article of 2009.
So that's what it is. So that's why...
Yes, 7 antibody panel, which actually diagnoses in a resource setting in a country where you cannot, this 10 color, 12 color, 16 color is a commercial gimmick. So you need basic panel in a country which has basic needs. So 7 to, Sumit Gujral had come with the 10 antibody panel, we modified that to 7. That has now been implemented in, I feel so proud that they have referred to some of our, primitive research. So 7 antibodies.
So starting with 6 color machine, 6 color does a decent job for diagnostics. But if you have to move to 8 to 10 to 12 because MRDs become cheaper and easier with those, then the 2-step approach is the best, because if the patient doesn't have money or then your first screening tube of 12 color gives you the diagnosis. You may not move on to doing the second step because with the current molecular era, actually it doesn't really add much to say if it's an M7 or M7 other than APMLs. Rest of it is all the same. So thank you. Yes.
Yeah, just have 2 very small practical questions. Since you have set up lab in so many places, first is cause whenever we take count for the bone marrow sample, there's always small bony component is there. So the analyzer, it gets stuck, it shuts down. So as per your experience, which one is analyzer you can doesn't shut down so frequently and we can.
So that is a valid question, but we still do process bone marrows. Yes, you can dilute the bone marrow and do an assessment. And when you pipette, instead of putting that entire vial in the cell counter, take out some amount so that you're ensuring that there's no clot in that the sample that you're putting in the cell counter. It's a good practice. It should be continued, sir, because although you can also do an assessment, a rough estimate, if you're sitting at a center where you just have one counter and you do not want it to be clogged, you can do a rough manual assessment on the slides.
Yeah,
that age-old traditional counting methods are helpful in practice.
I mean, shuts down, we do the same. Yeah, one more thing, we actually I work in a corporate setup, and we are in a process from switching from BD Canto to the Lyric.
Okay.
Now, getting a budget, for the validation is a big task.
So moving from a Canto 8 color to a Lyric what? 10, 12 color?
10 color.
Okay.
So my question is, like, you have placed in so many labs, like, getting a budget is a very big problem.
Absolutely, but why do you want to shift is the question.
No, I'm like, first, Canto machine is not working so well now, so we want to shift, and Lyric is a better one we thought of. So
what are you going to?
And was getting a better deal also.
So your constraint is you want a machine, but you don't have the budget for it.
No. What I mean to say is, like, because you have set up in so many places, do you ask okay, these will be like minimum number of cases for AML MRD or a myeloma MRD? That you can do. I
again had to rush through my presentation. Time was a constraint. Don't be in a hurry to do high sensitivity assays. Okay. If you started a flow lab, do it for decent 3 to 5 years. That will allow you to understand the limitations of your place, your reagent supplies, your technical workforce. The reason being, you do not have a CD73 in your diagnostic panel, you can run it. It's perfectly fine. But that CD73, if it's an LAIP marker, you run out of stock for that antibody, or your technician forgets to add that antibody, and you call it an ALL MRD negative, then you are in a big trouble, right? So do not at all be in a hurry to start high sensitivity assay. This is just one part of it. Very high precision accuracy is required. Reaching a sensitivity of 0.01% with more than 1 tubes in place is not, it is a Herculean task. When you're adding 12 antibodies, some of them are 1 microliter, some of them are 3 microliter, the antibody vials are colored. Your best technicians cannot see that, and that antibody is there in the pipette or not. So understand your workforce well. Again, good thing is that we are in digital era. You have to start an ALL MRD. There are set cocktails available, but there are 8 color cocktails, dry reagent cocktails. That takes away this headache that all these antibodies have been added or not. And they have a set protocol, minimal sample preparation, you do it, and at least the technical part is sorted. We are away from the analytical analysis, but I'm talking about pre-analysis part. That's complex. You have to know the people who are working on the bench well before starting MRDs. Do ALL MRDs for decent 2 years. BALL and myelomas, ready-made reagent cocktails are available. You are under too much pressure to start it, then only buy them and start them. For AML, wait for another 3 years. So I had to skip. If I can go back to those slides. I mean, in a diagnostic sample, marrow is full of blasts. Your processing has made you lose some 10% blast. It will not make a difference to your diagnostics. But that window of error you do not have with MRDs. So stakes are high. Wait to start them. Tread slowly. Thank you.
Thank you so much, ma'am. Can we please go for a photo session right now to commemorate this wonderful talk on how to set up a flow cytometry lab? Thank you, Chairperson, sirs, also. Next up, we have the next talk on the scope of pathology, a scope and opportunity for an MD pathology student in the field of hematology. For this, we have the chairpersons, Dr. Shrikant sir, additional professor of pathology at AIIMS Patna. A very warm welcome, sir. We have Dr. Sonal Jain, ma'am. Ma'am, please come on stage. And we have Madhu Kumari ma'am, Assistant Professor, Department of Pathology at AIIMS Patna. And for the other clinical, if you have any follow-up questions in this round, please mail to the respective faculties over here, and they'll be getting back to you. And for the clinical, for this side, there's the hall B. We have the other lectures going on for the clinical hematology. To the respected chairperson, sir, may I ask you to please introduce the next speaker for the session?
I feel privileged to invite Dr. Abhishek Sharma to the dais. He is a consultant hematopathologist and lab lead. He is an DM hematopathology from PGI Chandigarh. His present affiliation is with NRS Medical College, Kolkata, and his area of interest includes coagulation, flow cytometry, leukemia, and he's being attached with so many societies and the advisory committee of Hemophilia Society, Government of West Bengal, and so many publications with chapters. I'm very pleased to invite Dr. Abhishek Sharma, and this topic is very close to my heart personally as well. I wish the budding pathologists and hematologists are there in the audience to take the full advantage of this presentation. Over to you.
Thank you, chairpersons. And at the onset, I thank the organizers, Dr. Avinash and his team, for giving me this opportunity to talk on this often less talked topic of scope and opportunity for MD Path students in the field of hematology. And this is the first time I'm talking on this topic, so I think I'll try to do justice to the topic assigned to me. So when a student completes the undergraduate or the postgraduate course, the first thing that comes to the mind of an individual is what next? So what specialty or what super specialty to choose? So there are many options. Of the options, there can be some conventional established specialty, medicine related, surgical related, cardiology or others, or there can be some new emerging establishing specialty in the form of clinical hematology, hematopathology, nuclear medicine or others. And when we have a lot of choices, whether we go to a market or whether we are attempting an MCQ question, we lead to a lot of confusion, and we tend to take a wrong decision. But while choosing a career, we need to be very meticulous because it is your choice. Whatever you choose, I think should be stable, and it should lead to satisfaction, not only self-satisfaction, your job satisfaction, and should also maintain the quality of life. And as we know that no individual are alike, and there is inter-individual variability, so the specialty as individual choose will also vary. And before I move forward, I quote William Osler, who says that if there was no greater variability among individuals, medicine would be science and not art. And we understand that medicine is a bit of art. Just to introduce the topic to the young budding future hematologists, that what as a hematologist we do. As a hematologist, we tend to treat two broad categories of disease. One is the benign disease, which deals with bleeding disorders and others, and another is the cancer or the hemato-oncology group, which is more dreadful. And as a physicians or as a lab persons, we tend to treat or face diseases and fight against them, and not only fight hard to defeat them. We need to collaborate with other departments to prevent the disease, and if the disease is not preventable, then for early diagnosis. And here lies the important role of the pathologist to bring up the early diagnosis so that the early treatment can be put forward to bring smiles to the patients. And this can only be done by joining hands with different departments. So before I move forward, I'll just highlight that there is a deficiency of supply and demand. There is a global demand for hematopathologists in the field of hematology, and the data suggests that as the number of year increases, there are new cases, cancer-related cases, and so the cancer-related deaths are also increasing. And it has been estimated that hematological malignancy itself comprises to about 6% of all cancers. And what is more astonishing is that if we move at this pace, we will end up to close to 24 million cases by the year 2030. If you look at the benign disorders like hemophilia, Was the data presented in 2020, where we see that there was marginal improvement in the rate of diagnosis of hemophilia from 12% to 26% in a period of 2 decades. And again, if we move at this pace, we will miss off about bulk of the cases of hemophilia. And this is the standard diagnostic approach that one follows in a standalone lab. And if you see that genetic testing and specialized testing is the core of diagnosis of hemophilia, and here lies the importance of the hematopathologists which can take up this skilled test to bring up the correct and timely diagnosis. The Indian picture speaks no different stories. The India itself comprise about the 3rd highest case of hematological malignancy, and the projection is the rate will increase in next 20 years. What is more astonishing and paradoxical is only 12.5% of these patients gets diagnosis in early stage. So here the pathologist can make a big difference. So maybe 10 years down the line, if we have good pathologists or hematopathologists, this data will change and we will have more number of patients getting early diagnosis. Can we prevent the cancers? We talk about healthy lifestyle, we talk of eating healthy, but we know that there is no cancer specific diet. The best way to go is in cancer screening. And for cancer screening, multidisciplinary approach is the way to go forward. And in this multidisciplinary, the lab person will always find one place. And as I said that in hematology, the cancers and blood-related disorders are increasing, and there is an acute shortage of trained hematologists, and there is a strong demand. With the growth of molecular labs and BMT centers coming in, hematology is a good specialty to look forward. And as we see that this equilibrium, there is more of the demand and less of the supply, and we need more hematopathologists to treat the subject of hematology as a whole. As a physician, as a clinician, gets pride in taking the clinical findings or clinical examinations. So a good morphologist will always take pride in the morphology. Based on the clinical finding, the clinician approaches some investigations. Based on the morphological clues or morphological finding, a good morphologist will take on the ancillary tests like immunohistochemistry, FISH, molecular techniques, or flow cytometry, all with the attempt to arrive at a correct diagnosis. And one should always work in tandem with the clinical department and the lab department. There has to be a proper communication. So if I think of these two islands which work in isolation, there is a substantial gap. And I firmly believe, and I believe that most of us believe, that there is some bridging gap between a clinician, what does the clinician ask from the lab person, and what the lab provide. So if we have the clinician on the one side and the lab person on the other side, I believe that the bridge can be perfectly gapped by the presence of an smear called the peripheral blood smear or the bone marrow smear, and this can be even strengthened by integrating the upcoming integrating ancillary test in the form of flow cytometry ancillary test as the case demands. And it is the only specialty where both the lab skill and the clinical skill both are tested in a single department. So the person needs to develop skill, both clinical as well as lab findings, and to find a good hematopathologist is extremely important in the diagnosis. And we know that to find a good friend is always quite difficult, and this is a very rare picture where we see a lab person or a clinical person sitting just behind the microscope or near the bedside for a case discussion. I'll give you more scientific evidence to justify that we need a good hematopathologist for a correct diagnosis. This is a common glass slide, a bread and butter for any pathologist or hematopathologist, which contains loads of information, which can be a burden to an individual. And if we correctly sequentially analyze, we can convert this information a good learning, and there lies the importance of a correct interpretation of a good morphologist or a hematopathologist. Peripheral blood smear can also be regarded as a window for bone marrow, which will open to the complex world of clinical diagnosis. And as we all know, no finding, whether it is a peripheral smear or a bone marrow, should be interpreted in isolation. It has to be correlated with your clinical findings, your histograms and CBC parameters. This is an interesting study. The results shows, I'll just take up the MDS data where the findings were analyzed by the routine pathologist and were cross-checked by the hematopathologist. If we see in the left lower side of 266 cases of MDS were diagnosed by the central lab team. if we are rechecked and we got a concurrent rate of 72%, that means 25% were misdiagnosed or overdiagnosed as MDS, which is a good enough number, and lies the importance of a good morphologist in the correct clinical diagnosis as far as hematology is concerned. Now there's some good news for pathology lovers. So pathology is now regarded as a clinical subject, as a core clinical discipline as far as NMC is concerned. And there is an integration from bench to bedside diagnosis. It emphasizes a clinical decision-making skill, which is extremely important, and it merges the various clinical departments, and it is the only specialty which connects microscopic finding with real-time patient care. Why one should choose hematology? Because it is a rapidly evolving field which links both the lab side and the clinical side, and I said there is a high demand for specialized diagnostic skill with expanding scope of molecular diagnostic and flow cytometry, and it is the only specialty that speaks both with the microscope and with the stethoscope. And we as a pathologist or hematopathologist have to find something which is hidden in our slides or something, so we are often regarded as detectives, and the slides are our crime scenes. We need to extract fruitful information, timely fruitful information to help our clinicians. The job market for hematopathology is excellent because it has been shown in recent article that there is a shortage of hematopathologists in the coming next decade, and with the growing population and the increased incidence of disease, there will be close to 6,000 deficit of hematopathologists till the year 2030. The Indian story speaks the same thing. In contrary to 3 lakh medical diagnostic laboratories, there are only a handful of 5,000 qualified hematopathologists. So shortage of qualified hematopathologists needs to be built up, and the rising population will present an extreme challenge to the subjects of hematology if we don't have a trained qualified hematopathologist. Does lifestyle matters? Yes, if you want to have a correct, good quality of lifestyle, hematology is the way to look forward, because again, this is not absolute figures, but they have less working hours in comparison to the other specialty, depending on which center and the workload. There is above average professional satisfaction, family satisfaction, respect, and average below average stress as far as hematopathology is concerned. Obviously, it depends on the center and your workload. And as I say that, the genetics loads your gun, but the lifestyle puts your trigger. So the lifestyle is an important thing to be considered when you're choosing your specialty. Is there a scope of hematology in MD Path students? Yes, because lab hematology is a vast subject. There have been budding branches from this core subject. First is the morphology or the morphometries. Coagulation, we often talk of coagulation, and I quote Dr. Nair, who often says that coagulation is just like love. We talk about coagulation, but everybody talks about it, but we don't understand what is it. There is a scope of hematology lab, there is hemato-oncology, there is another specialized branch like molecular lab, cytogenetics lab, genomic hematopathology. There have been integration with transfusion medicine, and there is always a scope for research and clinical trials as far as hematology is concerned. What skills does one need to acquire while doing a hematopathology or hematology? First is the morphology, maybe a peripheral smear or a bone marrow, followed by advanced diagnostic techniques. You need to learn about the quality assurance, clinical research methods, and apart from having a good eyes, we as a hematopathology should also have a good communication skill. We had a session, I think in Hall B, where communication was taken. I missed that session. I think a lot was discussed in that also, because communication is something that can lead to reduce the error in judgment as far as the lab diagnosis is concerned. For example, if the patient is on therapy, and if you get a diagnosis of maybe 30% myeloblast, the diagnosis changes to therapy-related myeloid neoplasm. So always communicate with your clinical counterpart and the vice versa. And in hematopathology, we need to palpate the cells with our microscope, and this is some skill that needs time and dedication, but it will come one day. Do we have respect in the medical community? I'll say yes, because hematopathologists are often called Sherlock Holmes of medicine. They are trusted by different disciplines. They can be cornerstone of life-saving diagnoses like leukemias, APML, DIC, aplastic anemia, and they will be the leader in tumor boards, in transplant program, in clinical pathological correlation as there is live telecast in PGI Chandikar, and pathological autopsy, however, they are done in a fewer centers. Again, I'll just brief on some forms of morphology. Morphology is the first way to go forward. I show this picture in few of my presentation. Can anybody identify this individual? Who is she? Okay, can anybody identify the morphology of this individual? Is it very aggressive looking or a very indolent looking? I'll say that probably very indolent looking, but if you Google this picture, you will be surprised to know that she is Mary Bell, which is a murderer of 10 children. The point I'm talking about this is, as a hematopathologist, we don't need to just look at the morphology of the cell. We need to know the character of the cell, or probably read the mind of the cell, which is always not possible on morphology, and there lies the importance of integrating ancillary tests. I'll just talk about one ancillary test, that is immunophenotyping, and we have immunohistochemistry or flow cytometry is the way to look forward. And to know what is abnormal, we must always know the normal. That is for the same reason we are taught physiology in our first year, followed by pathology in the second year of MBBS. Basic outline of how the flow cytometry abnormality can be dealt with. Some have been dealt with my previous speaker. We look for cross-lineage expression, something which is not normally present in an individual, or something which is present but is present in an abnormal site. We call it asynchronous antigen expression. Or there can be an over or an under expression of an antigen. Monocytic lineage markers, each marker of a monocytic lineage will have an HLA-DR presentation. So if HLA-DR expression is absent in any of the lineage, that is itself is an abnormality one should pair. Morphology, but morphology has its limitations. If we are going to find one abnormal cells in the background of millions of normal cells, suppose if we are doing an MRD analysis, we tend to lie in a problem. We will end up in something like this, finding a needle in a haystack, which is not desirable. So we need to be smarter. We need to use the available technology in the form of next generation sequencing flow cytometry, multicolor flow cytometry, or other available molecular techniques. And as I said, in hematology, the cell will always speak. You need to have a good ears to listen it. The job sectors, they are quite, we can have an academic job sector, private, research, government, public banks, pharmaceutical companies, blood banks, and an NABL assessors are the different sectors that are available in the field of hematology. As I said, in an academic career, there are super specialization courses adding up each year in different medical colleges with the fellowship programs. There are job opportunities in private markets, in international opportunities in the form of fellowship and other certified courses. And hematology is not behind when we talk about research. There is scope of research in the clinical trials. There is a scope for diagnostic, novel assay development. AI and digital pathology is the way to looking forward, and bioinformatics as well as. Talking about the burnout, in terms of hematology, there is moderate amount of burnout, but that can be decreased with adequate lab support. If you have a good lab support, the clinician will be blessed to have it. And hematology is one of the highest paid non-procedural specialty to look forward. And as I said, we need to balance our work and life, and work-life balance is a treatment that we often forget to prescribe ourselves, which needs to be remembered while choosing your specialty. What is the future trend? There is a concept of precise medicine, targeted therapy, NGS, point of care, and digital diagnosis. So hematology is a long way to go forward as well as in terms of future trends. There are challenges which in terms of hematology as a career, there is always competition, and to be competitive, you need to upgrade your skills. You participate in CMEs and conferences like this, and you have to balance both your clinical and your laboratory expertization, and collaborate with the nodal centers. Some of the high-end diagnostic tests, if it is not available, you can refer it to some nodal centers, so you need to have a good networking, and conferences like this are a good opportunity. So the roadmap for MD pathology graduates is to bring strong core clinical labs, to pursue specialized training, publish your research, networking via conference, and stay updated with the technology and the recent guidelines. I'll just take two cases, one from the benign and one from the malignant part, to show how an hematopathologist can change or save a life of an individual. So this is an HPLC curve, and what abnormality do we see is the D window showing a 3.1%. So what will be the diagnosis? Can anybody from the audience, any junior resident can take up this? D window 3.1% in an HPLC. Any diagnosis to offer? So we cannot offer any diagnosis because 3.1 is too less to call it a D heterozygous or what. So again, we have to be very meticulous. We have to communicate and take a proper history. Probably the patient was transfused, and the transfused blood white adding up to the D window. Apart from that, HPLC, there can be some pre-integration peak in the form of bilirubin peak that can be also picked up, and you have your biochemical report to always correlate. There are other forms of integration peak in the form of acetylated HbF. If there is increased HbF, we'll always get a pre-integration peak, and there are other established causes of pre-integration peak. Can we pick a non-HPLC finding on an HPLC? Definitely, if you look at the P2, if it is more than 6.5, we can have an idea that the patient might be suffering. So these all information lies in the hand of a good hematopathologist. Apart from giving the diagnosis, you are also advised to give advisory service and to add up some other informations. One malignant case, this is a child which was suspected to have some sort of lymphoma, maybe Burkitt's lymphoma. We had some blastoid type of cells, close to 60% on peripheral smear. This was the typical immature looking cells. This is the bone marrow, which was hypercellular, and sheets of atypical cells, higher magnification. We can see a lot of cytoplasmic vacuolations. So probably what we are dealing with, any guesses? Burkitt. So probably maybe on the Burkitt. So we did an MPO and a PASTIN, both were negative. This is the trifine biopsy. In the interest of time, I have not added the flow cytometry part. We got a good MPO positive with myeloid marker 1333-117, highly positive, with some monocytic markers also positive, and we gave a diagnosis of AML with monocytic differentiation. But on cytochemistry, the MPO was negative. We went back to our MPO slide, and we can see that a single isolated OR rod we could find in the second picture. So morphology was there only to be picked out. Initially, we missed this MPO on initial screening on morphology, but again, looking at the flow cytometry, coming back to the smear, we thought that they were positive, and the diagnosis could easily be picked up on morphology. So morphology is always the look forward, and the ancillary test will only guide you in making a concrete diagnosis. To summarize, we should have an integrated approach. It all starts with morphology. Then you have to use your ancillary tests like molecular test, your FISH or cytogenetics, and colorful world of flow cytometry to add colors to the life of your patient. Which technique to use? Which is better, whether it is the flow, ISC, or molecular? It's always, I'll just finish up in 1 minute. It's always better to have all in one team, but it doesn't matter. If somebody asks me which is the best technique, I will say it depends on the particular case, a particular day, which person performs better, and that is the way to take forward. ISC and flow, should we care? Yes, we should care, but we should use it meticulously, or we will admit a male patient in the maternity ward, because nowadays there is molecularly defined leukemia and lymphomas heterogeneity, and recognizing this molecular heterogeneity is essential for therapeutic purpose. So current rates, we did an online survey about number of institutes which are having clinical hemat, and how many of them are from the PATH background. Since the central institutes are not eligible, so we excluded that, and this is the rough display. We can see that pathology takes place in most of the centers, and so, and even in the DNB or the clinical hematology. So pathology has a place, but we need to build on it and increase in the number of terms of MD path background taking hematology as a subject in the near future. So a drop of blood or a smear always tells the story, and you need to be a good storyteller. And this is my take-home message. I'll again quote this novel which Dr. Chatterjee said. So this is a beautiful novel in which their decision whether the leg of a girl should be amputated or not should be taken. So you play an important role in the life of others as well. So be proud of it, and always ask for help, because ask for helpers to help you, and use your technology wisely, because otherwise you'll end up Alexa asking what cell it is. And on the lighter note, to make the mood lighter, this is the image of the drones which we have seen recently, sooner or later, and I take this opportunity to thank the women power of India for this wonderful expression. And we have all seen drone in our life, in our childhood life in a class, some drones flying out, and I don't wonder why teachers are also known as drone acharyas. So thank you all for your patient hearing.
Thank you so much, Dr. Abhishek. It was extremely interesting, and it began to look like hematopathology is the most glamorous of all branches. Given a choice, everybody should pick it up. So having said that, one comment is the hematopathologists want to make a comment that hematopathology is not about flow and molecular. I cite a case for an example. A 55-year-old lady, she had breathless on exertion. She has been given IV iron infusions, and her hemoglobin didn't come up. The doctor suggested to her that you do a bone marrow now. And I was surprised to see that only tests available were the CBCs and iron ferritins, and an iron was given with a ferritin of 500. And now the next test advised was a bone marrow. So what does this mean? We have to tell doctors that anemia is diagnosed on peripheral smears and peripheral investigations. That female just had a thalassemia trait. And that's why hemoglobin, on digging out, she said she has a family history of trait. She has always had this low hemoglobin, just dipped down to 2 grams recently because she has a unregulated thyroid and all. So what I'm just trying to mention to you that you have to train yourself in basic skills. For advanced, the world is there to collaborate. Everybody doesn't have to know flow and molecular. They can be safely sent to higher centers. You can safely get expert consultations from everywhere across the globe. So it's important to do your anemias good, important to do your coagulations well. And Dr. Pati and Tufan sir possibly can comment on it.
Dr. Abhishek always takes a good lecture. Also, I'm good that I'm hearing today. I have to give a comment, basic comment to our pathologists, basically, because if you remember, all our throughout India, the MD pathology, in that histopathology, we are all histopathology super specialists. Whenever after 3 years, we are really taught the maximum is the histopathology. But a large number of MD people are really will practice hematology in their day-to-day practice. They have to see the peripheral smear and basic tests. And problem is the interpretation of a peripheral blood smear is not that easy. And particularly anything beyond the normal. A lot of pathologists just think they are blasts. That's a deficiency. I say that it is required for MD pathologists, those who are practicing hematology, basic hematology in their practice, should get some training in a few months, maybe 3 to 6 months training. That will help, but they're getting the confidence not to do silly mistakes.
I think I'm totally agree with Dr. Sonal. So the hematopathology is not only the molecular, not only into the flow cytometry. The important thing is that the majority of the setting we need to diagnose by the basic tools and technique. You have to have a specialist, you have to have a important emphasis on that. Then only the majority of the diagnosis we can make. And without the proper diagnosis, I think the treatment is totally in the erroneous and totally in the wrong direction. I think to improve the common gadgets and the tool, if we can able to acquire it, then the problem of the common things we can solve in our day-to-day clinical practice.
Excellent insights from the people, great teachers sitting in front. I think coming back to the session and the topic itself, I would request if any of the budding pathologists, particularly the hematology pursuing postgraduates, if you have any query to ask, because this was a topic based on the career aspects, career prospects for people from hematology background. So if you have any question to ask, you are most welcome, because other insights can always go on over the tea, over the coffee. And
I hope MD pathology students are still in the hall.
Yeah, I can see and I recognize many of the faces.
Even 1% are motivated, then the job is done. So
no,
we will have the fresh data coming in.
It was truly motivating, Dr. Sharma. It was really. So let's declare the session over. Thank you for an excellent presentation.
Thank you so much, sir, for such an enthusiastic session and definitely steering us all to take up hematopathology. I would request the chairperson to join the speaker for a photograph. I have an announcement to make. There is a simultaneous session happening in Hall B in first floor for clinical hematology topics, so interested people can join the session as well. So now we have seen series of 3 sessions beginning with interesting cases, insisting on the importance of flow cytometry and how to set up a lab. So I think what's left is to get the lab accredited. So that brings us to the 4th session before our inauguration, titled as How to Get Your Lab Accredited. So for this, I would request the chairperson, Dr. Arundhati Ma'am, Associate Professor, Department of Pathology, PMCH Patna, to join the dais, please. Following, I request Dr. Pankaj Patel, sir, Assistant Professor, Department of Pathology, SKMCH, Muzaffarpur. I also request Dr. Ashish Gupta, sir, Assistant Professor, Department of Pathology, NMCH Patna, to join the dais as well, sir. Thank you for joining, ma'am and sir. I now request the chairperson to introduce the speaker, please.
In this session, I invite Dr. Gaurav Chavda for his insight on how to get your lab accredited. Dr. Gaurav is Additional Professor of Pathology with Laboratory Medicine at AIIMS, Bhubaneswar.
Yeah. At the outset, I would like to thank Dr. Avinash for inviting me once again this year. I am observing a change in the pattern of RAKTAVIGYAN. I have been a regular at this RAKTAVIGYAN conference. It has changed from the peripheral blood smear, red color peripheral blood smear, to a green RAKTAVIGYAN 2025. Very good afternoon to all of you. So today, I must appreciate that hematology conference, it is going a bit offbeat, off the track, covering the topics which are of we are daily facing in our routine clinical practice. Today these topics are being discussed. Rather than saying a potpourri of hemato-oncological cases, which Dr. Tathagat sir discussed with the beginning of this session, it would be a rather pertinent to say a potpourri of different offbeat topics which we are covering today. So continuing with that, I'll be speaking of on one of the very relevant topic to every one of us, to every resident, to every clinician, to every pathologist, whether he's a faculty or he or she is a consultant working in the private sector, how to get your laboratory accredited, whether it is important and what's the process to be followed. So let's start. So before we go further, let's start with the picture of, imagine yourself, you are boarding an aircraft. The crew is beautiful, the flight seems to be very clean, and suddenly you get to know that this airline has never passed a safety test or a safety accreditation. Would you still feel confident to fly in this aircraft? Will you? Maybe we may not feel confident, but we still may have to fly on that aircraft because we have already booked that ticket, we have paid for that. The same situation goes with our laboratory. Consider your laboratory as this aircraft which has not undergone any safety checks or safety accreditation. Similarly, when your lab does not go does not have a accreditation, that means does not follow does not follow that standard technical processes or that robust technical processes, it may lose the trust of the patient, it may lose the trust of the clinician. So it becomes very, very important to understand this process, how to get your laboratory accredited with an accreditation board or an agency. So let's delve into this. So first and foremost, we should know what actually is this laboratory accreditation. It's a formal recognition that a laboratory is competent to perform specific tests. It's not gonna focus on only one aspect, yes, whether you are using a good instrument or a good equipment or a good technician. It follows or it covers each and every process that is followed in your laboratory, that is as per the standard documented procedures. It goes beyond having a modern infrastructure. Modern infrastructure does not mean that your lab is producing a good quality test result. It actually verifies, this process of accreditation actually verifies that your processes are standardized, your staffs are competent, and your results are accurate and reproducible and meet the internationally acceptable standards. So technically speaking, it assures both quality management as well as technical competence. So before we get into how to get our laboratory accredited, the question is that why accreditation is important. So it, first of all, it validates our, it validates the technical competence. It ensures that the result and the processes that are being followed in the laboratory are technically sound and as per the standard documented procedures. It enhances the trust of the clinician as well as the patient in your laboratory, in your test report, which further overall improves the patient safety and the outcome. And more importantly, it facilitates national and international recognition, because some of the boards, they are recognized internationally or globally. Like your NABL is recognized globally because it follows ISO 15189. Your CAP, College of American Pathologists accreditation, is recognized globally. So it opens the door for more and more collaborations, more and more multicentric research and trials. So that's why this accreditation is important. So this accreditation is not just about passing an inspection. It's about embedding a culture of quality, developing a trust, which overall will result in a better patient outcome. Now, coming on to the what are the various agencies which gives this accreditation to the laboratories. So every country has got their own different boards. Like India has got National Accreditation Board for testing and calibration of laboratories, which is also referred to as NABL. There is College of American Pathologists, which is primarily a US board, but it is acceptable globally. Many other labs globally are going for it, who are particularly getting into international collaborations. Another international board is your JCI, Joint Commission International for Laboratories. And every country, like this CNAS is a Canadian Accreditation Society, which gives this laboratory accreditation. These boards are different, but they follow one standard set of procedures, that is ISO 15189, which is a standard which describes all the scopes, all the quality related policies, all the staff related policies, all the equipment related policies, how the equipment validation has to be done. So this all processes are included in this ISO 15189, which has got multiple clauses. So as I mentioned, there are different boards which provides you this accreditation for your laboratories. These boards may be different in their processes or in their documentation, but the one thing that is common is that they follow one common SOP or the standard, which is ISO 15189. Now coming on to the different steps, how a lab should be accredited. The first step has to be, it's a stepwise approach. The first step is that you should be defining your scope. By scope, I mean to say you need to know what all tests you want to include in the in your scope of accreditation. Then you should be identifying your gaps where you are lacking by comparing it with that standard. You should be developing your quality management system, doing all those documentation, writing up these standard operating procedures, doing internal audits, and by looking at the findings of the internal audits, taking corrective and preventive action, which are commonly referred to as CAPA. Once you are done with all these things, then you go with the submission of the application with the appropriate board, and finally get your assessment done and close your NCs and get the accreditation from the accreditation board. So I'll be going to all these steps one by one very briefly. So the first step has the scope of the accreditation. The first step, this is the first step. Now, what do we mean by scope? It actually means what all tests you want to include in your accreditation scope, or what all tests you want to get accredited. So these tests can be selected. It could be the department based, whether you want to get your all hematological test under accreditation or all biochemical tests, or it could be test specific, like I want to get only my CBC done. Now, how you are going to decide on that, what test you want to get under the accreditation scope? So the best thing is that start with the high volume and the critical test, because it is going to have the maximum impact. Suppose you take your CBC test, you are doing around 200 CBCs in a day. So it's wise to get CBC under the accreditation scope, because it is going to have a maximum impact on your quality, because this is the maximum volume test which you are doing. Apart from these, other factors like include the tests which have got validated methods, validated equipments. For that equipments you have got trained and competent staff, you have got aqueous coverage. So this is another way on the basis of which you can identify what all tests to be included. So it is not mandatory that you need to include all the 100% tests at the very beginning. Go step by step in a phase-wise manner by following these principles. Now you have decided your scope, what tests you are going to include in your scope. The next step is doing the gap analysis, which involves a thorough review of comparing your current lab practices with the requirement of the ISO 15189 standard. Okay, so this allows you to identify your deficiencies. Okay, now you have identified your deficiencies, make a targeted action plan to bridge those gaps. So in this way you can fulfill your deficiencies. Now once you have done the gap analysis, the next step is the developing a quality management system. Now quality management system is the backbone of your laboratory, which is a structured framework that brings all your quality initiatives together. So what are those quality initiatives which this quality management system incorporates? It includes your quality manual. That's the most important document, and often the first document which is seen by the assessor when they come for an on-site inspection to your laboratory. This quality manual outlines the policies and scope of the laboratory. The quality policy, which includes the commitment of the management, the defined role and responsibilities of each and every individual working in the laboratory, what are the various training which have been imparted to the technical staff, to the doctors and to the other persons who are working in the laboratory, and what are the measured objectives of the laboratory, what are the goals of the laboratory, what the lab is targeting to achieve in terms of quality. So the key component, as I mentioned, quality manual, it's the constitution of your laboratory, which includes all your quality policies, all your standard SOPs, how all processes and every aspect of quality which will improve the overall efficiency and the accuracy or reproducibility of the test. The other aspect is quality policy, which includes your commitment from the management. It primarily focuses on patient safety, accuracy and reproducibility of the test role. What are the other component is the defined role and responsibilities. Every person working in the lab has got a defined set of its role and responsibility. Suppose if a person is looking after hematology, so he is the one who will be doing hematological analysis, so that you can ensure the traceability of your each and every test result which is generated by your laboratory. What are the objectives of quality? For example, my lab's objective is to have a turnaround time of less than 6 hours, whether I am able to achieve it or not. So this is one of my measurable objective. My turnaround time is going to be less than 6 hours. So all these things are to be reported in the quality manual. Once you are done with your quality manual, let's talk about the documentation. Documentation forms one of the very, very important steps. No matter what steps you are taking in your laboratory, if you are not documenting it, that means you are not doing it. That's the simple funda of all the assessors, whatever board it may be, whether it is NABL, whether it is CAP, whether it is JCI. If you are not documenting each and every aspect related to the quality or related to the accreditation, that means you are not doing it. So what all documents have to be prepared? So you should having the quality manual, these SOPs for each and every test, which should ensure that all your tests are standardized, approved, and all your documents are version controlled. You should be maintaining the record of all your equipments, when they were validated, when their calibration was done, what is about their AMC and CMC detail, what is all details about their maintenance logs, about the quality control practices, all records about your internal quality control, external quality control, staff documentation, their competency testing, their training, and apart from that, incident records like whether any NC was observed or whether any complaint was obtained. So all these records have to be documented. Apart from that, other technical requirements include personal competence. Accreditation agencies want not only qualified staff, but they want your staff to be competent enough. So it becomes very, very important that a regular competency check has to be done, and regular training has to be imparted to all the training, all the technical staff working in the laboratory, all the doctors working in the laboratory. You have to look at the your premises and the environmental condition, the infrastructure, the space has to be adequate with following all the safety measures, the equipment, and the traceability document. This is very, very important. What does a traceability means? Traceability means every test result that is generated by your laboratory should be traceable back to the patient sample, to the equipment on which that sample was analyzed, and who was the person who analyzed that sample. So this, in short, is your traceability. So that record should be maintained, and all biosafety practices record has to be maintained. Now, once all these technical requirements are done, the next step which comes is performing an internal audit. Accreditation agencies, they want that you should be assessing yourself first for any deficiencies or gaps before calling on the final assessment. So one should be doing an internal audits like a mock inspection, okay, and any deficiencies which are identified, proper corrective and preventive action should be taken for those deficiencies. And once these corrective and preventive actions have been taken, they all should be documented. And once in a 6 month or once in a year, this regular management review meeting should be held, where all these CAPA should be reviewed, and whether any change has to be made in the quality manual, it should be considered in that management review meetings. Now till this step, once you have followed all these steps, this means you are well prepared for applying for a accreditation. So all preparation done. The next step is filling up the application form and making the payment with the accreditation agency. In India, the most common accreditation agency which is imparting this accreditation is NABL. Submit application to NABL or any other agency like CAP or JCI, depending upon your requirement. The NABL is going to review your application, and once they are done reviewing your application, they will do a pre-assessment by sending one assessor. This assessor will come and review your overall processes, and if any deficiencies are found, he will let you know and give you some time to cover up those deficiencies or gaps, and then a final date of assessment will be given. Then once you get the final date, that is your assessment day. An assessment team which would include your lead assessor and a technical assessor will come. The day starts with an opening meeting and the introduction, which is followed by the document review and the tour of your laboratory. The assessing team is going to observe your all testing procedure. They are going to interview your staff. You will not be allowed to be present in that interview. Your staff is going to face those interviews, and they will look for any non-conformities as per the ISO 15189 standard. And finally, at the end of the second day of the assessment, those NCs will be told to you and the meeting will be over. Now wait for what are the various post-assessment action. Once your assessment is over, in another 1 week to 10 days, you are going to receive the assessor's report. What are the various non-conformities which were found in your laboratory during the visit of the assessors? Address those NCs within stipulated time. It is very, very important that you should follow the deadline which is given by the NABL board to cover these NCs, submit the evidence for all the corrective actions you have taken to close those NCs and and await the final decision from the accreditation body. So in short, that's the whole process of NABL or any other accreditation agencies process for getting the accreditation. So the major takeaway from this talk is that accreditation is a continuous journey. It is not a one-time procedure or a one-time checklist. Okay, it is an ongoing cycle which includes monitoring, auditing, improving, and reassessing. It's not gonna close once you have got the accreditation, your job is over. No, your job starts right from there, that you have to ensure that all these processes are followed up regularly. So with this, I'll finish my session by just saying one word, that accreditation is not a single man job. It is a teamwork. So build your team, go for accreditation. It's not a myth. Okay, it's not just passing an examination. It's just about developing a culture of quality in your laboratory that is going to enhance the accuracy and reproducibility of your test results. Thank you so much.
Thank you, Dr. Gaurav, for giving such an interesting talk. And we all have gained a lot of knowledge through this talk of yours in terms of accreditation of lab. And I'm sure the audience may be having a few questions. So, any questions?
It was indeed a nice, very nice and gist of the basic and this quality control and lab accreditation procedure. So very gracious and nice presentation. Thanks, Dr. Chavda. And if there is any question from our young pathologists, the PG students, because this is very important topic for the PG exams and for all practical purposes also.
I just want to know how many of you are working in an accredited laboratory? Just one or two fellows in the audience. So this is a culture we need to imbibe. It's not just a, I'll say, not a certificate that is just for getting an insurance accreditation done or something like that. This should be there to improve the overall quality and functioning of your laboratory. So I think you as a young residents, you should be following these practices in your respective laboratories. Because at this very young age, if you are going to develop this culture, then only you are going to follow in your routine practice.
Though we all acknowledge that it's labor intensive and work intensive thing to get accredited, but indeed it's required and a demand of the time. So now we close the session with all, I think that is.
Thank you. Thank you so much, everyone.
Yeah. And we have now next inauguration. No?
Thank you so much, sir, for such an enlightening session. Now I would like the chairperson to join for a photograph. I once again thank the chairperson. Now we have come to the most awaited part of the day, the inauguration of RAKTAVIGYAN 2025. I warmly welcome all the delegates for your time and patience to attend this event. I'm most honored to welcome A very warm welcome to you all to the inauguration ceremony of RAKTAVIGYAN 2025. I'm most honored and grateful to welcome the chief guests for the event, Padma Shri Dr. G.P. Sinha Sir, Senior Consultant Neurologist, Patna. I request Sir to join the dais. I now welcome Padma Shri Dr. J.K. Singh Sir, Director SS Hospital and Research Center, Patna, to join the dais, Sir. Padma Shri Dr. Vijay Prakash Sir, Senior Consultant Gastroenterologist, Big Hospital, Patna. Welcome you on the dais, Sir. Followed by Dr. B. Sanyal Sir, Director Mahavi Cancer Sansthan, Patna. Warm welcome to you, Sir. Padma Shri Dr. Shanti Roy Ma'am, Senior Consultant Gynecologist, Patna. Warm welcome to you as well, Ma'am. Dr. A. Hi, Sir, Chairman Paris HMRA Hospital, Patna. Dr. Kamlesh Tiwari, Sir, Senior Consultant Physician, Muzaffarpur. Please join us on the dais, Sir. Followed by Dr. Sahajanand Prasad Sir, IMA Past President and Senior Consultant Surgeon, Patna. We welcome you on the dais, Sir. Dr. H.P. Pati Sir, ex-Professor AIMS. Warm welcome to you, Sir. Dr. R.K. Jena Sir, Professor of Department of Clinical Hematology, SCB Medical College, Cuttack. Professor Dr. M.B. Agarwal Sir, Senior Hematologist and Hemato-Oncologist, PD Hinduja Leelavati Fortis, Breach Candy Hospital, Bombay. Can we welcome you on the dais, Sir? Now I welcome Dr. Avinash Kumar Singh Sir, Consultant Hematologist and Hemato-Oncologist, Bone Marrow Stem Cell Transplant Physician, to join the dais as well. Can we have a round of applause for the chief guest for the event? Now I would like to, I would request Dr. Suchismita Ma'am to felicitate Dr. G.P. Sinha Sir. Now I would request Dr. R.N. Tagu Sir to felicitate Padma Shri Dr. J.K. Singh Sir. Now I would request Dr. Sanjit Kumar Singh Sir to felicitate Padma Shri Dr. Vijay Prakash Sir. I would request Dr. Sanjit Kumar Sir to felicitate Dr. B. Sanyal Sir. No, Dr. I would request Dr. Avinash Singh Sir to felicitate Padma Shri Dr. Shanti Roy Ma'am. would request Dr. Suchismita ma'am to felicitate Dr. Kamlesh Tiwari sir. I would now request Dr. R.N. Tagu sir to felicitate Dr. Sahajanand Prasad sir. Okay. I would now request Dr. Avinash Singh sir to felicitate Dr. H.P. Pati sir. Now request Dr. Suchismita ma'am to felicitate Dr. R.K. Jana sir. हो गया, अच्छा. Sajan sir हो गया. Request Dr. Suchismita ma'am to felicitate Dr. Sajanand Prasad sir. I will now request Dr. Avinash Singh sir to felicitate Dr. Avinash Kumar Singh sir. I now request all the respected delegates on the dais to join us for lighting of the lamp.
वक्रतुण्ड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा वक्रतुण्ड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा वक्रतुण्ड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा
लाल चढ़ायो अच्छा गजमुख को दोन दिल लाल विराजे सुत गौरी हर को हाथ लिए गुड़ लड्डू साई सुरवर को महिमा कहे न जाए लागत हूँ पद को जय देव जय देव जय जय जी गणराज विद्या सुखदाता धन्य तुम्हारो दर्शन मेरा मन रमता जय देव जय देव भगति से कोई शरणागत आवे संतति संपत्ति सब ही भरपूर पावे ऐसे तुम महाराज मोह को अति भावे गोसावी नंदन निच दिन गुण गावे जय देव जय देव जय जय जी गणराज विद्या सुखदाता धन्य तुम्हारो दर्शन मेरा मन रमता जय देव जय देव
Thank you so much, sir, all the delegates on the dais for inaugurating the event. Now I would request Padma Shri Dr. G.P. Sinha, sir, to say a few words about RAKTAVIGYAN 2025.
Distinguished guest on the dais, Padma Shri Dr. Srimati Ranti Rai, Dr. J.K. Singh, Dr. Kamlesh Tiwari, the organizing secretary of prestigious API conference to be held in Patna very soon, Padma Shri Dr. J.K. Singh, past president of IMA Dr. Sahajanand Singh, and all my colleagues and guests and scientists who have come from outside. It is a great pleasure to be here with scientists of super speciality, hematology, which is so useful for every practitioner. Maybe he is physician, surgeon, pediatrician, plastic surgeon, anything, but hematology is for all. And that is the theme of Hematological Society Hematological Foundation of Bihar. This year the theme is Hematology for All. I was just looking for the souvenir last year, published in 6th session. This is the 7th session. It was there, come to the basics. The two themes are very, very important and exciting, that they come to basics. In spite of being a super specialty in hematology, with all latest investigations and stem cell transplantation and gene therapy, still the basic hematology is the basic and remains the basic treatment for all of us. And today, it has made more common. Dr. Avinash, with his fertile brain, has given a new option for this thing, that hematology for all. Hematology for all specialties, and therefore these two topics are very, 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 very self-explanatory. It serves the purpose of very conference here, and basics, I still emphasize basics, because in spite of super speciality and a rapid growth of investigation and treatment in hematology, the basic hematology remains basic, and it remains basic and more important. I will just cite one example, the how basic is so important. In 1940, Dr. T.N. Banerjee was the head of Department of Medicine, Patna Medical College. It was British Raj. The governor he was in the Ranchi at that time, because Jharkhand was in Bihar. The Ranchi was the summer capital of Bihar. And the governor fell ill. He had fever for 2 days. And every physician in Ranchi came to Bengal. His fever did not count. The 7th day, he became mentally confused. Somebody told Dr. T.N. Banerjee is a very famous physician in Patna Medical College. There was no regular flight from Patna to Ranchi. He went by a special plane to Ranchi. He saw the governor, and what a basic, I am example giving you the basic hematology. Being a physician, he told that I will examine the slide himself. He took a slide and prepared himself and saw that it was case of falciparum malaria. And he was given quinine, and the governor survived, and Dr. T.N. Banerjee was given the title of Rai Bahadur Dr. T.N. Banerjee. This simply emphasized that the basic is basic, and hematology basic is still a wonderful armamentarium for all of us. It does not mean that we have not to go with the scientific advancement. Today, the hematology has made a stride with T-cell transplantation, hematocell transplantation, immunotherapy, and targeted therapy. But still, we have to go a long way, and hematology is a really, when I was looking for a souvenir last year, I was surprised that how much we do not know about hematology, where hematology has gone. Today I have a chance to hear some of the lectures. It was very exciting, and therefore I only wish Dr. Avinash, who is a pioneer of Hematology Foundation of Bihar, to organize such conference. And he organized 7th conference, and nearly now the people of Bihar are recognizing the super specialty hematology as a very, very strong pillar of medical science. Thank you very much.
Thank you so much, sir, for sharing such memorable insights. Now I would like to request Dr. Sahajanand Prasad, sir, to share a few words.
Respected Dr. Mrs. Shanti Rai ji, Dr. Gopal Prasad Sinha ji, Dr. J.K. Singh ji, ladies and gentlemen, Avinash ji, you have done a very good work here. So, it is my pleasure to be here on the inauguration of RAKTAVIGYAN 7, Conference of the Hematology Foundation of Bihar. I feel happy and proud to see the activities of the Hematology Foundation of Bihar to cope up the specialized management and research techniques for the benefit of the patients in blood disorders. Hematology was developed a separate branch in last few decades. The specialist care such patients is made possible by the hematologists of Bihar through this forum. This scientific session, spread over 2 days, will covering important topics related to blood disorders in children and adults. Diseases like hemophilia, thalassemia, and leukemia still remain a challenge for the medical fraternity. Genetic disorder, genetic counseling, and public awareness form major role preventing the restricting some of these disorders. I am sure the present session will discuss all the recent advantages available for our patients. Blood bank services in other important ancillary services required in the treatment of the blood disorders. May I appeal the hematologists, the foundation to work up in this line of so that the blood is really readily available even in remote places over the state. I extend my thanks to the organizers, Dr. Avinash ji, for inviting me and giving me opportunity to address this August gathering. Finally, my best wishes to the organizing committee and the delegates to the wonderful and successful scientific session. Thank you very much, sir.
Thank you so much, sir. Now I would like to request Dr. Kamlesh Tiwari, sir, to say a few words regarding RAKTAVIGYAN.
Respected Madam Shanti Rai, my teacher Gopal Babu, senior faculty sitting here on the dais, and colleagues sitting off the dais. This clinical hematology is started by Avinash. I will say one day it is called Avinash is the father of clinical hematology in Bihar. We also know hematology, but if we land in problem, we send cases to Avinash. Avinash help us and give the solution, and he does help to us to quite a lot of time. Thank you, Avinash. He has invited me for this program. It is nice for him. But one thing I would like to say here that I'm organizing Epicon Bihar in Patna this January, and Avinash is one of the speakers in workshop on bleeding disorders. I must invite you all people to come in Epicon, enjoy it, and bless Avinash. Thank you very much. Thank you.
Thank you so much, sir, for your kind words. Now I would like to request Padma Shri Dr. Shanti Roy ma'am to say a few words, please.
Respected dignitaries on the dais and off the dais, faculties, students, friends, and people from media, good evening to every one of you. It is really a great honor and privilege for me that Dr. Avinash invited me and to share this platform. This is a very prestigious platform which is going to deal with hematology, and it is the 7th conference of Bihar Hematology Foundation, which is being held here. In our days, hematology was limited to, as Dr. Gopal said, we knew while we were students, we were taught of hemoglobin, total differential count, ESR, and very few other things. We knew only that much of hematology. But now it has greatly advanced, tremendously advanced. And now there is bone transplant, stem cell transplant, bone marrow transplant, immunotherapy, and this has provided treatment for many those patients who were incurable in the past. We could not think of that they will live any more than 15, 20 years, but now they are having good lives. So congratulations, Dr. Avinash, that you have started the conference on hematology here. And as Dr. You said that you are the father of hematology, so congratulations to you. And everyone should help you in bringing the newer things in hematology, which will be able to save many lives. And this conference, as you have organized, there are many young students, many young doctors I am seeing. This conference is going to help them. They will definitely get motivated to do research and to do further in the field of hematology that will improve the health system of Bihar and of the India on the whole. So thank you very much for inviting me. Thanks everybody, especially to Dr. Avinash.
Thank you so much, ma'am. We are equally honored to have you as well. Now I would like to request Padma Shri Dr. J.K. Singh sir to say a few words, please.
Dignitaries sitting on the dais and off the dais. Friends, medical science is a vastly growing science. It's a constantly developing science, and it's a rapidly changing science. Whatever it is today, tomorrow it is going to be obsolete. So everybody has to be keep in medical fraternity to keep them updated every time. And conference is the best platform to keep you updated. Friends, we have the research, medical research is going on in a very big way. And I'm sure every milestone, each and every milestone has been giving us some information, some technological advancement, so that we can move in a better way to give the better result for the patients. So research is very important for us. For the last 5 decades I'm in oncology, and I have seen many, many changes. And in spite of the various advancement in the field of oncology also, there are still some gray areas, still today, and that needs to be rectified, and that needs to be conquered. There is still some disagreement that needs to be corrected, and that needs to be solved. And there are still some issues which needs to be addressed. Friends, today, if I see the clinical oncology and the hematological oncology, probably this has given, and this has tremendously gone very high. If we talk about the results are coming from not from the physician's clinic, not from the surgeon's clinic. Now it is coming from the molecular lab. They are give you enough data, enough everything, and they are dictating us as to our clinician how to use the medicines, which one is good and which is not good for this patient. So every guideline today is coming from the molecular lab. And I think this is your lab, and you are a part of that lab. And you are telling us what is good and what is not to be used. So everything, credit, what is worth the credit of oncology, medical oncology, entire credit is going now to the molecular lab and the lab persons. So thank you, Vinas, for organizing such a beautiful conference. In every year he organizes, and we are really overwhelmed to see many of old friends here. Many of us are here to congratulate you, and we are very much thankful that you have invited us to make this conference a great success. Thank you.
Thank you so much, sir, for your valuable words. Now, I would like to welcome Dr. A. Hai, sir, Chairman, Paris HMRI Hospital, Patna. I would now request Dr. Avinash Singh, sir, to felicitate Dr. A. Hai, sir. Thank you, sir. Now I request respected Dr. A. Hai, sir, to say a few words about RAKTAVIGYAN 2025.
My friend Dr. Avinash and respected and dear friends, my friend Gopal is there, Shantiji is there, friends from the dais, ladies and gentlemen. Sorry for being late, actually I was out, I just came from the airport. I always take this opportunity to congratulate Dr. Avinash for what he has done. He established hematology as a specialty in Bihar. You know, when I and Gopal and Shantiji were students, our only hematology was, the investigation was TCDC-SR, and there was only two types of anemias, pernicious anemia and iron deficiency anemia, that's all. That was beginning and end of hematology. Today it has become a specialty, and thank God we are able to save so many lives. Even yesterday I think you have done a very difficult and very complicated bone marrow transplant, and we have got the highest number of bone transplants now in Bihar, and very difficult cases. And I think more than that is the fact that every year without any break, he is getting some of the best brains from all over the country. You can see the faculty here, to bring this knowledge to the people of Bihar. I think that is a great success, and I am sure that with this cooperation from you and with his hard work, we will be able to benefit more and more patients. I thank you once again, welcome you, and congratulate Avinash for this effort. Thank you, God bless you.
Thank you very much, sir. Now I would like to request Dr. B. Sanyal, sir, to say a few words.
Distinguished guests on the dais, participants, invited teachers, friends, ladies and gentlemen. It is indeed a privilege to be with you this evening, for which I thank Dr. Avinash to invite me to take a chair on the dais. I am seeing for the last 7 years, from the day he started this RAKTAVIGYAN 1. And over the last 7 years, I have seen tremendous progress in the form of volume of participants, the quality of presentations. It is amazing. To the people who have come from outside, I welcome a rising partner, and on behalf of my institution, Mahavir Cancer Sansthan. We have seen in the morning session, evening session, a lot of academic activities like anemia, lymphoma, leukemia, so many things. If I summarize what are the last 50 years, what are the things has achieved or progress has been taken in this profession of hematology particularly and lymphoma in particular. There are tremendous progress in the diagnosis of the diseases. That is most important. You can go to the molecular level and you can dictate the treatment according to the nature of development of the cell or cell biology. Flow cytometry, immunohistochemistry and genomic sequencing has changed the whole scenario of diagnosis of hematological lymphoma profile. Similarly, the progress has taken place in the form of therapy. When we were students about 60 years back, we have got hardly limited 1 or 2 molecules, say cyclophosphamide, methotrexate, something like that. 5 or 6 in the late 60s, I'm talking. I'm too young that I can go in late 50s, started my career in 1969. So I'm fortunate enough to be associated with this organization from the day one, the RAKTAVIGYAN one. And I have the type of pen taken by Dr. Avinash is tremendous. It is so nicely organized. And since I'm an administrator, I like to highlight that there are 2 components of a conference. One is the academic conference, which we are discussing in depth, where with the students, younger generation getting update of the subject. On the other hand, what is the most important requirements of a hematology is the presence or number of blood banks. In my state of Bihar, now I'm 7 years old in Bihar, so I have to say it is my state. 100, we have got about 13 crore 68 lakhs population, having 126 blood bank, out of which only 13 has got a cell separation system. So 1 blood bank about equivalent to 11 lakh population. You can realize that how deficient we are. In Patna, we have got 33 blood banks having 11 probably cell separators. Mahavir Cancer Sansthan is one of the most big hospital having, we see about 2,500 leukemias per year. And we use about 2,500 units of blood of different nature, full blood, then elements, thing, where we have got justified use of a most precious substance is blood, which is most important. As a part of the foundation, Hematology Founder Bihar, I request the organizers as well as the office bearers that along with the side of education, you have a moral obligation to increase the facilities of, if you diagnose it, but if you don't with the blood, where from you could treat? A leukemia patient takes several numbers of units of blood during the time of treatment and subsequently as well. So this facility has to increase. For this, I will request organizers so that at the end of the conference, you summarize the outcome of the academic activities as well as give a demand to the government that we need all the banks, more increased number of blood banks and facility of cell separators. With this, again, I thank you, Avinash, for giving me a chance to stand before you all. Thank you.
Thank you so much, sir. Now, next, I would like to request Dr. H.P. Patil, sir, to say a few words.
respected dignitaries, invitees, delegates. It's a great pleasure to be here at this conference. As you have seen from the morning, the hematology as a super specialty, whether it is the clinical aspect or the lab aspect, both there is a tremendous progress, and one has to keep in contact and knowing each of them. And this is a very important thing that Dr. Avinash is filling that gap by conducting a national level conferences of this magnitude year after year, and keeping and it is that everybody looking forward to attend at the national level. Thank you, Avinash, for doing a great job.
Thank you so much, sir. Next, I would like to request Dr. R.K. Jena, sir, to share a few words, please.
So, respected, dignified guests on the dais, and ladies and gentlemen, you know, Patna and Bihar is very important city, not only from the political reason, even from the historical reason, and so far the education hub is concerned. Patna was the education hub of the ancient India. I know most of my teachers, they did their MD from the Patna only. And the second example is, you have so many Padma Shri. Padma Shri in oncology, Padma Shri in neurology, Padma Shri in gastroenterology, Padma Shri in nephrology, and so many Padma Shri also. That justifies that. You know, Biharis are very intelligent, they are highly talented, their IQ is 100 plus. If you compare to the all rest of the Bihars, their IQ is 100 plus, far higher than the rest of the country. I was observing the Hematology Foundation of Bihar since 7 years, even from the day one also. Avinash did it in a very loud and clear. Even the first annual Congress was with a very huge success also. If you see the trajectory of the RAKTAVIGYAN or the every annual event, now the 2 halls, so many things. It is just like in many hematology conference also. You find delegates and participants are participating across the country also, starting from Kashmir to Delhi to Bombay to Eastern India, everywhere they are coming together also. You know, so for annual Congress of Indian Society of Hematology is concerned, people compete, people do a lobby to take the annual conference. But Avinash is going to host the annual Congress of Indian Society of Hematology in 2027 in Patna, being the organizing secretary. It is being given to him. He has never demanded. This is the first declaration he has never demanded, because if you consider the Bihar has never hosted any annual Congress of Indian Society of Hematology in the entire history also. Considering the importance of the Bihar and Patna and the way the Avinash has contributed, etc., so he deserves to host the annual Congress of Indian Society of Hematology for the first time in Bihar and Patna, probably in 2017. As the chairman sir has already told, he single-handedly established the hematology as a distinct discipline also. You know, I always tell people, look at the magnitude of the hematological diseases, anemia, hemoglobinopathy, hematological diseases, and bleeding disorders, taken together, outnumbers any other discipline so far the magnitude of the disease is concerned. Secondly, if you look at the sheer advances of the magnitude of the advance, of the speed which the advances is occurring, or any recent changes are occurring, you pick up any disease, it outnumbers any other discipline. So considering all these highly expanding, highly developing discipline, Avinash established, he's the father, he's not only the father, he's the mother, he has established the hematology as a separate discipline in Patna. I think that one Padma Shri is missing, because there must one Padma Shri in hematology also deserves to sit here on this dais also. I will request the chairman, Sir Paras Hospital, all the dignitaries to put forth. I think you will never get a better person than Avinash to be awarded with the Padma Shri, the kind of the contribution, etc. So today we are pitching the Avinash to be awarded as a Padma Shri. I will again urge upon all these dignitaries and all of you to continue to create a lobby and all the necessary steps so that he can get the Padma Shri award. Maybe in the national conference he will be called as Padma Shri Avinash Singh. Thank you very much for it.
Thank you very much, sir, for your very kind words. Now I would like to request Dr. Avinash Kumar Singh, sir, to deliver a vote of thanks.
Good evening, ladies and gentlemen. Thank you, Sandhya, Dr. Sandhya, for moderating the inauguration session. और सबसे पहले जितने भी हमारे गुरुजन हैं उनको चरण स्पर्श और बहुत बहुत धन्यवाद कि आज आ करके उन्होंने यह जो हमारा रक्त विज्ञान 7 2025 हुआ उसको इनॉग्रेट किया। और कभी कभी लगता है कि जैसे हमारे जो गुरु हैं उन लोगों से हम लोग कुछ ज़्यादा ही मांगते हैं। जैसे हर साल सर लोग आते हैं, हर साल हम सोचते हैं कि जाके मिले सर से, पैर छू के प्रणाम करें, फिर कहें कि सर आइए। लेकिन लगता है कि सर इस एज में भी अभी हमको लगता है 50+ पेशेंट्स देखते हैं, एक्टिव हैं। और उनके बातों को आप लोगों ने सुना होगा तो उनके पैर थोड़े कमज़ोर हुए हैं, लेकिन जो जोश है वो पूरा, उसमें कमी नहीं है। और जो लोग बाहर से आए हैं उनको जस्ट मैं बताना चाहूँगा कि ये लोग बिहार में चीज़ों को इन्होंने इस्टेब्लिश किया। सर हैं गोपाल प्रसाद सिन्हा सर हैं, उन्होंने क्लिनिशियन को इस्टेब्लिश किया। हम लोग जब MBBS करते थे तो सर जैसे सर का जो HOD थे सर, तो सर जाते रहते थे मेडिकल कॉलेज से, तो लेस जूता का लगाते थे कि अब कार में बैठना है। तो हम लोग देखते थे कि अच्छा सर जो है क्लिनिकल मेडिसिन फिजिशियन, इतने फेमस फिजिशियन HOD कैसे लेस लगाते हैं। और सर का जो ऑलवेज कॉन्फिडेंस, जोश, ये ऑलवेज इंस्पिरेशनल है हम लोग के लिए। कमलेश तिवारी सर हैं, API के पास्ट प्रेसिडेंट हैं। इस बार जो API 2026 हो रहा है उसके सब कुछ है। और API एक वाइब्रेंट बॉडी है हमारे स्टेट में। जो एनुअल API मीटिंग होती है उसमें बिहार को अवार्ड दिए जाते हैं अच्छे एकेडमिक एक्टिविटीज़ के लिए। उसके पीछे सर का काफ़ी बड़ा रोल है। और सर पटना से नहीं है, पटना से 80 किलोमीटर दूर मुजफ्फरपुर में रहते हैं। वहाँ के श्री कृष्ण मेडिकल कॉलेज में HOD रहे हैं, अभी रिटायर्ड हैं लेकिन काफ़ी एक्टिव हैं। शांति राय मैडम, उन्होंने बिहार में गायनी को इस्टेब्लिश किया कि लेडीज़ डॉक्टर कुछ होती हैं, उन्होंने इस्टेब्लिश किया। इनके सारे स्टूडेंट्स बिहार में ही नहीं, PMCH से ट्रेंड होके US में हैं, UK में हैं। CFD होती है PMCH की तो उसमें लोग आते हैं। तो मैडम हैं JK सिंह सर ने हमारे स्टेट में कैंसर टर्म को इंट्रोड्यूस किया कि ऑन्कोलॉजी कुछ होता है। B सान्याल सर बिहार के वन ऑफ द लार्जेस्ट कैंसर हॉस्पिटल को डायरेक्ट कर रहे हैं। पति सर हमारे एम्स न्यू दिल्ली से डिपार्टमेंट ऑफ हेमाटोलॉजी से हैं। और जितने लोग अभी एज ए हेमाटोलॉजिस्ट आए हैं दे ऑल नो हिम। एंड एज ए हेमाटोलॉजिस्ट मैंने सर से सीखा कि कैसे किसी भी प्रॉब्लम को अप्रोच करना चाहिए, जो हिस्ट्री क्या होता है, कैसे लेना चाहिए, PS के फाइंडिंग कितने इंपॉर्टेंट होते हैं। हम लोग स्टूडेंट थे तो वी यूज टू जंप कि सर ऐसा है, बोन मैरो में क्या है। तो सर यूज टू स्कॉल्ड अस कि हिस्ट्री क्या है। हम लोग कभी एक्सपेक्ट ये नहीं करते हैं कि कोई एक हिमाटोपैथोलॉजिस्ट या पैथोलॉजिस्ट हमको बताएंगे कि भाई हिस्ट्री में हिस्ट्री क्या है। हम लोग को लगता है कि अरे नहीं ठीक है, ऐसा ऐसा है, ब्लड चढ़ता है, PS और बोन मैरो में क्या है। तो वो अप्रोच, उसमें कोई हाईफाई चीज़ें नहीं है, मॉलिकुलर 25,000 50,000 का NGS नहीं है। वो हिस्ट्री है, PS है, बोन मैरो एस्पिरेशन है। दैट मे कॉस्ट हार्डली 400-500 रुपीज़, बट मेनी ए टाइम्स ऑल डिफिकल्ट केसेज वी यूज टू डायग्नोज इन दैट क्लिनिकल हिमाटोपैथोलॉजी डिस्कशंस। RK जेना सर, हम पहले भी जानते थे सर को। When I came to Bihar, I came close to him and I learned with him how to make people together, कैसे सोसाइटी बनती है, how to run society। ईस्टर्न हिमाटोलॉजी ग्रुप बना, इंडियन सोसाइटी की एक्टिविटीज़ होती है, काफ़ी इनर्जेटिक डायनेमिक हैं और बहुत सारी एक्टिविटीज़ में हम लोग को गाइड करते रहते हैं, हमारे गार्जियन हैं। तो आप सभी को बहुत बहुत धन्यवाद। सहजानंद प्रसाद सर हैं, पास्ट IMA प्रेसिडेंट रहे हैं। और जैसे हम लोग कहते हैं पेशेंट फ्रेंडली डॉक्टर, तो सर इज डॉक्टर फ्रेंडली IMA प्रेसिडेंट, ऑलवेज रेडी। आज यहाँ आए थे, ही हैड 4, 5, 6 कमिटमेंट टुडे, कहीं इनॉग्रेट करना है, कहीं कोई मीटिंग है। तो आप सभी सर को बहुत बहुत धन्यवाद। और ये धन्यवाद ऑन बिहाफ ऑफ ऑर्गेनाइजिंग कमेटी ऑफ रक्त विज्ञान 2025 कोर कमेटी मेंबर्स, बहुत सारे हमारे सीनियर मेंबर्स सामने बैठे हुए हैं। तो वेन एवर देर इज़ वन मीटिंग समवन हैज़ टू स्टैंड इन फ्रंट, ही इज़ नॉट लीडिंग, ही इज़ नॉट द लीडर। सर लोग तो अपने बच्चों को कुछ देना चाहते हैं तो कोई पद्मश्री दे रहे हैं, फादर ऑफ हीमेटोलॉजी कह रहे हैं, लेकिन आई एम जस्ट स्टैंडिंग इन फ्रंट, बट मेरे पीछे मेरे साथ मेरे सीनियर कलीग्स हैं, मेरे जूनियर कलीग्स हैं, उन लोग का साथ ऑलवेज रहा है। हाई सर तो शुरू से भी MBBS से भी सर के साथ रहे, जब हम 4th या 5th ईयर में रहे होंगे तो सर रिटायर्ड किए थे, and fortunately I joined Paras Hospital where sir is there, so I had opportunity to meet him once or twice in a week and I always learned from him. तो आप सभी सर लोगों को, मैडम को बहुत बहुत धन्यवाद। थैंक यू वेरी मच।
Thank you so much, sir. Now I would like to request all the delegates gathered in the hall to stand for national anthem. I would once again thank all the esteemed delegates on the dais and off the dais. Now we'll break for a short tea break. Kind announcement, tea and snacks are being provided in Hall B, first floor. Please join.
नहीं कुछ सर।
Kind attention to all. Now I would like to request the quiz participants selected for the final round, Team A, Team B, Team C and Team D, to come forward in front of the dais, please. I repeat, I request the quiz participants, Team A, Team B, Team C and Team D, to join us in front of the dais. We are about to begin the quiz.
everyone present here, and we would like to start the new session, which is an interesting session. Good evening everyone present here. Now we would like to go to an interesting session, that is state level hematology quiz session, and without any delay I would like to request the moderators of the quiz, Dr. Rishu Vidatri ma'am, Assistant Professor and Department of Clinical Hematology, AIIMS Patna, and Dr. Avinash Singh sir is a Assistant Professor, Department of Pathology, AIIMS Patna.
So all the teams are here. We are meeting very frequently nowadays. 4-5 teams have qualified in the end. After the screen round of 10 teams, there is only 5 teams left, 2 from IGMS, 2 from AIIMS and 1 from DMCH. So if we will have our PPT ready. Yeah. I'll go through the rounds, quiz rules. So in general, there will be 25 seconds for each question. If question has got two parts, there will be 25 for first part and 25 seconds. Stick to the time. If pass question is attempted, don't take much time. There will be just if you know the answer, or else pass will be there. We will finish in 30 minutes. Round 1, the rules are same as before. The college level quiz rules is applied to this round 1. There are 5 questions and historical figures of stalwarts of hematology. You have to identify. Now, little bit of change is there. Don't have to identify him now. You have to identify or tell the hematology work he has done, or the whatever contribution in the field of hematology. The scientist name will be there, his photograph will be there, but you have to tell the contribution in the field of hematology. 10 marks for correct answer. If past question is attempted, +5. I'll start with team A. All of you are ready? Ready? There are no buzzer questions, no buzzer round. So I'll start with team A. Can you identify him? No, it will be difficult, so I'll tell you his name. Sir James Homer Wright. Now, what is the most important hematological contribution?
Sir, right stain given by him.
Yeah, +10 to team A. Very good. Team B. You get the name Max Perz. You have 25 seconds. Think. No, there is no negative marking in this round. Attempt. Even a wild guess will fetch you 10 marks. No. So I'll pass this to team C. Team C, if you want to get 5 points, 5 marks, tell the most important hematological contribution. Team C, do you want to attempt? Team D? Team D? Team E? Team A? No? No. He determined the structure of hemoglobin using X-ray crystallography. Team C, get ready for your question. Janet Rawling. Now you have to tell the most important contribution in the field of hematology. There might be several other contributions also of the scientist, but in the field of hematology, what is the most important contribution? Team C, 25 seconds. Time is running out. Think. No. We'll pass the question to Team D. Team D? Team E? Very good. They get +5, +5. Team D, your direct question. He is Donald Metcalf. Time is running out. If you know, tell the answer. There is no negative marking. There is no negative marking. Somewhere in the book, textbook, you would have read about him. So they pass. Team E. Team A. Huh? No. Team B. No. Team C. So I'll tell you the answer. He discovered colony stimulating factors. Now, last question is for team E. Get ready. He is Galileo Bezzero. What is the most important contribution? You should be knowing about these hematological figures, personalities, scientists. Because of them, we are having hematology.
Sir, HPLC?
Huh?
HPLC?
No, we will pass it to team A. Huh? What? No. Very good. Team B gets +5. This was the end of round 1. We are going fast. This was the end of round 1. We have scores, please. Can we have scores, Pritika? Team A +10, Team B +5, Team E +5. C and D, buckle up, because the next round is more oriented or inclined towards lab. There are 10 questions. Okay, so we will start with Team A. First 5 question is image representing principal or end result of a test. So looking at that image, you have to name the test. You identify the test. First 5 questions, there is no negative marking. First 5 questions, you get 10 marks if you are primary. For secondary teams, for past question, there will be 5 marks. There is no negative marking. So pathology residents, buckle up for this round. For the questions 6 to 10, there is a penalty there if you take the hint. There are 2 parts. Part A, direct question, you get the answer, you get 10 marks. If you don't get the answer and you opt to take the hint, if you take the hint, it becomes very easy. You get +5 for that if you guess it correct. If it is incorrect or you pass it, you get -5. अगर दूसरी टीम ने, if you pass the question without taking the hint and other teams take the hint, then there is -5 for the team who takes the hint. Okay, so if you don't know the answer, you pass it. But trust me, if you take the hint, it will become very easy for you. So take the hint. Don't pass it to others because they will guess it correctly and get marks. Round clear? Rule clear? I'll start with team A. Now, this image, you have to identify the test. Name the test. Name the test. Looking at this image, everything is there. Everything is there. Yeah.
Sir, in case of PNH,
you have to name the
serum
test.
lysin test.
Huh?
Acidified serum lysin test.
I'll give you 10 marks for that. 10 marks. Very good, team A. This is Ham's test. Team B, this question is for you. Don't take much time. This is very easy. Come on. This is the principle of some test. You have to name the test. Team B, time is running out.
Immunofluorescence test.
No, I'll not give you marks for that. IF is not the answer. Team C. Team D. Team C.
Immunochromatography.
Huh?
Immunochromatography.
No. Team D. Team D, do you have an answer? Team E, shall I pass it? Team E? Team A? No. This is fluorescence spot test. Next question, no. You don't get it any marks for immunofluorescence. Team C, this is very easy question for you. This is very easy question for you. You scored 10 marks. Name the test. Huh?
Coombs test.
Coombs test is correct. 10 marks plus 10 to team C. Team D, this question is for you. This is end result of a test. You identify the test. Enough hints are there. Time is running out. We have 2 more rounds to go. Please hurry up. Shall I pass it? Huh?
HPLC.
No, wrong. Team E, do you have an answer?
Nestrov test.
Huh?
Nestrov test.
Nestrov test, wrong. Do you have an answer, team A? Team B? There is no negative, huh? Wrong. Team C? Do you have an answer? Wrong. This is a solubility test. We will move on to team E. You identify the test. There is a curve, there is magnet, something is happening. Guess it correct. Time is running out. I'll move on to, if you know the answer, tell. I'll move on to team A. What? Principle of some test. Do you have an answer? Team A? Team A?
Magnetic chromatography.
Huh?
Magnetic.
No. Team A? What? Coagulation test? No. Very good. They get +5. Team B? Team B? Now the next part, next 5 questions, there is a hint. If you don't know the answer, take the hint. It will become very easy for you to. You will get more marks, or at least +5 will be there. If you directly take the answer without taking hint, you get +10. But beware, there is -5 with your wrong answer or passing the test, if you take the hint. This is an HPLC of 6-year-old boy presenting with progressive pallor since early childhood. Diagnosis, easy case. No, this is for team A. Team A. What? HB parts you are saying? Are you sticking with your answer? This is 6-year-old boy presenting with. Do you want to change your answer, or shall I give chance to team B? Time is running out. You still have a chance to take the hint. If you want to take the hint, you can take that. If you want to take the hint, take now, or else pass. That is not correct. That is not correct. Take the hint. Take the hint. Hint. Hint is this. Now it is very easy for you to tell. With hint, you get another 25 seconds. But if you are wrong, you will get -5. If you are correct, +5. Your time is running out. Tell an answer, or else I'll. Team B. HBH disease, very good. +5 to team B. This is microscopic image of a 28-year-old female presenting with painless swelling in left axilla. Very easy. You give the diagnosis on this image. Is the image clear? Yes, image is almost clear. You can, team B, you have to give the diagnosis. Should be accurate, pinpoint diagnosis for this. If you don't know the answer, take the hint. Take the hint. Now, there was -5 for team A, done? Okay. Take the hint. Hint. This is IHC, CD34 and HHV8. With hint, it becomes very easy, very easy. Pathologist should buckle up, pathologist should contribute. I'll pass this through, huh? Are you taking the question? Are you taking the question, or shall I pass? No, this is too much. You have to pass. No, team C.
Castleman disease.
Very good. Team C gets +5. Very good. Team C, this question is for you. Looking at this image with this history, 5-year-old child presenting with fever, pallor and easy bruising for 1 month. You have to give the diagnosis. Give the diagnosis. This is +10 for you straight away. You don't even need the hint. There was -5 for team B. Team C, if you guess, you get +10. Time is running out. What do you think this is? If you want to take the hint, take now. Take the hint, it will become very easy for you. take help from the pathology resident. Yes, they will know the answer. Come on, do you want to take the hint? No? Yes or no? You have to, time is running out. Shall I pass? Pass. Pass to team D.
We'll answer.
You want hint or not?
No.
No, you can't take so much of time. You have to decide.
It was our question.
It was?
ALL.
No, incorrect. But you have not taken the hint, so no negative marking for them. Still the question is for team D. If you want to take the hint, take it now, or else pass. Huh? No, wrong. Team E. Huh? Hint. You want to take hint? Yes, you will get negative marking if you take the hint. Hint will make it easy. You don't want to take the hint? You want to pass? Team A? Anything? If you want to take the hint or else pass. You want to take the hint? Huh? -5 if you take the hint. No, you can. If you answer the question, you get +5. But there will be no negative marking if you are wrong now. Huh? No, you have to diagnose the disease. If you are wrong, then I'll just ask the audience if anyone can diagnose this, because no, all 5 has passed it. Anyone from the audience, because this case was discussed by Tathagat sir. There are cytoplasmic blebs here, and I have put this hint as 61 and 41 positive scattered plots. Next question is for नहीं मिलेगा. So ninth question is for you. You should focus on this, on your primary image. A 62-year-old man presenting with fatigue, weight loss, abdominal discomfort. On examination, he has generalized lymphedema. There is a microscopic image. Sorry. Even if you saw the hint, I am very sure you wouldn't have got it. So this image, as well as there is a fish image. Looking at this, you have to give the diagnosis. You want 10 points? Take it. Because I have shown you the hint also. Because there is a karyotyping image. Huh? CML, wrong. Team E. Generalized lymphadenopathy, lymph node, wrong. Mantle cell lymphoma, +5 to team A. Very good. This was a karyotype of mantle cell lymphoma. Team E. This is a bone marrow aspirate of a 68-year-old man who is presenting with progressive fatigue and weakness. You have a CFA image here. Looking at this with that immunofixation, you have to give the diagnosis. If you don't know the answer, take hint. It will become very easy. No, if you want to get ahead of team B or team A, now is the chance. Team E. CML? No, that is wrong. A. You get full marks for it. I'm very happy you did the diagnosis. Team A gets +5 for this. Yes. Yes. नहीं मिलेगा. They didn't get the AML बोला, AML M7 को वो नहीं मिला. HB Bards और HBH में नहीं मिलेगा. 6 साल का बच्चा था वो. ठीक है, नहीं मिलेगा. Don't argue about, or else I will disqualify you. This was the hint. Score. So first 2 round was taken by me. Next 2 round will be taken by Dr. Rishu ma'am. So I request ma'am to take over the mic.
So with the end of round 2, team A is 25 points. Team B is yet to score. Team C is 15. Team D is also yet to score. Team E is 5. So we'll start with round 3. So in round 3 you have team A is 25, team B is 20, team C is 15, team D is 0, Team E is 5. So round 3, there are total 5 questions. All these questions are based on some syndromes. So we will give you the syndrome as a jumble word. You need to unjumble it. If you unjumble it, you will get 20 points. If you don't unjumble it, we'll give you some clinical hints. Then if you get the syndrome, you will get 10 points. There is no negative marking. So we'll start with team A. Identify the syndrome. You can unjumble it. And if you cannot, I'll give you the clinical hint. You want hint or you want to pass it? You'll get plus 20. If you take hint, you get plus 10. Hint de do. So this is a newborn child. He presented with recurrent infections, severe neutropenia. You can see the bone marrow aspirate smear. This is autosomally recessively inherited with HAX1 mutation. You can see some typical features in the bone marrow picture. I think it will be passed to team B. Team C. Team D. Team E. The correct answer is Kosman syndrome. So next question is for team B. If you can unjumble it. You need hint. So this is an elderly male. He is presented with redness and swelling of the nose and the ear. You can see the CT scan of the thorax and the typical erythroids in the bone marrow, UBA1 gene mutation, somatic mutation in an elderly male. You can see some vacuoles kind of thing. I think we'll pass it on to team C. No? Team D? Good. It's plus 10 for team, sorry, plus 5 for team D. Next question is for team C. You can unjumble it, team C. You need hint? So this is a child with hypopigmented patches, gray hairs, immune dysfunction. I think we'll pass it to team D.
Can you show the jumbled image?
It's time up, team D. Team E? Wrong. Team A? Good. Plus 5 to team A. The next question is for team D. You want hint? Exocrine pancreas insufficiency with some typical iron deposits in the bone marrow. Mitochondrial gene is implicated in this disease. We'll pass it to team E. Team A. Pass. Team B. We'll pass it to team C. Team D. Correct answer is Pearson syndrome. This question is for team E. If you can unjumble. I'll give you hint. You want hint? So you can see the electron microscope of the platelets. You can see the CT scan image.
Kiran-Sayre syndrome.
Wrong. It goes to team A. Correct. +5 for team A. So now next we'll start with round 4. Round 4 is a clinical round. There are total 10 questions. If you give correct answer, you'll get +10. If you want to pass the question, it will be passed to the next team. The next team will give correct answer, they'll get +5. There is no negative. So we'll start with team A. A 58-year-old male with high-risk MDS presented with transfusion dependence and 9% blast cells in the bone marrow. Cytogenetic was complex karyotype with deletion 7q. He has no comorbidities and HLA matched sibling donor. Which of the following is the most appropriate next step? Start azacitidine. B. Proceed to allo-SCT without bridging. C. Initiate azacitidine as a bridge, then allo-SCT. D is use high-dose cytarabine followed by allo-SCT. B. You want to proceed with allo-SCT without bridging. Incorrect. Team B. You want to initiate azacitidine as a bridge. C. Correct. It's +5 for team B. Next question is for team B. A 32-year-old woman presented with fever, confusion and petechia. Laboratory study shows anemia with cystocytes, thrombocytopenia, elevated LDH and normal coagulation. What is the most appropriate next best step? Start high-dose steroid, administer IVIG, you initiate Plex or you give rituximab as first line. C, correct. It's +10 for team B. Next question is for team C. A 56-year-old man presents with progressive fatigue, bilateral lower limb edema and periorbital purpura. Lab evaluation shows nephrotic proteinuria and elevated NT-proBNP. SPEP shows a small M spike and serum free light chain shows markedly elevated lambda chain. Cardiac MRI is suggestive of amyloid. What is the next appropriate next step in diagnosis and therapeusis? First is you perform a fat pad aspiration for Congo red stain and then start a high dose DEXA. Proceed direct. You want to proceed directly to bone marrow biopsy without tissue confirmation. It's wrong. Team C. Team C. Team D. Perform fat pad. No. Team E. Huh?
C.
Team E, you want to?
C.
C. Confirm amyloid type via tissue biopsy. It's correct. It's +5 for team E. So next question is for team D. A 52-year-old man is diagnosed with de novo AML. Cytogenetic shows inversion 16 and molecular testing shows negative for FLT3, NPM and T53 mutation. He is otherwise healthy with ECOG 0. According to current recommendation, which of the following is most appropriate initial treatment? 3+7 chemotherapy. B. Induction with cytarabine plus donor plus midostaurin. C. Induction with CPX 351 followed by SCT. Or D. Start AZA plus VEN. A. It's correct. It's +10 for team D. Next question is for team E. A 32-year-old woman present with newly diagnosed ITP and platelet count of 8,000. She has mild mucosal bleeding with no life-threatening hemorrhage. She is otherwise healthy and is non-pregnant. Which of the following is most appropriate initial treatment? Observe. B. Oral prednisolone for 1 mg per kg body weight per day or dexamethasone. C. Rituximab. D. Romiflostim. B. You want to give oral prednisolone. It's correct. It's +10 for team D. Next question is for team A. A 50-year-old woman with chronic CML Has been on imatinib for 6 years with excellent tolerance. Her BCR-ABL IS score has revealed a MR of 4.5 for the last 4 years. She asks you if she can stop the treatment. According to the ELN guideline, which of the following statement is most accurate? She is eligible for TFR since she has maintained an MR of 4.5 for last 2 years and has been on TKI for 3 years. B, she is ineligible because only on imatinib treated patient can attempt TFR. C, she is ineligible because MR 5.0 is required. And D, she should continue nilotinib indefinitely as stopping is never recommended in CML. A, she is eligible for TFR. Correct. It's plus 10 for team A. Next question is for team B. A 52-year-old male is diagnosed with JAK2 V167 positive polycythemia vera. He has hematocrit of 57% and platelet of 5.5 lakh. WBC is 13,000. He has a history of hypertension but no prior thrombosis. Which of the following is most appropriate initial management? Phlebotomy to maintain hematocrit less than 45 plus aspirin. B, hydroxyurea plus low dose aspirin. C, ruxolitinib. D is interferon alpha. Team B, what do you want to answer? B. Wrong. Team C. Huh? Wrong. I think no more passes because we have only 2 options. The correct answer is phlebotomy to maintain hematocrit less than 45 plus aspirin is low dose polycythemia. So next question is for team C. A 45-year-old AML is on day 10 of induction chemotherapy. She presents with temperature of 38.5 and ANC of 180. She is hemodynamically stable, has no obvious source of infection and mass risk index score is 24. Which of the following is the most appropriate management? First, you start with oral antibiotics and observe as OPD patient. B, start IV piperacillin tazobactam immediately after cultures are drawn. C, delay antibiotics until chest X-ray and urine cultures. D, start vancomycin empirically with cefepime on febrile neutropenia cases.
D.
Sorry?
D.
D. Incorrect. Goes to team D. B. You want to give IV piperacillin. It's correct. Plus 5 for team D. Next question is for team D. A 28-year-old woman present with fatigue and recurrent infection. Examination reveals pallor and petechia but no hepatosplenomegaly or lymphadenopathy. Investigation shows hemoglobin 6.9, WBC 2100, platelet 18,000, reticulocyte 0.3. Bone marrow is hypocellular with no dysplasia or blast. Flow cytometry reveals a PNH clone of 2% in WBCs or granulocyte. Cytogenetics is normal, next gen, no mutation. HLA typing available, 1 match sibling donor is identified. What will be your next appropriate treatment? Allogenic HSCT from match sibling donor. C. Correct. It's plus 10 for team D. Next question is for team E. Which of the following is correct regarding CAR T-cell therapy in relapsed refractory mantle cell lymphoma? Approved in newly diagnosed high-risk mantle cell lymphoma. ZUMA-2 trial of brexucabtagene autoleucel showed overall response rate of more than 90%. C. CAR T-cell in mantle cell lymphoma has negligible CRC risk. And D. targets CD22 antigen only. Team E. No, you want to pass. B. ZUMA-2 trial. It's correct. Plus 10 for team E. So with this, we come to the end of the quiz. So the winner of the quiz is Team A with 45 points. So Team A will go to the zonal to represent Bihar. Okay, we'll inform you the final dates. Thank you.
Congratulations to Team A.
Thank you so much, ma'am, sir. This was an amazing quiz session. We appreciate the thoughtful of these questions. And without any delay, we'll move on to the next talk, that is lab approach to the bleeding patient. And with great honor, I would like to call upon Dr. N.K. Barrier, Professor and ex-HOD, Department of Pathology, PMCH Patna, followed by Dr. C.P. Jaiswal, sir, Professor and Head of the Department, Department of Pathology, NMCH Patna, and Dr. Amod Kumar, sir, Assistant Professor, Department of Pathology, NMCH Patna, and followed by Dr. Rajesh Kumar, sir, Senior Consultant Pathologist, Katiha. Sir, please come to the dais.
One correction, I am Dr. N.K. Barrier, retired professor and HOD of pathology, PMCH.
Good evening. I welcome Dr. Sameer Kumar Behera, Professor of Pathology at MKCG Medical College and Hospital, Behrampur, Odisha. He is the executive member of ISHBT and he is presenting on the topic lab approach to bleeding patient. Welcome, sir. Over to you.
Thank you, Bihar Hematology Foundation and Dr. Avinash and his group for inviting me for this lecture. So, the lab approach to bleeding, patient with bleeding, we'll discuss this. What is hemostasis? Hemostasis is basic, where there is, you want to stop the bleeding, okay, from a vessel. It can have, when a patient is bleeding, it can have different, what is a primary hemostasis or a secondary hemostasis, then a blood clot, and then fibrinolysis. So primary hemostasis is basically associated with the platelets. Secondary hemostasis is basically mostly in the coagulation factors. Inside your body, it's not that primary or secondary hemostasis, is what is called a cellular mechanism. But in practical way, we divide this into primary and secondary hemostasis. So, bleeding can be due to either there is a defect in the blood vessel, platelet disorder, derangement in the coagulation, or combination of all these things. So, It can present as purpura. It can present as deep soft tissue bleeding, which is coagulation disorder, or in a combination which is present as generalized bleeding disease. And it can be inherited or it can be acquired. So inherited, what is called as platelet disorder, or inherited coagulation disorder, or combination of inherited platelet and coagulation, what is called von Willebrand disease, and it can be of acquired type, which is of platelet and also coagulation factor and also the combinations. Most of the time when you look at the bleeding, we look at only the hemophilia and the von Willebrand disease, but the most important factor is the acquired coagulation disorder is the most important common cause of bleeding. Patient comes with acquired, it can be due to the thrombocytopenia, it can be due to the liver disease, it can be due to renal failure. So these patients can come to any department, not only to the hematology department, it can come to the surgery, it can come to the medicine department, it can come to the any department, or simple nasal bleeding can come, or it can present as generalized bleeding. It can gynecologic, one of the common cause of bleeding, or inherited factor, which we think this is the bleeding disorder, but inherited causes are relatively rare compared to the acquired bleeding disorder. So how to approach this patient? If a patient comes with the bleeding, how a lab approaches this? It needs a systematic approach. So in this 20 minutes, we will discuss about how I approach in my lab a patient comes with the bleeding. So it starts with not only if a patient clinician tell you do a what is called a PT, APTT and factor 8 or factor 9, it's not like that. You will go through this. You have your own system how to approach a case of bleeding. First is the detailed clinical history, and if a blood has come to your lab, you'll have to see whether this blood is properly transported to your lab or your collection and your then comes the analysis and comes the diagnosis. After the diagnosis, you'll have to tell the clinician what to do next. Okay. So a patient can come as a umbilical bleeding, subcutaneous bleeding, petechiae, purpura, ecchymosis, hematrosis, intramuscular bleeding, urinary bladder bleeding, or uterine bleeding. It can be deep subtissue bleeding or any other generalized bleeding disorder. So first one is the bleeding assessment tool. When a patient comes to you should have a proforma how to have a clinically assessed whether it is a congenital or acquired bleeding disorder and whether it is a bleeder or non-bleeder. There is a tool is there, and you can have a proforma, or you can have it is there in your, if you have a laptop or any what is called as a mobile, a bleeding assessment tool is there, and you can sum up this and maximum score whether it is a normal range or a patient is having a bleeding or non-bleeder. Then comes the history, whether it will decide, this history will decide whether there is a bleeder or non-bleeder, whether it is mild, moderate or severe, whether it is due to the defect in the primary hemostasis or secondary hemostasis or combination. If it is acquired, what is the type, if it is inherited, whether it is autosomal dominant, recessive or X-linked type. Then comes the clinical diagnosis. You should have your clinical diagnosis, not only if it's patient sent by the clinician that the patient is bleeding, you should have your own clinical data, how to approach this. Then comes the, for example, is the case of 14-year-old male, large swelling in the back of the thigh, the soft tissue bleeding, and it is since it is a childhood, it has bleeding, so, and it has got a family history. So the case is, it is a bleeder, it is a severe bleeding because it is starting from the childhood. It is a secondary hemostasis because it is a soft tissue bleeding. It is a X-linked because it is a maternal uncle is died of similar type of disease. So it is a most likely diagnosis, inherited coagulation disorder. Then you approach this according to their inherited ones. So how to, most important part is the collection of blood and its transport. we look at most of the time clinician sees the report that this is this, but the most important part is the how to send the blood and how to processing it. Okay. The collection is the patient preparation, recommendation of the blood collection, sample handling and preservation of the sample. The four things has to be the most important step in a case of bleeding disorder. It is not necessary that patient comes to you and immediately will collect the blood. Patient should have avoid stress and vigorous exercise and avoid the tourniquet. If you are using the tourniquet, most of the time if a bleeding disorder patient comes, you should not avoid the tourniquet. If you are using tourniquet, it should not be more than 2 minutes. And the laboratory start must be your technician and your doctor must be knowing what they are doing. Okay. And sample collection is the most important part. And if whether you look at the sample, whether it is a clotted or icteric or a lipemic sample. So what are the vials to be used? Vials to be used are the for the EDTA, platelet poor plasma is the and platelet rich plasma and the observed plasma and the aged plasma. These are the four samples you need. Four things. For the EDTA blood, EDTA vial, and for the PT, APTT function, platelet function, observed plasma, you need the what is called as blue colored vial, and for the aged serum, you call the red colored vial. And you must know how the collection of the blood, series of the collection of blood. Then sample handling is for the transport of the sample, if the laboratory as soon as possible. It's not that we will collect in the overnight and send it in the morning. It should send the sample within 1 hour of the collection. If it is delay, and then the examination, it must be properly filled sample. If it is a 1:9 to be collected, and examination whether it is a hemolysis or if it is lipemic is there is a chance that you should not process that sample. Okay. Then criteria for sample rejection: if it is unlabeled, if it is a clotted one, if it is hemolyzed, if sample is broken, if it is wrong, you should not process all these samples. And what is the clotting stability? Once you receive the sample, you should process within 4 hours of collection. If it is, and in this 4 hours, you can keep it in the room temperature. If it is more than 4 hours, or the week, you can keep it in -20 or -50. For the -20 or -70, you should separate the plasma. There is an international guideline is there how to process this sample. It's given in the International Council of Standardization how to process this sample. You can go through this. So what is the basic hemostatic screen is first is the primary test and the secondary test. Primary test for the CBC, platelet count, bleeding time. Secondary hemostasis, PT, APTT, and secondary line of test is all these things. So how the first line of screening is the platelet count, CBC, and peripheral smear you must go find, not that if a clinician says do the only PT, APTT. For a bleeding test, you should start with the basic test, what is the platelet count, CBC, and peripheral smear, and PT and APTT. Fibrinogen is optional, and bleeding time is, if your technician is that much trained enough, you can do the bleeding time. Otherwise, there is no need of bleeding time. Clotting time nowadays is, we do not do the clotting time. Okay. And bleeding time has to be done by the template method. And if your technician is not good enough to do, don't do this thing. What is the role of the CBC and peripheral smear? And this is the first line is the count and morphology. CBC, count and morphology. For the RBC, cystocytes. Cystocytes is a feature which is usually seen in cases of DIC or microangiopathic hemolytic anemia. WBC, presence of the blast cell which will present with the bleeding disorder or DIC, which is called AML M3. platelet count morphology and agglutination is seen in the peripheral blood. So CBC and peripheral smear is one of the most important step which commonly we do not do. Okay. So in case of all cases of bleeding disorder, it starts with this morphology and CBC, and most important one is the parasite in our country. Falciparum malaria, it can cause DIC. So test for clotting pathway is the how to test for the clotting pathway? You do the PT and APTT. So if it is isolated increase in PT with normal TPC and APTT, what the possible abnormality is the, and most important is the liver disease. If a patient is vitamin K deficiency or warfarin is the formation, then comes the, you should suspect the factor VIII deficiency. You will have to, that comes in the clinical history. If a patient is receiving any warfarin or patient is having any liver disease is there, or all these things has to be ruled out before diagnosing this as factor VII deficiency. Isolated APTT increase in cases of factor VIII and factor IX, factor 11 and 12 usually do not bleed. Okay, if it is and in cases of von Willebrand disease, but you will have to exclude the heparin therapy. Patient is acquired inhibitor of the clotting factors or leukocyte anticoagulant before doing this what is called as isolated increase in APTT. Patient having increase in PT and APTT with platelet normal, what are the causes is the severe liver disease, vitamin K deficiency and heparin overdose, or in cases of inherited deficiency, what is called as factor 2, 5 and 10 and fibrinogen deficiency, or combined deficiency of factor 5 and 8 deficiency. So then comes the, depending upon the whether is isolated PT or APTT is increased, whether it is a congenital acquired disorder, go for the mixing study. Mixing study we do in whether the isolated increase in PT APTT, we mix this with the patient plasma with the control plasma, normal pool plasma. Normal pool plasma is important. You will have to collect it from the 20 donors, you will have to preserve it, you will have your own normal pool plasma, and you will have to standardize every day. You will have to every day you are starting with the normal pool plasma, what is your PT level and normal pool plasma. Then you add the Arger plasma, then the aged serum to look for the any factor deficiency. So mixing study will tell you whether it is factor 8 deficiency or factor 9 deficiency, factor 11, 12 deficiency, or presence of inhibitor. And test for fibrinogen assay based on the PT and APTT, you can go for the fibrinogen assay or D-dimer if you are suspecting for the hypofibrinogenemia or patient suspecting for DIC. Then comes the platelet function assay. It can be done by the platelet aggregometry, PFA and flow cytometry. Nowadays people are doing with the flow cytometry with suspected cases of Glanzmann thrombocytopenia or Bernard-Soler syndrome. So we will discuss some of the cases. So this is a case which we discussed earlier. What is a 14-year-old male? We discussed this, a bleeder is a severe one, is a secondary hemostasis. Then comes the autosomal recessive. What is the next test we will do? Next test we will do the CBC is normal, PT is normal, APTT is increased. Then you did this is what is called as test plus control. It's come to normal. That means there is a coagulation disorder which is it's on APTT. Test plus control Arger plasma is 33 seconds. Test plus serum is 62 seconds. So the defect is there in the either factor 8. Okay. The possible factor is the factor deficiency, and the factor 8 is less than. So the simple clinical history, PT APTT, mixing study, then the factor assay. Then case number 2, this is a known case of hemophilia A, and patient is receiving treatment. Now this patient is showing the symptom, and maternal family history, that is aunt has a family hemophilia A. She is getting on demand basis. Now the patient is having increasing bleeding tendency and clinically suspected to be an inhibitor. So what will do? Same CBC and platelets, CBC and this CBC hemoglobin is the WBC is normal or little bit increased, platelet is normal, PT is normal, APTT is increased, and when you do the mixing study, it's not with the normal plasma, it's not controlled, not coming to normal. Then you still look for the inhibitor study. It came out to be Bethesda acid 62. Then case number 3 is a case of large painful hematoma and gluteal lesion appears spontaneously after a history of trauma. Patient has there is no prior episode of the bleeding. Lab investigation, PT, APTT and all are normal. And when you did the urea clot lysis test, it came out to be factory. So history is important, and then systematic approach. So when you did the factor 13 assay, it came out to be less than 10%. Case number 4, patient having 5-year-old boy, prolonged bleeding from the trivial injury. First noticed in the child having started with it 1 year age, no current wound healing, patients having for the diagnosis. Sister, one of the patients died, the prolonged bleeding, tongue bite. So what is the test result? Hemoglobin is normal, WBC is normal, platelet is normal, bleeding time is more than 15 minutes, PT normal, and APTT is 70 increased, APTT with a normal pooled plasma is normal, and TT is normal. What the next test will do? Suspected case of what is called as more than increased bleeding time and APTT, suspected a bleeder, platelet is normal, morphology, blood smear morphology is normal, so suspected to be a von Willebrand disease, and we did what is called as platelet aggregometry. It came into the not reduced to the ristostatin. The suspected could be a von Willebrand disease or Bernard-Solier, but Bernard-Solier used to be a thrombocytopenia and large platelets. So because this patient has got normal platelet and normal morphology, so the possible diagnosis is the von Willebrand disease. So how I investigate is this ILSS approach is there. You can go through this, how to investigate case of bleeding disorder. One of the best handbook is there is the practical hemostasis. You can go through this the practical hemostasis, or if you have an Apple phone, if the Apple close to Embolus app is there, and son you can go your how to approach a bleeding disorder. So summary of this: clinical history, pre-analytic factor and systematic approach plays an important role for the in case of bleeding. First line of screening test is CBC, peripheral smear, PT, APTT and mixing study if a suspected. So important first one is the history. History will tell you where you stand. Then screening test is the CBC, CPS, PT, APTT and mixing study. Second line of investigation is the based on the final first two, history and the CBC screening test, second line of investigation. Then the most important point is the technique, equipment and the reagents should be standardized. Before you must be standardized yours, and most important is the technician and the doctor. Technician and doctor must know what they are doing, okay, and quality control, external and quality control for your lab. So even if you have got a lot of doctors, your technician must know what he is doing. Okay, thank you.
Okay, Dr. Behera, well presented, nicely explained. Thank you.
House is open for any questions, if any. Thank you, sir.
Thank you, sir, for that enlightening talk. We'll be moving forward to the next session on quality control. I would like to invite the two chairpersons on the stage, Dr. Shambhavi Sharma ma'am, consultant pathologist, Safera Hospital, Patna. Can we please have you on the dais? And Dr. Amber Parvez sir, assistant professor, Department of Pathology, AIIMS, Patna. Sir, can you please invite the speaker on the stage?
It's my privilege and honor to introduce our next speaker, Dr. Ruchi Sinha ma'am. She's a professor of pathology and Dean Academics at AIIMS Patna, and she's actively associated with several clinical trials as PI or co-PI. Ma'am, please take the stage and enlighten us with your knowledge.
Thank you, Shambhavi, and a very warm good evening to all. We are the last few straggler speakers. I won't be taking much of the time. And as Dr. Behera concluded his talk, he spoke about quality control. So what is quality? Quality is a state where you have which is free from any error, any deficiency. Is that what? So any excellence towards that is what is quality. And it is brought about by, it is not an easy task. It has to be, you have to be disciplined and you have to adhere to a measurable and verifiable standards to achieve this level of quality. And if you see this diagram, there is a diagram there which shows 3 circles. The outer, the biggermost circle is quality management. Then we have quality assurance, and at the core of it is the quality control. So quality management is the overall comprehensive approach to the tests, and these includes not only the lab but includes the clinician who is writing the test, whether he is writing the correct test, he is writing the number of the tests which are required for the diagnosis of that condition. So it starts from there and it ends at how the report is interpreted, and in between comes the lab services. So this is the comprehensive, a very extensive level which is quality management. Next we have quality assurance. This is where the main lab comes into focus, and these are all the activities of the laboratory right from receiving the sample to releasing the reports comes under quality assurance. So we have here pre-analytical, analytical as well as the post-analytical. Whereas in the quality management we had even pre-clinic analytical, that is where the clinician writes the tests, what lab investigation he wants to come to a diagnosis. So quality control is at the heart of quality, and it is all the tests or procedures or process which are there to detect, reduce the any deficiency or defect and pick up any eliminate or minimize any errors to it. So the primary purpose of quality control is to evaluate a sample and to verify whether the method which you are using for it is within the specific within the specifications, and whether it is between the acceptable bias is there. That is quality control. In the laboratory, there we have 2 types of quality control: the internal quality control as well, and then we have the other set which is the external quality control. So internal quality control is specific to that lab, and it is a continual evaluation and which you can immediately target. And whereas external quality control is between laboratory, it is inter-laboratory, and it varies from method to method. That is why we have something called as a peer group in external quality control. So what we do every day or on a regular basis within the lab is your internal quality control, and what we do at fixed regular intervals between the labs is our external quality control. So what is the quality control? These are any what are the components of internal quality control? So we have it is just not related to reagents. So it has a part of manpower, how well trained your manpower is to perform that tests, because if the test is performed wrongly or the pipettation is wrong, the quantity is wrong, that will also affect the test. So manpower is a component of it. Then what equipment you have. So infrastructure also plays a role in internal quality control, and what we usually equate with quality control is the reagents or the test procedures which will be testing. But actually internal quality control is dependent on a lot of variables. So before you start a quality control, there are certain steps which have to be undertaken. For the foremost is that you have to plan which are the quality for which parameters or which tests you want to do the quality control. So you have to plan, that is the first step. Next is you write down the SOP, the procedures, that how you will go about doing the quality control, what are the steps of doing the quality control. Then the next steps of quality control itself and assessing it. So once you have decided that yes, I want to run quality control for hemoglobin, the next is how you will be doing it. You write down the steps, then you will be running that quality control, and the data which you will be generating, you will have to assess it, whether that is within the range or whether it is out of the range. And based on that, you will be improving the quality of your lab. So this is an entire circle which starts from planning and ends at improvement. So there are certain terminologies in quality control. Everybody is familiar with accuracy and precision. Accuracy is that the value which you is closest to the defined range of that quality control, whereas precision is that if you run that same quality control again and again, you get the set of results as close to each other. So everybody is familiar with this target diagram showing high precision, high accuracy, low precision, low accuracy, and high precision and low accuracy, and low precision as well as low accuracy. There is another way to represent this data as a Gaussian curve. So the other is the standard deviation and coefficient of variation. And so standard deviation is the measure of dispersion. So how far away from the mean of the result our value is coming when we run it on the machine, whereas the other is the coefficient of variation. So it is used to compare for variability across data sets, whereas standard deviation is used to measure or compare the variability across a single data set. So this is how the calculation is done. I will not dwell upon it. Then there is another term which we use with quality control is calibration. Calibration is not done routinely. It is done as when the machine is installed. So calibration is a sample which has the same value against a standard. Usually it is a WHO standard. So this is used when the machine is being set up to calibrate the instrument. Calibration is then regularly in between at intervals. It is done when there is maintenance, annual maintenance of the instrument. At that time the calibration is done. Another scenario where calibration is done when your quality control is running deviating from the known mean, then the calibration is done, whereas calibration is not regularly done. More is what we do is internal quality control. So this, what is a control material? So control material is any reagent or device which is used for the quality control process. So the quality control material has to be similar to, it can be natural or it can be synthetic, but it has to be similar to the human whole blood. It should be stable over time, because these have kept, they are to be transported by the manufacturer to the end users, and even at the end users we use it for a period of like 15 days or a month as the case may be. And it should have well assigned range of measurable parameters, and there should be multiple levels available, like low, high, normal, or low and high, and it should be commutable. So these are the some of the internal quality controls which we are running in the hematology lab of AIIMS Patna. So for the cell counter we have, because the machine is from Sysmex, we have E-check. Then for coagulation again we have a high and low. For this cell counter we run 3 levels, a low, normal and a high. For the coagulation we run a normal and a high. Similarly for ESR machine we also run controls, and for our HPLC machine or instrument also we are running. So these are the controls which we run every day when we start the machine. And for each machine, if you have multiple machines, for each machine when you start we run a internal quality check. So the data, when you will run the quality control, you will be generating a data. So how to use that data to know whether the tests which you are running are within the range, the expected range, or whether they are going out. So this is done by the Levy-Jennings chart. We chart that data, and for that everybody is familiar with it, that we use for plotting we use the LJ chart or the Levy-Jennings chart. And it is expected, the last line is that we use the premise that 99.5% of your tests will be coming within this 2 standard deviation. The problem starts when multiple your data points fall beyond the 2 SDs or beyond that, that is 3 SD. And how do we chart on it? So we need at least 20 runs have to be there, 20 data sets have to be plotted to decide whether your controls value which is given by the instrument is coming okay, or whether it is out of control and you have to apply some corrective actions. So the advantage of LJ chart is that it is a simple display of the data. You can easily interpret it whether it is within the range or out of the range, and accordingly do your corrections. So this is just an example to show for each parameter a LJ chart is plotted by when the control is run by the machine itself. And when does it indicate a problem? So for that we have the West Guard rules are there, and everybody is again familiar with these West Guard rules 1, 2S, 1, 3S, 2S. Due to shortage of time I will not be discussing this. So like a point which is this red point at the bottom here is when we reject it. The yellow one is between 2S and 3S, this is a warning sign but acceptable. So similarly we have different rules are there of West Guard which is used to reject a run and do corrective action, or whether it is just a warning and you can release the report of the patients. So there are certain errors which are there, which we call systematic error and random error are there. So systematic error is which is when your data sets, the points are trending or it's towards one end of the LJ chart, where and this indicates that your accuracy is not good, but precision is correct, because all the results are coming towards one end, but it is not coming towards the mean of the result, but all the tests. So the precision is good in a systematic error, but your accuracy is wrong. Systematic errors can again be of two types, shift and trend. Shift is that when there is a sudden jump, suddenly one value is totally out of the different from the other set of your results, that is called as your shift. Whereas trend is when there is a gradual, slowly towards one side all your results are coming. So this is usually happens is when the reagent is deteriorated towards the end of the shelf life of the reagents. This is what happens, or when the calibration of the machine or the maintenance of the machine has not been done. So whenever there is an error, then what has to be it is indication that you have to do certain corrective actions. So what are the corrective action is? One is that you clean the machine, shut down, rinse, start the machine again, or you auto rinse the machine, rerun the QC, call the engineer and perform the maintenance of the machine, check whether your reagents are within the expiry range, or whether they have already expired, and whatever corrective action you take, you have to document it and maintain a log. So another role of this is where I will tell you about delta check is, this is another way where you can know whether your result which you are giving is correct or not. Delta check is when you run a patient sample and then compare it to the previous results of the same patient when it has come before to you, and you compare with it. So if it is within the acceptable limit, you can release the result of that patient, but if it is out of, this is especially done during dengue season for the platelet count and patients who are leukemic patients who are on chemotherapy. So you can check with the previous results of the patient. Now coming to the from the internal, we move to the external quality assurance. So this is done at regular interval, not every day, quarterly or every 6 months or yearly this is done. So in this you compare your result with the other labs who are also running the same test with the same set of reagents and in the same machine. So here the concept of peer group comes into. So your results will only be compared to those other labs or hospitals who are doing the same, using the same machines with the same reagents. So if the machine is different, it will be a different peer group. And so most of these EQUAS samples, they can be from a lab, standardized big lab from within India, or it can be from outside India also. So we have EQUAS being run by AIIMS Delhi, then from CMC Vellore, and outside the country we have UK NEQUAS is there. What we are doing for the coagulation study in AIIMS Patna, we do UK NEQUAS. So in this Z-score comes, this is a statistical method where they compare your results with the other results. So this is what we are doing, the proficiency testing with the AIIMS New Delhi for our hematology. So they send us a sample which we run for the CBC, and this is the result, and you can see the lower the Z-score, the better it is. And the color, if you can see, there is a green color and certain values are in the red color. So green is acceptable, whereas those which go into the red, that it is a warning, and if it is orange, that means you are above, your Z score is above 3. So that is when you have to take some corrective actions. And there is another Uden plot can be used to show for the accuracy and the precision. Sigma matrix is another statistics which can be used, but most of the time we use our the LJ chart and the Westcard rules are applied to that. So my take home message is that quality control is a necessity. It has to be done. It is not a luxury which you can use. If you want to give a good result to the clinician, because the patient management depends on it, so quality control is your assuring yourself and the clinician that the result which I am giving out is which you can believe and trust, and accordingly treat the patient. And it also tells you if to take corrective actions, because if you don't do quality control, then you are not sure that the result which you have given today is okay or not. So that is why every day when you start the machine, a quality control run should be minimally run. Thank you.
Thank you, ma'am, for discussing such a complex topic in a simple way. So the house is open for any question and comment.
I would like to ask a question. Because quality control is very important for the laboratories, especially for those laboratories which have low sample load and it is not possible to run the controls on everyday basis, what can be done so that they give a decent report to the clinicians?
Good question, Dr. Shambhavi. In this you can do what, that you keep the sample, the previous day sample, and you run it again the next day and see how it compares to the previous day's sample. That can be, if you cannot run quality control every day, this is one way which you can check whether your, one is how, this also checks your whether how you are storing the sample. That is also tested, and this way you can overcome if you cannot do quality, run your material every day, you can, this is what you can do, that run the sample the next day and compare it with the previous day results. But there is no shortcut for if you cannot run it every day, run it the every other day.
Thank you, ma'am. The house is open for
I'll
the
just
question.
give a comment on
Yes,
this,
sir.
that I think Dr. What Madam says that you can't get a shortcut. I think in quality, it doesn't depend upon the less number of tests you are doing. So, but you have to run the controls daily. Only when the big laboratory, obviously they will run the controls more than once a day. Like every 24-hour lab, then every 8-hourly control has to be run. So a 2-level control has to run. But in a small lab, at least once a day, 2-level control has to be run. There is no compromise, as Madam
Yes,
said. I agree with her.
Thank you, sir.
Well, my comment or question is a little different. You may not answer that. You have been talking of the quality control, taking into consideration what is the standard value for that.
Yes, sir.
But my question is whether those values which have come from the Western world, is it applicable 100% to Indian population? Have we found out what is the standard value, what is the range in Indian population? Most of the hematological or blood reports.
Sir, actually
as
what
far
this
as we clinicians are, we find a lot of difference between the diseases in the Western world and in India, age-wise, and lots of difference. So is this a question or my question is absurd?
No, sir, it's not absurd. What you're talking about is the range what we give for the results, like for hemoglobin. You say, but what the quality control we run, the range is already assigned. They have been tested and assigned by the company which is giving it to us. Like when AIMS sends it to us, they would have tested it and sent it, and then what we give, that will be again compared to the peer group, and then our score. That's why when I showed you that report of ours, there it will be, there are different columns if you've seen. What we run the test twice. There's run 1, there's a run 2, and then we give the mean, and then our result is again compared to what value was assigned to that quality control, and then what our peer group who is running on Sysmex XN 1000, on that principle, how many other labs are also enrolled, because somebody must be doing it on another Umizan or Minray or whatever Beckman Coulter. So I will be only compared with the Sysmex, and then my Z score will come, sir. So your question is, in the clinical scenario, what range we give? Yes, it is based on Western. We should be doing Indian, and I think so some places they have already started doing this work. I see under ICMR project they are doing it. But in the quality control, the values are assigned by the whichever from wherever I am getting, they have assigned it. So in that Western or Indian does not come.
May I add just one sentence that when I'm talking of internal internal quality control, that is no assigned value. It is a value which you will do in your lab, and a precision has to be obtained. The same value you should obtain. It is whereas that is different from the calibrator. Yes, calibrator is an assigned value. It is hemoglobin 8.8 means everybody should get, whoever calibrated their equipment, the hemoglobin has to be 8.8. Whereas when you use a internal quality control of whether Sysmex or any other company provided, they just give a range, but you just have nothing to do with that range. Only thing you are supposed to do is with the LJ chart, so that every day you are giving a value with good precision with a very narrow coefficient of variation. So that any value is not important for you. It is that's what the quality control. It doesn't have a value at all. They just give a range for just give a range. The range is actually not important.
So what about EQUAS in that?
EQUAS is about accuracy. Yes, sir. Because that we expect that a large number of laboratories, like 95% laboratories, will get value which will be closer to a value which is common among, so everybody will get a similar value. Whereas those who are getting out of the range the values, obviously they are not doing a good job.
Yes, sir.
So that's what you showed in
yes,
that chart.
Yes, sir.
So it is
Thank you.
Can we please have all the chairpersons and the speaker on the stage for photography? Thank you, ma'am, for elucidating such a complex topic with remarkable clarity.
I forgot. I would like to thank Dr. Pritika and Dr. Rita. They helped me, in fact, with a lot with this presentation. Thank you so much to both of them.
Now moving on to the next session. The topic is basics of flow cytometry. I would request our respected chairpersons to kindly come to the dais. Dr. Imranul Haq, sir, Director, Department of Pathology, Medanta, Patna. Dr. Khurshid Malik, sir, Head of Department of Pathology, MCS, Patna. And Dr. Sanjeet Kumar Singh, sir, Professor and Head of Department of Pathology, AIMS, Diogar.
Delighted to introduce our next speaker, Dr. H. P. Patti. He is well known as ex-professor of hematology in AIMS, New Delhi, ex-president Indian Society of Hematology and Blood Transfusion. And the topic he is going to speak on is the basic of flow cytometry. It is a very important topic. Unfortunately, many of the labs don't have this facility, so I think it should be a very educating lecture for us. So Dr. Patti, please.
Thank you. We have hearing a lot of on the flow cytometry. You must have attended so many talks on flow cytometry. What you see is basically the dot plot we saw in multiple colors of grouping of cells, but we rarely talk about actually the basic part of it, what is going behind that. The flow cytometry is in routine use in hematology. It started around 1995, starting with the most important one, that is the leukemia or lymphoma lineage identification. What you call in the multicolor flow, what you mean by that the simultaneous analysis of multiple parameters with the fluorescent level antibodies, that is what you mean by the multicolor flow. Typically, if one are using called a 10-color flow cytometry, which have called a 10 detectors will be there, called the photomultiplier tubes, which detect individual the fluorescence and the fluorochrome, and can test about 10 antibodies in a single tube, along with two parameter, common parameter again we must have heard, called the side scatter or the forward scatter. So, and these instruments usually have about two lasers, or may have even a 3 laser. So this is how the flow cytometer usually works. Presently, flow cytometry is a gold standard for many hematologic disorders. As I told you that immunophenotyping of lineage identification of leukemia, lymphoma, the PNH clone size study, the CD34, the stem cell count, the HIV CD4 cell count, so and TB, NK cell identification subset, so and the spherocytosis also, EMA study. So many studies are, this is also the gold standard test. So that's become a very more routinely now in use. So what flow cytometry, if you remember in our CBC analyzers, there also the principle is called hydrodynamic focusing. That's what it means, that the single cells stream is there, the cells are flowing in a liquid medium in a single flow. Same thing also is happening in the flow cytometer. Under pressure, the cells move in a called the flow chamber or the flow cell. And the laser light, there's a beam is at the focusing on the individual cells which is in the flow chamber, and producing a scatter light and the fluorescent signal detected, because the cells are attached with a different fluorescent leveled antibodies. So with specific antigen, they are like, for example, you say 20 is there, you have used a FITC conjugated anti-CD20, CD20 antibody. So that it is surface antigen, until that fluorochrome will be attached to the surface, and the laser beam is now activating this fluorescent signal, and this will be detected by the two detector systems are there. One is the photomultiplier, which will detect the fluorescent signal, and another is called a photodiode, which detect the forward scatter. So this is just showing that the laser beam is coming, and the individual cells, they are excited, and which is at 100 degree at in the same direction, that is the forward scatter, and at 90 degree direction, that is the SSC, called the side scatter is there. So these are the two more parameters are also there, along with exciting the whatever the cell according to the cell fluorochrome is attached. So different fluorochrome, the intensity can be detected by the photodiode multiplier tubes. So this is just to say that so many photomultiplier tubes are there. So there can be 8, 10 or 50, whatever it is, the number can be more depending upon to detect different fluorochromes of different wavelength will be detected. Again, the laser are used commonly like 488 or 633. So different lasers are there. Is commonly the flow cytometers have about 2 lasers or maybe 3 lasers, or the higher end ones can be even up to 4 or 5 lasers can be there. So that basically the function will be of different fluorochromes can be excited. This basic flow cytometry, the important is the how to collect the patient sample, and the most important the sample is the blood or the bone marrow aspirate, or rarely even lymph node aspirate. The anticoagulant used are the potassium, dipotassium, EDTA, heparin, ACD, but the preferred most common anticoagulant used EDTA, because mostly the flow cytometry study are done on the same day processing. So, and with EDTA, the morphology also is better. And for morphology, these slides must be made while you collect in the sample. The slides should be made, because we all know the morphology changes if you are the sample is there for longer period in EDTA. But once we know that if the sample is will be more than 24 old, if we are not able to process, or it has to be transported, then only the heparin is the other another preferred anticoagulant. And because in heparin the antigen preservation is higher, even viability of the cell viability is again important, that also again much better than EDTA anticoagulant. Again, another tissue commonly used, you can say for flow cytometry is lymph node biopsy or the true cut biopsy. Again, here for the freshly you can transfer the lymph node without even any fixation, straight away, only the moist cloth you can transfer it to lab, and then it can process. The only delayed processing, then only different things are there, like RPMI media and all that there, and where the cells has to be made into the single cell suspension by a mechanical disruption or a proteinase like trypsin or the collagenase are commonly used. Some cases where the test should be done as quickly as possible, like the Burkitt's lymphoma, we know is a highly proliferative cell. The PNAs, the MRD samples, the lymphoma aspirates, they should be done as soon as possible, particularly within 8 hours of the study. The body fluids again need to be processed on the same day. If they are transported for longer duration, then can be even 4-degree temperature can be there. The CSF and another vital sample for flow cytometry is to be processed within 2 hours, or if a longer duration can be preserved in RPMI in bovine serum. Samples can be at room, all samples usually for up to 8 hours can be at room temperature, don't need refrigeration, but even up to 36 hours, it can be preserved in the refrigerator at 4-degree temperature. For longer duration, more than 36 hours, then only you can need RPMI, the medium again is important. Transport for longer duration, RPMI media, as well as the temperature control again are important. The cell processing, what exactly one does with the sample, the few steps are important. One is important is the lysis, the lysing the red cells. Different lysic reagents are there. Commonly procedure is the stain, lyse and wash. You stain the slide with the different antibodies and then lyse and they wash. The procedure common for most of the procedures, but sometimes the lyse and wash stain, some laboratories use for MRD, but no wash stain and only lyse and no wash for CD34 count, so prevent cell loss, and stain wash and no lyse for others like platelet processing, RBC, very specific things like cell cycle study, apoptotic study. So these are the things are there. And the cell concentration again is important because usually this is kept at 0.5 to 1 into 10 to the power 6 cells for 50 microliter. In each assay tube can there, and where multiple antibodies are used. For fluid and aspirates, the cell number can be much less. The other step is fixation and permeabilization. They are not done in every case. The fixation is important, particularly if they are doing an intracellular antigen studies where both fixation and the permeabilization are important.
like when you are looking for the antibodies like MPO, TDT, the cytoplasmic CD20, CD3, CD22, cytoplasmic immunoglobulin. So there the antibody is not on the surface. Obviously, you have to make pores on the cell membrane by the permeabilizing agents, and then only the fluorescent attached antibodies can enter the cell and attach the specific antigens are there. The another one is the viability study. Again, this is not important for in every case, but if the samples are old, particularly more than 24-hour old, then the viability study was there, because obviously the dead cells will interfere in the interpretation. So there, again the test is done with a DNA binding dyes like propydium iodide, and the cell viable cells must be more than 80% so as acceptable cell to cell. The fluorescent reagents, commonly as we said that the antibody conjugate with fluorescent dye or the tandem dye were used, but this DNA binding dye also have the fluorescent producing the reagents. The viability dye, as we discussed, that also again also produces a fluorescence. So these are not only antibodies conjugated, they only fluorescence, but some others are also again fluorescence. The same principle also used in the CBC, we use for particularly the high-end CBC equipments where we have reticulocyte count of the immature reticulated platelet count. So there we are using the fluorescent dye binding RNA, and when leukocyte differentiating with staining the nucleic acid. So the same principle also again used in the CBC analyzer as well. Just to give some examples of the fluorochromes are there, they have different wavelength are there, and the tandem dyes again also are there. So as per the many one can use, because as if you are used at the same time, multiple antibodies, each antibody has to be attached with a different type of fluorochromes with a different wavelength. So one has to choose judiciously different a large number of antibodies. Obviously, same antibody, same fluorochrome cannot be used in the same tube. The antibody panel selection, again another, all these things go before you interpret or you find what always show in our interpretation. But before the interpretation, all this goes into in the panel preparation, because panel preparation will be important to differentiate lineage T cell to B cell, blast to immature, from hematogon to lymphoid blast, the myeloblast to mature myeloid cell or myelocytes. So that's again the panel has to be properly made. The appropriate combination of antibody and fluorochromes, because the fluorochromes as you said that the wavelength may be very close by and they will be overlapping and interfering. So that also one has to look into. Usually the multiple tubes are used with a different combination of antibodies in every, like a acute myeloid leukemia, or if you are doing a CLPD, the panel are chosen properly with 3 or 4 tubes with the different set of antibodies. The lab has to pre-decided which antibodies they are going to take. And the important thing is 2 things. One is the antibody titration, antibody cocktail. The titration again with a large quantity of antibody, if you use not only it is a wastage, but also it will interfere and will give too much fluorescence and will will not give you the optimal result. So antibody the optimal result one can see even a smaller quantity of, so that one has to titrate with the antibody, the different antibodies and a particular result we are going to get. So maximum signal with least the background noise. So each antibody need to be again titrated, and this antibody cocktail with that titrated and different antibodies for each tube, you can make cocktails. So for like for example, if you are doing a acute myeloid leukemia with 14 or 15 antibodies, you don't have to really open all the 15 antibodies, and from each one you have to titrate different amounts. From this you are taking 2 microliter, From the other one, you're taking 4 microliter, another one 6 microliter, what as per your titration. You can pre-cocktail you can make for tube 1, like 4 antibodies of the one is 2 microliter, another is 4, another is 8, another is 10. Of about 10 total case, for 10 cases you have made a cocktail. So that type of you have to pre-decide, and so this prevents the pipetting error, or you may forget. Like for example, you have to take some antibodies, a group of antibodies in one tube, and technician may forget to take one. So actually what you will get is a completely negative report, and you don't know actually it is because of this cell doesn't have that antigen, or it is because the technician forgot completely. So that can be easily prevented if you are making the antiviral cocktail. Again, it is a standard practice in laboratories. This is just to give that many of these antibody panels are made, they are very flexible, you can decide on your own. Just to have given like for example, the acute myeloid leukemia, usually the common ones like 45, 34, MPO, 117, 13, 33, TDT, 11B, 65, they are the myeloid markers can be, all this you can include, or you can may choose depending upon how much laboratory you have. You need not have all the antigens available in lab. So depending upon like that. And the linear specific marker again important, because that must be there. Then only like CD3 and 7 for the T cell marker, or 13, 33, 117 as myeloid marker. So at least so that this is a myeloid lineage that should be there before even saying there is blast or they are mature cells. Similar CD19 again for the B cell. So these are the pre-decided for different antibody panel selection. Again, just to frame also, I'm not going to detail, so their panels are there. Again, they are all flexible, but as they're just an indicator, otherwise you can take. Aberrant antibody, again, they're important for diagnosis. Like for example, the CLL, the B cell lesion, the CD20 DIM is helpfully as a diagnostic marker. Like CD5 is a T cell marker, but again used in CLL because it is shown that CD5 is positive and important marker in CLL. So also the other examples there. Gating of population. What is gating? Is guessing it the selection. The what say you are wanted blasts, obviously you have to gate and say that these cells are actually the blasts. Like CD45 is a common marker used in every tube. You can use CD45 and it helps. Like just example of the APML or the TLL or BLL from the bright CD45 or slow CD45. So on that basis you can really, or CD5 negative, you can actually see the population whether they are blasts or not. Or maybe you can use like CD34 positive or CD3 positive for exactly it is a T cell subgroup, so gating can be again be cell specific to as per the markers. The forward and side scatter again like even we have, as you say, our CBC also we can the mature cell granulocyte, monocyte, lymphocyte. But we want simplify forward and side scatter without any use of the antibody, the fluorescent antibody. One can see, one can also recognize the cell population. This is we do in day-to-day our practice. Commonly what you see is the gating in different that the dot plot, the commonest one, but not the only one. One can use the other plots like the contour plot or the density plot or the histogram are also used to see the particular histogram is used to show the intensity of the fluorescent. The mean fluorescent intensity is high increased or reduced. So there are different types of plots are there. The commonest of course is the dot plot used in diagnosis. I'll just give you the quality control again is a vast chapter in this. The quality control from time of sample collection, the antibody panel choice, the fluorochrome combination, the daily, weekly, monthly, annual equipment maintenance, the antibody titration as we already discussed, for the flow check pro, flow set pro, for they are again important, compensation controls, daily use of 2 controls, particularly if we are doing for the normal cells. So and equals are again for interlab. it is not available for to do in as a national level, but in your own city you can do it. Those laboratories who are doing flow, you can among those laboratories you can do a inter-lab comparison and see that your data are matching every maybe 3 monthly you can do. So many advances also in flow cytometry. I will not go into detail. Now the flow cytometries are becoming they call the spectral flow cytometer with a high speed single photon. The use of the multiplier tube PMT tubes are obviated with a single photon sensors. Imaging also has been added to the flow cytometry called the real type imaging flow cytometry, the mass cytometry. Now we are mass spectrometry we know, but combined with flow cytometry called the mass cytometry. So there are a lot of the advances are there in the flow cytometry are coming up. So the exciting time is there in future for the flow cytometry. I will end here. Thank you.
Thank you, sir. You have made this complex topic very easy to understand, right from collection of the sample to the basics and how to choose the panel, how to decide the fluorescence and how to tag the fluorescent dyes. And it has become really easy for us to understand, and we can also, in Patna I think only few centers are doing, 2 or 3 centers are doing right now. But yes, it was a very good learning experience for especially the residents and the people who are not aware of the basic things. Yes. And you have made it in a flow only. Thanks, sir.
Thank you, Dr. Pati, for your nice presentation. My question is a bit away from the basics. Especially I am a hematopathologist, so in day-to-day practice, we face some difficulties. For example, in the treatment after chemotherapy of the acute leukemia, especially the BALL, sometimes after the induction, when we do the bone marrow, we find difficulties in the hematogones and the blast. So how do the flow cytometry will help in this identifying the hematogones?
No, the hematogones flow cytometry can be really clearly differentiated, but it is not required in every case. Wherever you are seeing a hematogones, you need not have to really do a flow cytometry, though there because flow cytometry one can differentiate because it is not a single cell, single population. In the hematogones are really both can be CD10, CD34, CD20, all it will be a spectrum of positivity. Where blasts are will be 34 positive and TDT positive, which will be not positive for the mature cells like CD20 positive or CD10. So this is how you can, but in every case you need not have to do the hematogone for a flow cytometry differences. Most cases the number of the hematogones are very limited number, because maybe around 7% or 8%. In most cases really the clinicians what we follow is just to, if you are getting a good number of maybe that doesn't look like blasts, because usually the hematogones they are not clearly good clear the nucleolus is not there, the multiple nucleoli what you find a clear blast which is not there, or mostly the blasts of hematogones have a scant amount of cytoplasm and most is a hazy the nuclear nuclear content. This is one way to differentiate, but if the number is too high, many times simply the repeating the bone marrow after another week, the hematogon disappear. This is what we have practiced at AIMS Delhi, that many times we just advise is that defer it another week and after repeat the bone marrow, and usually they all disappear. But in rare cases one can do that is easy, simple way to differentiate by flow cytometry, not a difficult thing.
Yeah, any questions from the audience? So if there is none, so thank you very much, Dr. Pati.
Thank you so much, sir. This was a wonderful session. I kindly request you, the speaker and the chairpersons, for the photography. without any delay, we'll move on to the next topic, that is evolving treatment landscape in management of recurrent and relapsed adult B cell. With great honor, I would like to call upon the chairpersons, Dr. Ketan Nathani, DM Clinical Hematologist, Paris Hospital, Patna, and Dr. Sudha Sethi, Associate Professor and Head of the Department of Clinical Hematology, SCB Medical College and Hospital, Cuttack, and followed by Dr. Mukesh Bharti sir, Clinical Oncologist, Darbhanga Medical College, Darbhanga. Please come to the dais, sir.
Thank you all for inviting us to chair this session. Actually, I would invite Dr. Riaz for his topic of discussion is evolving treatment landscape in management of relapsed or refractory adult audit B cell ALL, adult B cell ALL. So he is a very nice speaker and he is very well known for his lucid deliberation for the complex topic. So you can go ahead for that.
Good evening everyone, and thank you for giving us the chance to speak again. So just had a session on AML, so we are speaking on relapsed refractory B cell ALL. So acute leukemia, the center of treatment for all hematologists, whether it is AML or ALL. When a patient of ALL comes, we know that a lot of things can be done, and this is one of those disease in which still the chemotherapies of 60s and 70s is still valid, and we are able to cure most of the patients. Not all, most of the patient. We can say 90% of the pediatric ALL is still treated with the chemotherapy regimens or chemotherapy drugs and the regimens which has been made from 70s. Very few diseases are like that. And in adult, things are not that same. The adult population of ALL doesn't tolerate the chemotherapy that well. And we see in the range of 30-40% survival rate. And as the age crosses 50 years, the survivals drop to 10%. So before 50 years of age and more than 50 years of age, 30 to 40%. Less than 15 years, you have good survival in the first line. ALL is a very good disease to treat in the first line setting. Lot of good outcomes. You are attached to the patient for a long time and you are giving very good hopes. Yes, it can be done, it can be treated and over a period of time. But ALL is the worst disease if it relapses. The survival drops to less than 10%. So relapse ALL, getting treated and surviving for more than 3 years is a nightmare. Not many relapse ALL will be roaming around with more than 3 years of follow-up. So we know that relapse ALL, relapse refractory ALL is a bad disease, one of the worst disease to say. So treatment of ALL, as I say, it has still remains the same. Induction chemotherapy, lot of consolidation chemotherapy, finally the maintenance chemotherapy, and only one aim, to prolong the remission as long as possible. Now this is one of the many trials which has been done, that okay, what if the patient after induction therapy has gone into CR, what is their survival? This is for adults. You can see 40-45%, less than 50 years of age, and 40-45% means if I treat 10 patients, 5 patients is going to be cured. I know 5 patients are going to relapse in coming months or coming years. And if they are not into the CR, the survival is only 5%. Means I'm going to lose almost all my patients if they are not in CR. This is very standard, I said, induction, chemotherapy, consolidation, 20-30 weeks, and finally maintenance. This is the standard, and it has been initially started for the pediatric ALL. Finally, the adult regimens were made around the pediatric ALL, and things were modified accordingly. But we know this is the prognosis. 44% will have relapse, and once relapse, it's the bad. Poor prognosis associated with number of clinic failure and no complete remission, no minimal residual disease, and if they are not transplanted, there will not be much survival. So MRD is the new term, I can say relatively old term or new term you can say. Once we know that AML 4 standard drug induction has been given, and at the end of induction, if you only do bone marrow aspirate and biopsy and document CR, that's not enough. The first point, MRD is in, we had a beautiful session previously just now by Dr. Pati, that MRD, based on that MRD is the important, the MRD in ALL, if they are positive, you know, things are going to change. The dynamics of treatment is going to change, and if it is MRD negative, you may continue on chemotherapy. So I'm not going to talk a lot about this. MRD, it was done. The role of transplant in ELL, yes, MRD positive, you have to go, or high risk. And if you are not sustaining MRD positivity, you try to go into MRD negative with newer regimens or some innovative therapy and go for transplant. So what are the options when we know that it's in adult ALL, 40–50% of our patients are going to relapse. So what if the patient is going to relapse? What do we have? So either you enroll in a clinical trial, which is, you can say, none in our country. Treatment with chemotherapy, that has been the mainstay. We have been treating relapsed ALL with high dose chemotherapy without, you can say, much evaluating what has been the response. And with the advent of new CD19 and CD20 antibody targeted therapy, things looks that it is going to change. Okay, so in relapse refractory, as I said, we have been using a lot of high dose chemotherapy. What are the regimens? FLAG-IDA, CAG, clofurabine. Clofurabine was brought into the market, then it has been again withdrawn. So what we initially have, FLAG-based therapy or cladribine-based therapy, and you can use hyper-CVAD in few cases when they have not received. And we know this relapse cases of adult ALL, they don't generally tolerate chemotherapy well. Will have treatment-related mortality, lot of infections. It's a nightmare to treat adult relapsed ALL. So according to the NCCN guidelines, the newer therapy, you can say either in clinical trial, or if they are chemotherapy with steroids, or blinatumab, or you can say inotuzumab is the newer one, or the CAR T cell. So what we are going to discuss is the inotuzumab. This has been around there in the market, and we have somehow some experience with the inotuzumab also. What we can go ahead in this group of patients, we'll see in the inotuzumab. So as I said, this relapse ALL, once into remission, if you don't do anything, the survival is less than 10%. But those who go into remission, if you do the transplant, 30–40% we will be able to salvage. So relapse refractory ALL, if the transplant is not done, no survival. And if you do transplant, of those patients achieving CR, you have got 40%. So of the 10 patients who have gone into transplant, 4 are going to survive long term. So this is the prevalence and incidence and the mortality in India. You can see not incidence is quite high, and you can see the mortality is as good number. Means not many good centers are able to handle even ALL. Good centers are also not able to handle ALL in the first line or in the relapse, and we are seeing mortality. This is the Indian perspective of the all few centers combined, and in this what they were able to, the author was able to find that there are multiple regimens. MCP 841 was the most commonly used. BFN, GMAL, hyper-CVAD, TKI based regimens in the pH positives. In the MRD, if you can say, end of induction MRD was detected in 5% of 61% of the patient done. Overall relapse rate was 25–57% in this reported group. So adult ALL 25–57, you can see almost very high numbers. So what are we going to do this for? And the post-relapse treatment, if I can see, most of the patients chosen palliative therapy, not because they were not, it mainly the finances people have already spent. So 70–80% to 90% of the patient have chosen palliative therapy rather than curative therapy, and only 1–4% have achieved second remission. So this is the current scenario of relapsed ALL. okay? And we are not able to provide exactly good treatment options. This is our own. We have to say ourselves, hey, see, we don't have good, once we are relapsed ALL, it's a nightmare for us. So prognostic factors can be different. Poor prognosis is associated with older age, T-cell phenotype, high WBC count, pH positivity status, failure to achieve CR after induction. So what factors determine your choice of therapy evolution? Age, MRD status, CD219 or CD22 expression. For pH positive or pH negative ALL, when would you like to consider blinatumomab only or with or without TKI is the first line. There are few questions we will see. So let's see these two questions in the coming slides, few slides. Now this is the old slide, and you can see from 2000, this is the prognosis of relapsed ALL. Once the patient relapse, first relapse, 5-year overall survival is only 7%. And outcome is, you can say, 2-year, you can say, in the different LALA group was 11% and OS of 8%. So not even 10%, 1 out of 10 patient is surviving. We know it's, based on this data, it's a bad disease, something needs to be done. And this already said transplant is the only way, but how to achieve that remission and patient to go for transplant? And we know transplant is not like it's an easy job, it's a tough job. We try to avoid as much as possible, hardly given the chance that, okay, transplant needs to be done, the patient has to be taken for transplant. It's not easy for the doctor and the patient to go for transplant. These are the few new drugs which has been there, either in B or T cells, which has come over a period of time. This is the timeline from 2010 to 2022. You can say blinatumomab has come, the inotuzumab has come, and now the CAR-T is available or for this relapsed ALL group. So now we have the option of blinatumomab, we have option of inotuzumab, and option of CAR-T in relapsed B-ALL or MRD positive B-ALL. So a lot of patient trials has been done with inotuzumab and blinatumomab, and with variable response. If you can see the molecular response of in the range of 30 to 60%, and even in going up to 80% with complete MRD negativity. So that different authors have reported in different, but almost 50-60% of the patient have been said that, okay, they have achieved remission, and out of those 40% have gone into for transplant, and the survival, if you can see, again it's dismal. 7 months, 6 months, 36 months in one study, not great. This is, even with the transplant, you can see, not much. This is a very early data we can see. NCCN guidelines again, sorry, it's a repeat of slide. So who is the ideal candidate for inotuzumab? Relapsed refractory patient with CD22 positivity. Early salvage setting is always better than the better outcomes observed in the earlier lines. Ineligible for intensive chemotherapy or transplant initially. And consider for the patients needing disease control or MRD negativity before allo transplant and minimal extramedullary disease. So inotuzumab is not going to work if you have a lot of extramedullary disease. So this is the INNOVATE trial. We have studied just a repetition of this, relapsed refractory CD22 positive ALL, D4 salvage 1 to 2 therapy, more than 5% of the leukemic bone marrow blast, pH negative or pH positive if failing more than one second generation TKI ALL. So inotuzumab was given in total of 164 patients, starting dose of 1.8 and 0.8 on the day 1 and subsequently 0.55. And the cycles was repeated, and this was being followed as compared to standard care with FLAG, ARASI, HIDAC based on the physician's discretion. So in this, what we saw is the CR rate in the INNOVATE, the inotuzumab, whether you are giving combination of low-dose chemotherapy, what we are using, mini CVD. We know that 80-90% of the work is being done by the immunotherapy alone. Chemotherapy, we can say it's the physician we are adding on, but mainly the work. So even if you are using single agent inotuzumab, you are seeing the CR rate of 80% as compared to 30% in the salvage standard care with the chemotherapy regimens, and MRD negativity as going as high as 78% as compared to 28% in this salvage standard the chemotherapy arm. So innovate long term, when the response and proportion of patient who were MRD negative, you can say again it was maintained over a period of time, 73 versus 30%, and the MRD in the responders group 76 versus 38%. So most of the patient, those who achieved the first cycle, 85% of the patient has, 70% of the patient has achieved 85 out of 120 in the first cycle itself, and another 25 in the second cycle, and another 3% in the 3 cycle. But in cycle 4 to 6, none. So what we see is 3 cycles is enough to have the maximum response. Even if you are giving more, there is no use. So duration of response, you can see how long, 4.6 months is the maximum, you can say the median duration when the patient was kept on the follow-up. Again, the patient will relapse again. So we know that this is only a bridge. Inotuzumab has got very good response rates, MRD negativity of 80%, but duration is only median of 5 months. So in these 5 months means you have to do something else so to keep the patient in remission. So first thing was to bring the patient into remission. Bringing a patient of relapsed ALL into remission is nightmare. With inotuzumab in B-ALL, it has gone up to 80%, and if you just only give inotuzumab few cycles and chemotherapy, eventually the patient will relapse in another 5 to 6 months. So we have some time to decide. In the transplant eligible patients, you need to do transplant. So if you counsel a patient that only inotuzumab is enough to keep the cure, it's not, it has to be bridge. So this is the progression-free survival in the inotuzumab arm. You can see 3.7 to 5.6 months as compared to 1.5 to 2 months in the patient receiving the chemotherapy. Long term, you can see 22.8% in the 2-year overall survival, and 3-year was 20% as compared to 10 and 6 in the standard care arm. And it was better what the standard chemotherapy is there. Now those patients who went into remission, and the person the arm which has the inotuzumab, more number of patients were able to get enrolled in the transplant. So the MRD negativity, CR rates were better in the inotuzumab. The response was much more, duration of response was almost 5 months to 6 months, and more patients were convinced for going into the transplant. Whether the transplant help on long term, those who have received the inotuzumab, yes. That when the transplant was done on those patients, the you can say 2-year survival increased to 39, almost 39 months as compared to 13 in the no transplant arm. And inotuzumab was associated with lower hospitalization rates despite longer duration of as compared to the standard care. Survival by the salvage status, if you can see, the patient going with the inotuzumab followed by the transplant had better chances of survival as compared to the standard. Now, how important is the MRD? We always say before you do the transplant, the patient should be MRD negative. MRD negative gives you the chance that when the patient has been taken for the transplant, and if it is pre-transplant MRD is negative, the chances of survival is very high. So the patients who went for the transplant, those who are MRD negative, the median overall survival was 14 months, whether those patients who are MRD negative was 7.2 months. So better try to get the patient into MRD negativity. What we deduce is, okay, MRD negative is the way to go. But those patients who were also MRD patient positive, even after giving inotuzumab, they were also taken for transplant, and some had good response. You can see those patients has MRD negative, and the transplant had the best response. But also with the MRD positivity transplant, you can see 21, the third, 21 patients went, and the median survival was 11 months as compared to those patients who were MRD negative and didn't went for transplant, where it was only 9.4 months. So going for transplant, even with the MRD positivity, had better survival. So going for inotuzumab, again I am repeating, inotuzumab, better remission rates. Finally going for the transplant, even with the MRD negativity, has survival advantage. But those who had MRD negative had even better, 19 months as compared to 11 months in MRD positive. So what about the complications? The thrombocytopenia, neutropenia, and anemia remains the problem in this group, and the VOD, the liver-related issues, sinusoidal obstruction syndrome with transaminitis is the real challenge in the inotuzumab, which was more as compared to the chemotherapy arm. So we have learned that how the 2.7 milligram per meter square is the maximum. Even 1 or 2 doses of the inotuzumab is enough. 3 you can take for the transplant when it is bridge to therapy. Now, when the patient who have been taken for transplant, when they were followed up, yes, this arm had more the VOD as compared to the patient who have just not received inotuzumab, only received chemotherapy. So we have also learned how to manage VOD with the inotuzumab, giving some time. So what were the factors which were being taken to prevent this VOD was this inotuzumab related hepatotoxicity is linked to calcium payload leading to sinusoidal endothelial damage. Short interval between inotuzumab and transplant, less than 2 months, significantly increases the VOD risk. So when you have given inotuzumab, the patient is remission, try to give at least 4 to 8 weeks of gap before you take for the transplant, and that much time patient also need for a lot of logistic reasons, going to the transplant center, getting the finances arranged. We should not be in a hurry to do the transplant once the patient is MRD negative. Use of dual alkylating agent in the conditioning, so we don't not be using Bucide, the old regimen, that has increased the high VOD risk. Pre-existing liver dysfunction can also cause the damage, and cumulative hepatotoxicity from prior therapies can also do it. So monitoring VOD, I'm not going to this. Once VOD is developed, what are the prompt and targeted mitigation? So as we have discussed, we should know what are the factors, and once it has developed, using stopping the hepatotoxic agent, initiate defibrillate therapy, intensive supportive care with fluid management and ICU, and the repeat inotuzumab and counseling is the way to go. Whether CAR-T can be done after giving inotuzumab and whether it has got. So we know that now even in relapsed ALL that CAR-T works better. We have now options. So whether to go for inotuzumab or CAR-T. Now CAR-T is little better if it is done when your bulk of disease is less. So we need only 500 lymphocytes per cubic mm that CAR-T to be made. But sometimes the speed of growth is so much, the doubling time of blast is so much that the patient may not survive till the CAR-T is made. So what to do is you take the lymphocytes, you can do the apheresis, send it for CAR-T manufacture, and then use inotuzumab to reduce and try to bring it in under control. So those patients who were the inotuzumab was used, you can say their survival was much better after CAR-T than those who were not used the inotuzumab. So with this, I will stop my therapy, and thank you very much for the patient listening.
Thank you, Dr. Riaz. It is really a very nice experience to listen from you. And any comment or any question?
Sir, is there any plan for Indian government to include CAR-T monitoring help like government is doing for transplant? So is there any plan in the future that government will be helping the institutions in CAR-T therapy for the patients?
I'm not aware actually with the government, but yes, CAR-T has come a long way. It's with new companies coming in for the CAR-T, the prices is going to go down, and maybe this will be approved with some centers where PMCM fund can be used, and more people will be able to get this CAR-T. Whether government initiative, it's very tough for me to answer.
So one more question, like in case of this relapsed refractory ALL, adult ALLs, not going for transplant, And what's your experience? Like patients is in remission. You have given somewhat hypercived with sinotuzumab, and the patients have not gone for transplant. So do the patients remain in remission with the POM maintenance? Some sort of
To my experience, none of my patient has survived more than a year. Those who have not in relapsed.
Yeah, in relapse setting.
In relapsed, none of my patient has survived for more than a year. They all
Without
relapsed
transplant.
ALL, they have died.
Okay, sir.
Not more than 1 year.
Not more than 1 year. Thank you.
Okay. So, actually, we have finished this session. You have very fantastically completed your job. Thank you, Dr. Riaz. So we conclude this session. Thank you.
Thank you so much, sir, for the wonderful session. Now I request the chairpersons and the speaker to kindly have a photo session. Now we'll be moving on to the last session. I would like to make an announcement. As this will be the last session, dinner will be served in Hall B. So I request everyone to kindly have your dinner and then leave. Now coming to the last session, the topic is the art and science of meditation. I would request respected chairpersons to kindly come to the podium. Dr. C. Khandelwal, sir, Senior Consultant, Gastro Surgeon and Head of Department, Mahavir Cancer Sansthan, Patna. Dr. Niraj Vedpuria. Dr. Ratanish Chaudhary. This session will be chaired by Dr. Avinash Kumar Singh, sir, who is a Senior Consultant, Hematology and Bone Marrow Transplant Physician.
Well, I think everyone in the audience knows very well Dr. Avinash Prasad Singh, but still I feel to introduce him in a different way. We know him as a good clinician, as a good hematologist, as a good hemato-oncologist, probably one who has done maximum bone marrow transplant. But how many know that he is a spiritual man? And I was surprised to see that he knows every bit of his patient, every details. In tumor board, he would say everything about that patient 7 days earlier, what was the report and what. I was so surprised how much he is involved with his patients. And why I'm mentioning this, because this is gift to him because of his meditation. What he does in the heartfulness, what he does in other, like many people might not be knowing about what is heartfulness. Well, many people know about Bihar School of Yoga, the Isha Foundation, the Brahma Kumari, the Art of Living, so many things. Similarly, there is one heartfulness of which he is the follower. And when we listen to him, then probably we will know more about the subject. So may I request Dr. Avinash that science you have talked a lot, now you talk of art as well. So let Dr. Avinash speak and let us listen to it. Thank you.
Thank you, sir. Thank you. Good evening, everyone. And thank you, sir, for kind introduction. The topic of science and art of meditation was for Dr. A.K. Gupta, sir, who is professor of medicine, retired from Darbhanga Medical College Hospital, and for last 2 RAKTAVIGYAN, he talked on this subject, science and art of meditation or meditation. So this time sir was scheduled to come, but unfortunately he has mild fever and he is around 75, so he decided not to come. So I thought that we will discuss 10-15 minutes on meditation. So it's not a talk, not a scientific talk, so you should not worry. I would request all of you to come forward, please. एकदम हल्का है, इसमें कोई डाटा नहीं है, कोई PFS OS नहीं है, कोई मॉलिकुलर म्यूटेशंस नहीं है। डॉक्टर दिनेश सिन्हा आप आगे आइए। आई थिंक एवरीवन प्लीज, सारे लोग आगे आ जाओ, जल्दी जल्दी आइए तो जल्दी फ्री होइएगा। And I would request all of you to stay just for 10-15 minutes. You take your dinner and then leave. People who are leaving, they can do their dinners. Okay. So we will have one meditation session, experiential session tomorrow morning 7 a.m. I don't know how many will come. So faculty who are staying in this hotel, they can join. And whenever we discuss meditation, whenever we practice meditation, the numbers are not important. It's our mindset that if suppose someone discusses meditation, spirituality, we just want to go away. Why this happens? Because our brain are highly evolved. Throughout the day, so many things we have seen. One speaker had around 100 papers to discuss. This study, that study, PFS advantage, side effects, drugs. So we are highly evolved. We have done MBBS, after that MD Path, Medicine, Pediatrics. जो लोग रिप्रेजेंटेटिव हैं उन्होंने कुछ ग्रेजुएशन किया किसी सब्जेक्ट में, और उसके बाद हम लोगों को सिखाया गया कि भैया जीवन में जिंदा रहना है तो दिमाग का उपयोग करो, चालाक बनो, तेज बनो। खूब हर जगह हम लोग कैलकुलेटिव होते हैं, तो हमारा माइंड काफ़ी डेवलप्ड है। तो व्हाट इज मेडिटेशन? कोई बताएगा व्हाट इज मेडिटेशन? बोलिए, इसमें बोलना होगा सबको, बोलो व्हाट इज मेडिटेशन? व्हाट डू यू थिंक मेडिटेशन इज? एनी गेस, वाइल्ड गेस? बोलिए डॉक्टर अविनाश, व्हाट इज मेडिटेशन? वहीं से बोलिए, कोई दिक्कत। ओके, यस सर।
चित्त वृत्ति निरोध है। व्हेन वी आर फ्री ऑफ एनी थॉट्स, व्हेन ब्रेन इज नॉट, जब हम कोई विचार मन में नहीं है, जैसे व्हाट इज डार्कनेस? एक्चुअली एब्सेंस ऑफ लाइट। सिमिलरली एब्सेंस ऑफ थॉट, उस स्थिति में जब हम आते हैं तो उसको मेडिटेशन की एक स्थिति कहलाती है।
और कोई कहना चाहेंगे, कोई डिफिनीशन? ध्यान क्या है? यस, ठीक है। आप सर? यस सर। यस सर, यस सर, यस सर, यस सर। हाँ हाँ एकदम।
शादी से पहले माता पिता के साथ संबंध कितना अच्छा हो, बीवी शादी के बाद बीवी के साथ आपका रिलेशन कितना अच्छा है, ये बड़ा उसका इम्पैक्ट पड़ता है। क्वालिटी ऑफ हार्मोनी रिलेशन में है, सोशल मेडिटेशन हेल्प करता है।
हाँ सही,
इसलिए महिलाओं की इज्जत देना
सही सही सही।
महिलाओं पत्नी के सामने बोलिए दो चार बार,
हाँ,
ये बहुत बड़ा मेडिटेशन है। मेरा तो यही एक्सपीरियंस करिए या जो भी करिए हम।
यस सर, एकदम से बोलिए। वेरी गुड। सो जैसे ध्यान है, तो हम सब लोग यहाँ जो बैठे हुए हैं ध्यान के बारे में कुछ जानते हैं। किसी को भी हिंदी समझने में दिक्कत नहीं है ना? हाथ उठाइए किसी को हिंदी समझने में दिक्कत हो। नहीं ना? ठीक है ना? ठीक। हाँ हाँ, तो ध्यान जो है वो ध्यान के बारे में सब लोग जानता है, ठीक है। यदि हम लोग ऑक्सफोर्ड डिक्शनरी पढ़ें तो वहाँ लिखा हुआ है कि टू थिंक रिपीटेडली ऑफ समथिंग इज मेडिटेशन। ठीक है, जैसे कोई डॉक्टर है तो वो अपने पेशेंट के बारे में सोचता है, एनालिसिस करता है, बार बार सोचता है, तो दैट इज मेडिटेशन एज पर ऑक्सफोर्ड डिक्शनरी। तो ये हार्टफुलनेस संस्थान को पहले सहज मार्ग कहते हैं। सहज मार्ग एक मार्ग है विच टीचेज मेडिटेशन। तो देयर आर मेनी मेथड्स ऑफ मेडिटेशन। जैसे इंडिया में बहुत सारे इंस्टीट्यूट हैं जो हेमाटोलॉजिस्ट को ट्रेन करते हैं, सीएमसी वेल्लोर है, एम्स नई दिल्ली है, एसजीपीजीआई है, सबका अपना कल्चर होगा, ऐसे ट्रेन करना है। वैसे ही ध्यान सिखाने की जितनी भी संस्थान है उनका अपना ध्यान का कुछ परिभाषा होगा, कुछ मेथड होगा, कोई भी गलत नहीं है। जैसे मुंगेर योगा है तो उनका मेडिटेशन का कुछ टेक्निक होगा, ईसा फाउंडेशन है, आर्ट ऑफ लिविंग है, ब्रह्म कुमारीज है, वैसे ही एक सहज मार्ग है। तो ये सहज मार्ग डिफाइंस मेडिटेशन एज मूविंग फ्रॉम थिंकिंग टू फीलिंग। ठीक है, तो हार्टफुलनेस संस्थान में बताया गया कि मेडिटेशन इज मूविंग फ्रॉम थिंकिंग टू फीलिंग। सो हम लोग थिंक कहाँ से करते हैं? माइंड से करते हैं। और फील कहाँ से करते हैं? हार्ट से करते हैं। तो ये ध्यान में सोचने से महसूस करने की तरफ बढ़ने की यात्रा है। ठीक है, और इसको सीखना पड़ेगा। जैसे हम लोग साइकिल चलाना सीखे, बाइक चलाना, आज 4 व्हीलर चलाते हैं, ये ऐसे ही एक दिन में तो नहीं हुआ था। वी हैड टू प्रैक्टिस। तो ऐसे ही मेडिटेशन वी विल हैव टू प्रैक्टिस। यह इतना आसान नहीं है जैसे बोले थॉटलेसनेस हो जाएगा, आंख बंद करेंगे। हम 2 मिनट आप लोगों को देते हैं, क्लोज योर आईज, यू विल बी फोर्स टू ओपन योर आईज। आप बंद नहीं कर सकते हैं, इतने सारे थॉट्स आएंगे। ठीक है, सो वी हैव टू लर्न द आर्ट ऑफ मेडिटेशन। तो कैसे करना है मेडिटेशन? तो इसमें बताया गया कि वी हैव टू सेलेक्ट वन टाइम, फिक्स टाइम। बिफोर सनराइज इफ वी डू, दैट इज द बेस्ट टाइम। बट इट्स वेरी सहज मार्ग, सिंपल है, नो नियम कानून ज़्यादा नहीं, कोई धर्म, जाति, काम, नॉन वेज, वेज का बंधन नहीं है। इवन इफ समवन इज एडिक्टेड टू सिगरेट, अल्कोहल, दे कैन स्टार्ट मेडिटेशन। So time should be fixed. Suppose in my busy schedule I have 11 AM time, 10 minutes time for meditation, I can fix it. That daily 11 AM I will sit for 10 minutes. If you do before sunrise, that is the best time, but any time is preferred, but you have to fix. So you have to fix time, you have to fix place. आपके घर में कोई भी एक जगह हो जहां आप 10 मिनट बैठ सकते हो, आप उसको फिक्स कर लो। You can put a chair, that this is the chair where I will do meditation. It should not be on the bed where we sleep, because वहाँ सोने का वाइब्रेशन है। हम जब जाते हैं तो हमको नींद आती है। मेडिटेशन इज नॉट स्लीपिंग, उसमें सोते नहीं हैं हम। तो टाइम फिक्स करना है, जगह फिक्स करना है, और पोस्चर क्या होता है, कैसे बैठना है, तो उसको हिंदी में कहा गया इट शुड बी सुखासन। सुखासन का मतलब है कि हम ऐसे बैठें कि हमारे शरीर में कहीं दर्द नहीं हो। बहुत तन के बैठेंगे, कमर में दर्द हो रहा है, दैट इज नॉट सुखासन। सो इजी। एक मिनट सर, हम करते हैं। शवासन में आप लेट जाते हैं ना, तो वो नहीं ध्यान हुआ। तो इट शुड बी इजी पोस्चर, जिसमें हम आराम से बैठें और उसमें हमको हमारे शरीर में दर्द ना हो। दर्द नहीं क्यों हो? क्योंकि ध्यान में यदि दर्द होगा तो हमारा ध्यान जहाँ जाना चाहिए वहाँ नहीं जाएगा, उस कमर के दर्द पे, घुटने के दर्द पे रहेगा। बहुत सारे लोग ऐसा सोचते हैं कि अभी तो हम बहुत यंग हैं भाई, दौड़ते हैं, बहुत काम करने को है, नाम कमाना है, पैसा है, बच्चों की रिस्पॉन्सिबिलिटी है, बूढ़े होएंगे तब ध्यान करेंगे। जब आप बूढ़े होएंगे ना तो आप किसी काम के लायक नहीं रहेंगे, तो ध्यान तो छोड़ ही दीजिए। आपको घुटने का दर्द परेशान करेगा, आपको 25 तरह की दवाइयाँ लेनी होंगी, तो ध्यान नहीं। ध्यान इज लाइक वैक्सीनेशन, जो पहले से करके आप अपने जीवन को परिवर्तित कर सकते हैं। And any age, 15 year, 80 year, 60 year, 40 year can start meditation. तो इसका क्या हुआ, टाइम फिक्स हुआ, प्लेस हुआ, पॉस्चर हुआ, हम लोग हाथ को जस्ट जोड़ लेते हैं हल्के से जब बैठते हैं आराम से, ठीक है, एंड वी क्लोज आवर आइज and we take one thought. What is that thought? Thought is that the source of divine light is in my heart which is attracting me inward. इसको हिंदी में दिव्य प्रकाश का स्रोत हमारे हृदय में है जो हमें अपनी ओर आकर्षित कर रहा है। ये ध्यान किसी धर्म से संबंधित नहीं है। कोई इसको ईश्वर कह सकता है, कोई इसको नूर इलाही कह सकता है, कोई इसको वाहेगुरु कह सकता है, कोई इसको गॉड कह सकता है। इसका सिंपल मतलब यही है कि आपका जो भी हायर पावर आपके अंदर है वो आपको आकर्षित कर रहा है। आंख बंद करके इस विचार के साथ यू हैव टू सिट। तो व्हेन यू सिट विद दिस थॉट यू विल नॉट बी एबल टू सिट इन द फर्स्ट सिटिंग। व्हाई? बिकॉज अदर देन दिस थॉट विल डिस्टर्ब यू। कोई भी चीज़ हो, घर जाना है, बारिश हो रही है, क्या होगा नहीं होगा, कल आ पाएंगे कि नहीं आ पाएंगे, इतना लेट हो गया, उसमें ही भाषण दे रहा है, बहुत सारी चीज़ आएंगी ना। तो वी डोंट हैव टू एनालाइज थॉट्स विच आर कमिंग अदर देन थॉट्स वी हैव टेकन। बात समझ रहे हैं आप लोग? एक विचार शुरू में लिया, उसको बार बार रिपीट भी नहीं करना है। Whatever thoughts are coming, we have to ignore that. हमको उसके प्रति उदासीन बने रहना है। And when you sit for 10, 20, 15 minutes जो भी है, at the end of 10 minutes, you will feel something. And that you will experience. वो मेरे कहने से नहीं होगा या मोटी मोटी किताब मेडिटेशन पढ़ने से नहीं होगा। You will feel. You will be regular. 1 day, 7 days, 30 days, and the 30 days you will feel something, some change in your personality, some change in your behavior, some change in your acceptance, your anger, your जो भी होता है, आपकी जो भी कमी होती होगी उसमें आप परिवर्तन महसूस करोगे। बहुत सारी चीज़ें हैं जो हमको इरिटेट करती हैं। अभी किसी का फ़ोन बजे तो हर लोगों का रिस्पॉन्स अलग होगा। कुछ लोग को कुछ फ़र्क नहीं पड़ेगा, कुछ लोगों को लगेगा कि उठा के उसको बाहर फेंक दें, ठीक है। तो आपकी रिएक्टिविटी वो चेंज होगी और इसको आप महसूस करोगे। आप में जो सुकून होगा, पूरे दुनिया में जितना इंसान है वो सुकून की तलाश में है, चाहे वो अंबानी हो, टाटा हो, चाहे एक वेटर जो सर्व करने के लिए वेट कर रहा है, चाहे हम डॉक्टर हैं, कोई फार्मासिस्ट हैं, मेडिकल रिप्रेजेंटेटिव है। वी ऑल आर लुकिंग फॉर कंटेंटमेंट इन आवर लाइफ। और ये सारे मीन्स हैं। हम डॉक्टर की तरह काम कर रहे हैं तो परिवार का भरण पोषण कर रहे हैं, कोई होटल में काम कर रहा है, कोई कहीं काम कर रहा है। तो व्हेन यू डू मेडिटेशन, तो आइडियल मेडिटेशन कैसा होता है, या जैसे हमको कभी फील हुआ तो कैसा हुआ। तो जैसे आप सुबह में बैठते हैं, यू क्लोज योर आइज, यू रिलैक्स योर सेल्फ एंड यू टेक दैट थॉट। सो फॉर 2-3 मिनट्स यू आर अवेयर ऑफ सराउंडिंग। हम चाणक्य होटल में हैं, ये प्लेट के कुछ कुछ आवाज़ आ रहे हैं। इन 2-3 मिनट्स टाइम यू आर लॉस्ट। यू डोंट हैव सेंस ऑफ योर हार्ट बीट, आपको पता नहीं। फॉर अराउंड 25-30 मिनट्स यू आर लॉस्ट। देन एट द एंड ऑफ 25-30 मिनट्स यू विल फील योर हार्ट बीट। अब समझो आपका बेसल मेटाबॉलिक रेट कहाँ चला गया होगा, कितना कम रहा होगा। इवन यू हैव नॉट फेल्ट योर हार्ट बीट फॉर दैट हाफ एन आवर टाइम। एंड देन ग्रेजुअली यू विल हैव अवेयरनेस कि हम अभी चाणक्य होटल में हैं और हमारे कलीग्स थे यहाँ, हम ध्यान कर रहे थे। एंड हम आपको एक एश्योरेंस दे सकते हैं कि वो जो आधे घंटे का सुकून है या रिलैक्सेशन है, वो दुनिया में प्राप्त करने वाली बाहरी किसी भी खुशी, चाहे अचीवमेंट की तुलना में कितना गुना होगा, आई कांट कंपेयर। और ये मेरे कहने से, अगेन हम कहेंगे, या यूट्यूब पे किसी बाबा का वीडियो सुनने से, या कोई डिफरेंट थॉट्स वाले का सुनने से, या मोटी मोटी किताब पढ़ने से कोई फ़ायदा नहीं है, बेकार है लोगों के लिए। और कभी कभी होता है, आप लोग सोचते हैं कि या सुने हैं कि इस तरह की चीज़ों को हम सुनते हैं, लेकिन यहाँ से जब बाहर निकलेंगे तो हम पे असर अलग होगा। तो वो क्यों अलग क्यों होता है? Because as a human being we are in sleeping state spiritually. कुछ लोगों में कुछ लोग seekers होते हैं who wanted to know why I am so worried, why I have so anxiety, why I have sleep issues, why I have so many thoughts, why I am disturbed. या सिंपल चीज़ सोचो कि जब 6 महीने साल भर के थे बच्चे को देखो तो उसको कितनी खुशी होती है उसके चेहरे पे। वही बच्चा बड़ा होता है तो चेहरा क्यों लटका रहता है उसका? खुशी गायब है, सब कुछ बढ़ गया, पढ़ाई हुआ, एजुकेशन हुआ, पैसा हो गया, अच्छे अच्छे कपड़े हैं, घर है, कार है, पहले साइकिल पे चलता था, लेकिन खुशी कम हो गई। कुछ तो हुआ है। देयर मस्ट बी समथिंग, सम थॉट कंट्रोल या रेगुलेशन, वो कहीं दिक्कत हुई। सो जो सीकर्स होते हैं, जब चीज़ें उनको हिट करती है और उसको फॉलो करते हैं तो इसी को अवेकनिंग कहते हैं। आप लोग सुने हैं कभी स्पिरिचुअल अवेकनिंग हुआ किसी का? नहीं? तो जैसे यदि हम स्पिरिचुअली सोए हुए हैं तो कितनी भी चीज़ें हो, कितनी भी घटना हो, कोई हमारा साथी है, कोई हमारी मान लो वाइफ है, बच्चे हैं, पड़ोसी होगा, हम पर कुछ असर नहीं होगा, बिकॉज अभी हम सोए हुए हैं, अभी हम सोए हुए हैं। लेकिन इन लाइफ देयर मे बी सम मोमेंट्स, सम ओकेजन when we may have questions, when we may look for answers कि ऐसा क्यों होता है, then we will roam around कि अरे कुछ ऐसा बात हुआ था, वो क्या बात था, उसको सुनेंगे, प्रैक्टिस करेंगे, चीज़ें हमारे लिए चेंज होंगी। लेकिन आप कितना भी चाहोगे, आप अपने पार्टनर को, बच्चों को, दोस्तों को, किसी को चेंज नहीं कर सकते हो। यू कैन चेंज ओनली योरसेल्फ। पूरे दुनिया में आपका अधिकार आप ही पर है, आप कितना कोशिश कर लो। आपकी पत्नी है मान लो, वो बहुत मान लो थोड़ी सी सैड रहती है, एंग्सियस है, डिप्रेस्ड है, आप कितना भी कुछ कर लो, यू कांट चेंज हर सेल्फ, जब तक कि वो खुद नहीं डिसाइड करती है कि हमको चेंज होना है। ठीक है? सो वी हैव कंट्रोल ऑन आवर सेल्फ ओनली, एंड व्हेन वी चेंज आवर सेल्फ बाय मेडिटेशन, या कुछ और भी हो सकता है, पूजा हो सकता है, कोई अच्छी किताब पढ़ के हो सकता है, then surroundings will change. We will start accepting people, we will start accepting gracefully. वहाँ tolerate करना नहीं होता है कि हम लोगों को tolerate कर रहे हैं। ठीक है? तो कोई पेशेंट भी आता है, मान लो गुस्सा होकर के बोलता है तो कभी हम यदि परेशान हैं तो हमको लगेगा कि ये इडियट आदमी है, इसको नहीं देखना है भाई, इसको कोई और देख ले। लेकिन जब यदि आप मेडिटेटिव रहते हैं, देन यू फील कि अरे उसके बच्चे को मान लो ब्लड कैंसर हो गया भाई, उसकी जगह हम रहते तो उससे ज़्यादा गुस्सा होते। तो कोई नहीं, आप बैठिए बैठिए, बच्चे को प्यार से दुलार दिया, इतना ही देख करके 5-10 मिनट में वो फादर वो चेंज हो जाएगा, एकदम परिवर्तित हो जाएगा। और ये ब्लड कैंसर का इलाज तो 3 साल चलना था, और शुरू में ही कम्युनिकेशन खराब हुआ तो सब खराब। सो मैसेज इज we all should learn any art of meditation. Students हैं, consultants हैं, senior लोग हैं, we should learn art of meditation. वो आपका कुछ तरीका हो, कोई और सिखाए, कोई और मेथड हो, but we should learn. That is for ourselves only. अभी तक जितना हम लोग डिस्कस किए आज, कल करेंगे, that is for our patients, our career, और अच्छा इलाज कैसे करें ना। लेकिन ये जो है मेडिटेशन, that is for आपके लिए है। हाँ, so you can try it. You can try it for 7 days, you can try it for 30 days. If you don't feel good, leave it. कोई ज़रूरत नहीं। हो सकता है ये मेथड हमारे लिए नहीं हो, कोई और मेथड होगा, कोई समय अलग होगा, when we will have. So I personally, I do meditation and wherever I am in clinic, हमारे क्लिनिक के स्टाफ लोग हैं, उन लोगों के साथ मेडिटेशन करते हैं। उसमें बहुत सारे को मन नहीं करता होगा, लेकिन हम कहते हैं करो मेडिटेशन। हमारे डिपार्टमेंट में है, BMT में है, जितनी नर्सेज हैं, डॉक्टर्स हैं, उनको कहते हैं आप करो। जो भी हैं, डॉक्टर रहमान हैं, डॉक्टर ये हैं, केतन हैं, हमारा कोऑर्डिनेटर है, सब लोग मेडिटेशन करता है। और आज तक हमको कोई ऐसा आदमी नहीं मिला। बहुत सारे जगह हम जाते हैं जहाँ की डिस्कस करते हैं मेडिटेशन के बारे में। I have never found any single person who has said कि अरे यार एकदम बकवास चीज़ है या इससे कोई फ़ायदा नहीं हुआ, ठीक है. बट वी हैव हेजिटेशन इन डूइंग दैट. हम अपने आप को बैकवर्ड फील करते हैं कि अरे ये क्या है. मैंने सब लोग तो अच्छे अच्छे कपड़े, अच्छा डिजाइन, ड्रेस, स्मार्ट बनना, अच्छी अंग्रेजी बोलना, ये फैशन है, ये क्या, ये तो बेकार है एकदम. आंख बंद करके पीछे जाना होगा, ये नहीं करना है. लेकिन इफ़ यू डू मेडिटेशन, वट एवर यू डू, आप क्लिनिशियन हैं, पैथोलॉजिस्ट हैं, फिजिशियन हैं, आप अपने काम को बहुत अच्छे से कर पाओगे. एंड सबसे बड़ी बात है कि नो वन इज़ परफेक्ट. सो वट एवर यू विल डू, यू विल एक्सेप्ट योर सेल्फ ग्रेसफुली. सबसे ज़्यादा हम लोग अपने आप को ही हेट करते हैं, अपने अचीवमेंट को ही अंडरमाइन करते हैं, अपने आप से ही परेशान रहते हैं. तो ये मेडिटेशन आपको अपने आप को पसंद करना, अपने आप को प्रेम करना, सेल्फ लव डेवलप करना, सेल्फ कंपैशन डेवलप करना. जब ऐसा होगा तो आप किसी से हेट कैसे कर सकते हो भाई. आपका हृदय इतना पवित्र हो गया कि एक बच्चा यदि किसी दूसरे कंट्री में ही बमबारी में मारा जाता है, यू सी द न्यूज़, हाउ कैन योर हार्ट नॉट फील द पेन कि उसके मदर को, फादर को क्या महसूस हो रहा होगा. सो दिस मेडिटेशन इज टू बी हार्टफुल, मूव फ्रॉम thinking to feeling or mind to heart, and that will give you the best contentment, self love, compassion. और हमको लगता है कि इसी की ज़रूरत है. पूरे देश, 2 देश लड़ाई कर रहे हैं, पैसे के कारण हो, वाइल्ड बेचने के कारण हो, पॉलिटिक्स हो, कुछ भी हो. अरे अल्टीमेटली आदमी मर रहा है भाई, कोई एक जीवन चला गया इस दुनिया से. भाई इससे बुरा क्या हो सकता है. हाँ, बीमारी कोई थोड़ी हुई थी, अचानक से बम गिरा, 20-25 हज़ार लोग मर गए, ठीक है. तो इट्स इम्पॉर्टेंट एंड आई थिंक एवरी वन शुड लर्न द आर्ट ऑफ मेडिटेशन. इट्स फॉर अस. और जैसे जैसे हमारा उम्र बढ़ता है हम लड़ना ही सीखते हैं, अपने भाई से लड़ते हैं, ज़मीन का बंटवारा हो चाहे जैसे भी हो. यदि एक हॉस्पिटल में 4 डॉक्टर हैं तो वो आपस में कम्पीट करते हैं, वो मेरा ले लिया, वो मेरा ले लिया. बाप रे बाप, ओह माय गॉड. खाली मैंने कंपटीशन और लड़ाई ही है. हम यही फील करते हैं कि एट द लास्ट मोमेंट जब किसी आदमी की जान जाती होगी तो उसको ज़रूर अफसोस होता होगा कि बहुत सारा चीज़ जो हम किए नहीं करना चाहिए था. बट एट पर्टिकुलर मोमेंट वी डोंट पुट इम्फेसिस. हमको लगता है कि नहीं, सब लोग सिखा रहा है कि ऐसे करने से ही जीवन जिया जाता है, नहीं तो हम घाटा में रह जाएंगे, हम पीछे रह जाएंगे. सो दैट इज ऑल अबाउट साइंस एंड आर्ट ऑफ मेडिटेशन. एंड साइकोलॉजिकल प्रॉब्लम्स दे लीड टू ऑल सोमैटिक प्रॉब्लम्स. ब्लड प्रेशर, डायबिटीज़, फलना चिलना जो भी होता है. आपको नींद नहीं अच्छी आती है, किसी को यदि नींद की दवा खानी पड़ती है, सो इट्स इम्पॉर्टेंट टू लर्न मेडिटेशन.
अविनाश, 2 मिनट का अनुभव क्यों नहीं हम लोग को कराते हैं?
Yes sir, yes sir. So we will have guided heartfulness relaxation and then meditation for 5 minutes. I would request you can keep your phone in sleep the silent mode and just relax. After that we will have dinner. Okay, please don't talk. हाँ, लाइट ऑफ कर देंगे. आप लोग भी बैठ सकते हो, बैठ जाइए, बैठिए. अरे बैठ जाओ भाई, कोई दिक्कत नहीं है. सब लोग रेडी हैं? कुछ सवाल है किसी का? एनी क्वेश्चंस?
अच्छा नींद कैसे आए?
हाँ
नींद नहीं आती है.
हाँ, तो वो मेडिटेशन से ठीक, अपने आप ठीक हो जाएगा. सो मेडिटेशन का जो एम है दैट इज द हायर सेल्फ रियलाइजेशन या गॉड रियलाइजेशन कहते हैं. बट हैप्पीनेस, कंटेंटमेंट, गुड स्लीप, सेल्फ लव, ये सब उसके बाई प्रोडक्ट्स हैं. वो अपने आप मिल जाएगा आपको. कोई कहता है कि हम ओबीज हो रहे हैं, चाहे हमको कुछ प्रॉब्लम है मेटाबॉलिक, सो इफ यू आर मेडिटेटिव योर बॉडी विल टेल कि यू शुड ईट दिस मच, यू शुड ड्रिंक वाटर, यू शुड स्लीप दिस मच. योर स्लीप क्वालिटी विल इम्प्रूव एंड थिंक विल इम्प्रूव. चलो तो करते हैं मेडिटेशन.
दिमाग में सोते वो वही आता है, फीवर आता रहता है, मतलब ब्लड से लाया, सिम्टम आया, लक्षण आया, उस दुनिया से कैसे बाहर?
हाँ, हो जाएगा. विचारों को नियंत्रित करना ही मेडिटेशन सिखाता है. हम यदि किसी पेशेंट के बारे में सोचते सोचते रात में सोते हैं तो हम अच्छे डॉक्टर नहीं हैं. वी डोंट नो हाउ टू मैनेज. So we have to learn how to manage. The best doctor is best at the moment, जहाँ पेशेंट देख रहा है, डिसाइड कर लिया, डिसीजन हो गया, बात खत्म. उससे बहुत इमोशनल अटैचमेंट भी नहीं है, लेकिन उसके लिए बेस्ट कर रहा है. जब ज़रूरत हुआ तो बेस्ट सोचा, फिर हट गया वहाँ. तो पेशेंट का भला होता है. बार बार सोचने से तो और इरिटेट होके जाएंगे. कल को पेशेंट कुछ कह देगा अटेंडेंट, तो कहेंगे हम दिन रात होने लगे सोच रहे हैं, तुम ऐसे बोल रहे हो. नहीं नहीं, इमोशनल नहीं. हाँ हाँ, नहीं इमोशन नहीं होता. क्या है कि बताते हैं, जो ट्रू इमोशन है, जो प्योर इमोशन है, वो नहीं. हमारा इमोशन जो है वो हमारे थॉट्स ने धुंधला कर दिया है, उसको क्लीन करना है, वो मेडिटेशन से. चलिए अभी करते हैं, ठीक है? हाँ, बैठे बैठे सब लोग. So even if someone is not willing, please keep your eyes closed for 5 minutes gently and just follow. Close your eyes gently. 2 बार लंबी और गहरी श्वास लें और धीरे धीरे श्वास छोड़ते हुए अपने आप को शांत एवं शिथिल बनाएं. अब एक विचार लें कि धरती माँ से एक रोग हरने वाली ऊर्जा हमारे शरीर में पैरों से होते हुए प्रवेश कर रही है. अपने पैर के अंगूठों को हिलाएं और उन्हें शांत एवं शिथिल करें. आपका तलवा, एंकल, काफ, नी, थाई, हिप्स, दोनों पैरों की एक एक मांसपेशियां शांत, शिथिल एवं तनाव रहित हो गई हैं. धरती माँ से आने वाली यह दिव्य ऊर्जा हमारे पूरे शरीर में प्रवाहित हो रही है. दोनों पैरों में जो भी थकावट, दर्द या अकरन था, वह पिघल गया है. धीरे धीरे यह दिव्य ऊर्जा अब हमारे कमर, पीठ, पेट एवं छाती की मांसपेशियों को शांत, शिथिल, तनाव रहित बना रही है. धरती माँ से आने वाली यह दिव्य ऊर्जा अब हमारे दोनों कंधों में प्रवेश कर रही है. कंधों में जो अकरन या तनाव था वह पिघल गया है. आपका बांह, केहूनी, फोरआर्म, कलाई, हथेली, उंगलियां, फिंगर टिप्स सारे शांत, शिथिल, तनाव रहित हो गए हैं. धरती माँ से आने वाली दिव्य ऊर्जा हमारे पूरे शरीर में प्रवाहित हो रही है. गर्दन के नीचे का पूरा शरीर रिलैक्स हो गया है. सारा दर्द, सारा तनाव पिघल गया है. धीरे धीरे गर्दन के पीछे की मांसपेशियां रिलैक्स हो गई हैं. मस्तिष्क की मांसपेशियां रिलैक्स हो गई हैं. अपने चेहरे पर एक हल्की मुस्कुराहट लाएं. आपका माथा, आँख, नाक, कान, गाल, जीभ, दांत, ठुड्डी सारे शांत, शिथिल, तनाव रहित हो गए हैं. आपका पूरा शरीर सिर से लेकर पैर तक रिलैक्स हो गया है. शरीर के किसी भी भाग में यदि तनाव या दर्द महसूस हो तो धरती माँ से आने वाली इस दिव्य ऊर्जा को उस तरफ डायरेक्ट कर उसे तनाव रहित बनाएं. अब धीरे से अपना ध्यान अपने हृदय की तरफ ले जाएं और एक विचार लें कि दिव्य प्रकाश का स्रोत हमारे हृदय में है, जो हमें अपनी ओर आकर्षित कर रहा है. कृपया ध्यान शुरू करें. दैट्स ऑल। आप धीरे से अपनी आँख खोल सकते हैं और अपने स्थिति का अवलोकन कर सकते हैं कि आप कैसा महसूस कर रहे हैं। थैंक यू एवरीवन, थैंक यू। ये मेडिटेशन जो होता है उसमें एक प्राणाहुति होती है, प्राणाहुति। उसमें कहा जाता है कि इफ़ यू डू मेडिटेशन, इवन इन फर्स्ट मेडिटेशन यू कैन अचीव समाधि, दैट इज अ क्वालिटी। सो यू कैन ट्राई, यू कैन प्रैक्टिस। और गौतम बुद्ध कौन थे नहीं थे किसको पता है? यू डू मेडिटेशन एंड यू फील कि गौतम बुद्ध को ऐसा ही लगता होगा। हाँ, लोगों ने कहा गौतम बुद्ध, आप फील कीजिए पहले आपको कैसा लग रहा है। यू डू प्रैक्टिस, यू लर्न एंड सी थिंग्स विल चेंज। थैंक यू एवरीवन।
Thank you so much, sir.
रिलैक्सेशन जो है सर, शुरू में जो हुआ वो योग निद्रा का पार्ट हो सकता है, बाद का मेडिटेशन अलग था।
Thank you so much for this enlightening session, sir. I request to capture a photograph. And the dinner will be served in first floor, Hall B, and the further sessions will be resumed tomorrow morning. Thank you so much.